anesthesiologist. This is the second day of first International E-Conference on PAIN 2020. Yesterday, it was fantastic inaugural session, started with very special, inspirational message from our beloved Honorable President, the People's Republic of Bangladesh, MD Abdul Hamid, His Excellency. It was a great honor to be and first International E-Conference on PAIN 2020. Honorable President, His Excellency expressed his realizations for the necessity of the development of pain medicine subspecialty of anesthesia in Bangladesh. WFSL leader, WIP leaders, and other pain societies leaders of many countries joined in that inaugural session. There was subsequent to award ceremony, Lifetime Achievement Award ceremony, and Young Pain Physicians Award ceremony were there in the last day. There was a very special session on FIPP examination, how to become a qualified pain physician, and it was a very fantastic program for the young pain physician of Bangladesh. And Chair of FIPP Board of Examination, Professor Chris Sippy Visars, and EO WIP Mark Tolliver was there. And it was very helpful and informative program for the young pain physicians for getting preparation for the FIPP examination. And it was ended with a fantastic cultural program yesterday. So we are in the second day of the international conference. This is actually the session 3. This session will be moderated by our beloved Dr. MD Mazharul Alam. He is a young pain physician. He has been awarded yesterday with the Young Pain Physician Award. And this session will be chaired by Professor Abdul Rahman Sir, Professor Mainul Hossain, and Professor Debabrata Bonik, and as well as Professor Shaira, U.S. Shaira Khatun Bella Madam. I would like to request Dr. Mazharul Alam to moderate the session. I'm handovering the mic to you, Dr. Mazhar. Are you here?
Yes, sir. Thank you so much, sir.
Okay.
Thank you, our beloved Professor Kausar Sardar, sir, for your tremendous support. Welcome to all in our first International E-Conference on Pain, organized by Bangladesh Society of Anesthesiologists. And this is the day 2, session 3. I'm Dr. Mazharul Alam, working as a pain physician at Bangladesh Korea Mochia Government Hospital and consultant at Mazhar Pain and PRP Center, like to conduct this session. And this session will be chaired by Professor Muhammad Abdul Rahman Sir. He is a very renowned anesthesiologist. He is a past head of the Department of Anesthesia, Analgesia, and Intensive Care Unit Department of Dhaka Medical College Hospital. Now, Sir is working as a professor of anesthesiology at Bangladesh Medical College Hospital. And we have Professor Mainul Hossain, sir, very prominent figure in pain medicine field in Bangladesh. And he's a retired professor of Department of Anesthesia, Analgesia, and Intensive Care Medicine Unit of Bangabandhu Sheikh Mujib Medical University. And Professor Mainul Hossain has started his pain career since 1998. And we have Professor Debabrata Bonik, sir. We are very lucky to get this professor. And he is a very, very well-known face, president of Bangladesh Society of Anesthesiologists. And sir was a past chairman of Department of Anesthesia, Analgesia, and Intensive Care Unit of Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh. And currently he's working as a professor of same department of same university. And he's my teacher, my mentor, my guardian. And he's doing a lot for Bangladesh Society of Anesthesiologists. And he has a lot of contribution, lot of dedication in the pain medicine field in Bangladesh. Thank you, sir, for investing your valuable time. And this session will be enlightened by 6 important speakers from different countries. And every speaker will have 15 minutes time to present their presentation. And at the end of the session, we will have 10 minutes for question answer session. If you have any doubt or any queries, please shoot your question in our chat box. And I would like to request Professor Abdur Rahman sir. First, I would like him to introduce first speaker and allow him to start his presentation. Rahman sir, are you here, sir?
Rahman sir.
Sir, thank you, sir. Thank you for your valuable permission. I would like to introduce first speaker. Our first speaker is Dr. Sarfaraz M. Khan. He's from Saudi Arabia. He's a fellow of interventional pain practice, Miami, USA from 2014, and working as consultant pain management unit, King Fahad Medical City, Riyadh, Saudi Arabia. Dr. Sarfaraz sir, are you here, sir? Can you hear me?
Yeah, I'm here. I hope I'm audible.
Yes, sir. Please start your presentation.
I hope my screen is sharing now. Is my presentation visible?
Yes, sir. We can see your presentation slide. You can proceed, sir.
Actually, I want to thank Bangladesh Society of Anesthesiologists and Professor Kausar Sardar for giving me this opportunity to present in this magnificent conference being held in Dhaka. Although we are missing it personally, but at least we got a chance to present it via Zoom platform. I'm very happy to present on this topic. I'll be talking in the next 15 minutes on this topic, which is pain medicine, a leap in the future. Actually, it's very, very vast topic to bring it in a nutshell. I will try my best to do the same. Thank you. I have nothing to disclose. Actually, want to start by talking about this slide. These two photographs, they somewhat relate to pain practice as well. When Porsche thought long back of something like a concept of flying the cars, they just got real cars, put it on a ramp, and they fix it over there to make it something like a concept that the cars are flying. That was not long ago, but in the last few months, a few European companies and Japanese companies have come up with real flying cars. So something similar has happened in pain management. What was a concept of doing advanced interventions in pain management? We are not far, we are not behind this flying car concept as well. So actually, John Boniga is known as the father of medicine. He once said that for the proper management of pain, it remains, after all, the most important obligation, main objective, and the crowning achievement of every physician. So no wonder that a majority of the patients, when they seek medical advice, pain is the real complaint they have. If there is no pain, they don't have a feeling that any pathology is going on inside at molecular level. So when we talk about pain management, we need to really have, regard these people who have been doing so much hard work to establish pain medicine as a specialty. John Bonica in 1970s, he was an anesthesiologist. He thought of establishing pain as a specialty and was involved in creating ISP. And he designed so many interventions and had his own pain clinic. He wrote so many guidelines, and his book is considered as a reference textbook of pain medicine. In today's world, we still have people who are contributing on a daily basis. There was Professor Raj as well, Prithvi Raj. He did a lot, being an anesthesiologist himself, and writing so many of policies and guidelines and textbooks. We still have Gabar Rags and Manchikanti who are still doing hard work. I just got these people because I actually, few of them I've met them, but there are many more from different specialities, because pain medicine is not limited to anesthesiologists anymore. But the major force of pain clinics all over the world is still being taken care of anesthesiologists, and they still are doing around 60% of interventions in pain management all over the world, along with their anesthesia practice as well. So the journey of pain physicians as anesthesiologists started long back. Anesthesiologists were involved in taking care of pain during surgery initially, and there were limited options in the 1600s when they had to use extracts of opium as the only painkiller. Till date, opium is still very important for our pain medicine as well. In the 19th century, with modern chemistry, chemicals like chloroform and ether, they were getting popular, and operating rooms had these medications for putting patients to sleep and killing their pain. In the 20th century, with the invention of hypodermic needle, injectables came into practice, and till date we are still using morphine and other medications in the injectable forms, and they continue to be very promising in our practice as well. When we talk about pharmacotherapy, the pain clinics were initially started to use pills in the form of tablets and capsules, and recently they've been very popular transdermal delivery system, which is also known as patches, and there are at least 10 to 15 different type of patches all over the world where people use them. And also there are inhalation forms and sublingual forms sprays still available for pain physicians to be prescribed. So we as pain physicians, we have taken the burden of musculoskeletal disease all over the world. At present, it's ranked 4th in the global burden of illnesses after cardiovascular disease, cancer, and mental illness. More than 50% of US population, they attend pain clinics. And directly or indirectly, it affects American economy to around $950 billion a year. And this is going on exponentially high now. In last 20 years, it has multiplied, and it's like 45% more than what it was 20 years back. This is due to the number of pain physicians adding to the market, plus the awareness the people have, and the recognition of the pain physicians and their role in the community. Majority of the patients still in the pain clinics are with low back pain, neck pain, and joint pain. And when we see the patients in the pain clinic, as a pain physician, I'm looking at what kind of interventions I can do so that I have, as a pain physician, there can be some benefit in the lifestyle of the patient. So initially we were just related to doing only diagnostic kind of blocks, and we were trying to delineate the origin of pain, and we were trying to exclude anatomical pain generators. We were supporting spine surgeons and orthopedicians who were majoritarily doing the pain practice, although it's part of their practice. But before the pain physicians were really recognized, these were the people who were taking the real burden of this musculoskeletal disease. Although with this kind of steroid injections, we just get short-term relief, but we were at least getting some guidance to appropriate treatment, and this was preventing them from getting inappropriate treatment. Lately, therapeutic options have started to be available to pain physicians, and these are giving patients long-term relief. And we were trying to know what targets are really the pain generators. This is helping patients to get fitness. And now with the availability of regenerative medicine, we are targeting aging and degeneration, and we are looking at how to regenerate degenerated tissue. So our role is really shifting, but we are very happy to be part of the shift. We were initially taught as pain relievers because of anesthesia background, Then we went into diagnostics, where we were helping the primary specialties in getting patients on board with the proper diagnosis. For example, a pain physician is helping a spine surgeon to diagnose whether a facet is the real pain generator or the disc or the nerve root, so that he can go ahead with the surgery. Then we thought that we are becoming healers because we have different medications and steroids where we are injecting in different tears and inflammatory tissue. And now our role has gained further, and we have incorporated regenerative medicine into our practice. So we are now being called as regenerative therapist as well. So I'd like to just bring into a nutshell of our pain practice by presenting two cases. The first case is about low back pain, and the second case is about knee pain. I know we have a very extensive conference, and the next one, next 2 days, people will be talking about these two topics, but I'm just trying to bring in nutshell what was the practice and how we have gone so far in another 2-3 slides. So a 55-year-old male patient is seeking advice at a pain clinic with low back pain, which goes down to bilateral lower limbs in L5 dermatomal pattern. On MRI, patient has annular tear of the L4-5 disc and a facet synovial cyst at L5S1. The patient is given oral pharmacotherapy and physiotherapy by the spine surgeon and sent to pain clinic. So as a pain physician in the olden days, I just had an option of epidural steroid injection or a facet joint block. If at all, if I have an interventional radiologist and a CT suite as a luxury, can go ahead and do a synovial cyst rupture under CT guidance. But people lately have started to do advanced things like doing provocative discography to really know which disc is the one with the tear or the one above or one below. This is diagnosed by provocative discography. Lately, people have also started to do bioculoplasty, which is actually burning the nerves of the disc by radiofrequency ablation. Hydrodiscectomy has also added into the armory of pain physicians, where jet-propelled saline is used to excise the disc and help patient relief from low back pain. So as I said, provocative discography is a diagnostic tool for discogenic pain, where contrast is injected under pressure, pressure is recorded, and then we observe for the leakage of the contrast, and also by mimicking the same pain by increasing the pressure in the nucleus. Bioculoplasty, as I said, is burning the nerves of the disc by using radiofrequency ablation, and this has gained a lot of acceptance with the patients. We also do hydrodiscectomy, where we use jet-propelled saline to cut to get the fragments of the disc, and this prevents the scar in the back. So it's a very minimally invasive procedure, which but through a needle, and it's in no time patient is ready to go home and get street fit. Epiduroscopy not done at many centers. If the patient gets surgery anyway and get persistent low back pain, 30% of the patients, even after spine surgery, they land up in pain clinic with persistent low back pain, which is also known as failed back surgery syndrome, where you can use epiduroscopy to have real visualization of epidural adhesions and dura and the foramen. You can even do adhesiolysis or under vision RAX procedure, and also you can do some kind of decompression. If everything fails and patient is going on higher doses of opioids, pain physicians have the option of this marvelous technology of spinal cord stimulation, where you thread the leads through epidural space above the dorsal columns, and with a pulse generator or a battery, patient gets the luxury of using remote control, and whenever patient feels pain, can stimulate and get pain relief with his or her own endogenous opioids. This marvelous technology has more than 50% of success rate. So my second case is to show in nutshell about pain practice is about knee pain. After low back pain, the majority of the patients coming to our pain clinic in this part of the world are knee pain. And it's good to see that orthopedicians have realized the pain practice as a cornerstone of knee pain or joint pain. And that's the reason we got flooded with so many referrals. Mind you, all over the world, there is a very, very long waiting list for total knee arthroplasties. And these patients have no other option other than to eat kilos and kilos of non-steroidal or NSAIDs. So they just send the patient to us, and believe me, pain clinics all over the world are doing great job to relieve knee pain for patients who are either not the candidates for surgery or patients are waiting on a waiting list. So this is a 65-year-old patient with bilateral knee pain, ischemic heart disease, on anticoagulants, diabetes, known case of diabetes, and hypertension, and was decided as not a candidate for surgery. With the orthopedician, was sent to pain clinic. This patient is asking me solutions. I remember before 6 to 8 years when I was in the clinic, I would just say, we are not solution providers. We are only pain relievers. We can just relieve your pain. The solutions lies with the surgeon. But now I'm very happy to say to the patient that if it's a stage 1 or stage 2 osteoarthritis, I can give you solutions in the form of regenerative therapy, which can reverse the degeneration or at least delay the surgery for another few years. So if a patient is young, around in 50s, I definitely have solutions for this kind of patients, and I'm really feeling happy to be part of this part of this cycle. So the initial injections we were doing were only steroid injections and sending patients back. Then Highline came into our practice, but now we have options of prolotherapy. Prolotherapy was there in the 90s as well, but it has recently gained a lot of popularity and acceptance, and platelet-rich plasma, and there is a big spectrum of regenerative therapy, which I will show you in the later slides. We are doing a lot of knee geniculars, radiofrequency, where we are targeting the nerves for the patients who are not candidates for surgery. So we just make the joint senseless. Before there were 3 nerves targeted, then came 4 nerves. Now in the latest literature, evidence-based literature, 5 nerves are being targeted. So where we just ablate through radiofrequency, and these nerves take around 3 years, if not less, if not more, in regeneration, and patient can avoid NSAIDs and other painkillers through oral route. We do a lot of intra-articular injections as well. This includes shoulder injections, hip and knee, and as I showed you, that spectrum of different medications includes the steroids, and regenerative therapy has added recently. So because we are talking about pain medicine, where this was the real leap for us as well, that regenerative therapy has come to our help. In the 90s, people were using different forms of dilution of dextrose, different concentrations of dextrose in diluted form, 15%, 25%, and this was very promising. Platelet-rich plasma has been recently accepted by all pain clinics, and there is a lot of awareness, and patients are demanding this kind of therapies because they know from their near relative or distant relative who has undergone this therapy. It was really, really promising. Stem cells have recently gained a lot of acceptance, although it's really a little bit costly therapy, but it's really getting popularity as well. Exosomes is the latest one in the pack, and I will talk about it in the next slide. So as I said, platelet-rich plasma is evidence-based, and a lot of people get injections of platelet-rich plasma for tennis elbows, and osteoarthritis is high-quality evidence. There is also moderate to high-quality evidence for patellar tendinopathy and plantar fasciitis. There are not much studies for rotator cuff, but people do a lot of PRPs for rotator cuff tears, and for post-surgery or non-union, there is no efficacy or it's not proven. So you can get stem cells on a bedside, and many pain clinics, they are equipped to get this. And there are a lot of kits, and technology have been very helpful to us. We can do stem cell harvest through bone marrow or through adipose tissue by liposuction. These are very easy techniques, and the kits are customized for this bedside use or office use. Also, there are a lot of banks now which are storing umbilical cord blood for stem cell, saving the stem cells to be used in later life. So I was talking about exosomes. Exosomes, these are secretions of the stem cells. So basically, when you put stem cells, they work through, they communicate with the target cell or a degenerated cell, or order this cell to grow back, or this kind of cell communication is through exosomes. So we have now purified exosomes as well. A step back was doing stem cells and let it work through exosomes. Now they have isolated. The technology have been so fast that exosomes are available now in commercial form for injection. And it can be given nasally, it can be given intradiscally, and neuroaxial, intraarticular. These are very small, nano-sized membrane, 40 to 120 nanometers in diameter, and they help in growth through multiple growth factors. So when I'm talking about pain medicine, how we got this leap, I don't want to miss this opportunity. The clinics wouldn't be where we are because without the radiological guidance. So initially in 60s and 70s, people used to practice pain. There were not much technology available. People were using surface landmark or blind methods. And it was really challenging for these guys because they were using all their clinical acumen and trying to do something good for the patient. I don't know how much was the success rate, but they did a marvelous job. X-rays came into practice in 1970s and 80s, but the equipment was bulky and we need to have a luxury of a radiologist to allow you to go to his suite and do a procedure. Then came CT scans and MRIs. They were more helping in diagnosis. Few of the pain physicians were having the luxury to do CT guided procedures, but really patient selection was really a criteria to see that which patients can go to CT suite being a luxury. Image guided procedures have been the mainstay of pain practice from 1980s, and we are going on getting modernized day by day. At present, ultrasound and sorry, I forget to say about C-arm. C-arm was the real cornerstone of pain practice. And I'm sure this is one of the very much, I mean, like a lifeline of a pain clinic, that with a C-arm, you can do majority of the procedures. But if the patient is pregnant or patient is, I mean, you want to avoid radiation and see real-time guidance, ultrasound has come to us, to our, to save us, to our help. And we also have now portable probes where you can customize with handheld devices and mobile phones. So we are going really faster. So at interventional pain management, I feel that this is the only option.
Sorry to interrupt, sir. Sorry, if you can do it a bit faster because time.
I have 2 slides. Only 2 slides remain. So I have only the only option left for patients who are not fit for surgery. I thought that we are part of bridging therapy if patients are waiting on the list. And if patients are seeking advice directly because of the awareness, we have a chance that we can just start directly interventional pain management and give all the options what we have on the table. Regenerative medicine is the new entity in the neighborhood, but we have to be really selective with our patients and never forget that rehabilitation people have a vital role for return of function. To summarize, we at Pain Medicine, we are into the fastest evolving specialty, and we are the cornerstone of managing illnesses. We have our own role, and people have started to recognize us, and advanced techniques are getting added day by day. Preventive medicine and anti-aging therapies are gaining acceptance in pain clinic. And I want to end by telling that pain is inevitable, but suffering is optional. And a good pain physician will work on this part to reduce the suffering and bring smile to the patient's face. Thank you.
Thank you, sir. Thank you for your elaborated presentation. We have very limited time, already 15 minutes behind from scheduled time. I would like to request our second speaker, and I would like to request our Professor Manoj Hussain sir to introduce the second speaker and allow to start his presentation very quick. Please unmute yourself, sir. Manoj Hussain sir, please unmute yourself.
Hello. Hello.
Yes, sir.
Yes.
We can hear you.
Can you hear me? Our
Yes,
speaker, welcome to our presentations, is Ashish Chakraborty. He's working in the 2 hospital as far as his bio, and he's working in the field of pain medicine. And one is at the IPSC at Dwarka, New Delhi. And second is he's working in the Artemis Hospital of Gurgaon. May I request Dr. Ashish Chakraborty to present his presentation, please.
Thank you, Dr. Moinul. It's really a great honor to associate with you people for this international conference, and which has already kicked off in a very esteemed way. So my topic for the presentation is interventions for cervicogenic headache. So these are the current evidences which I have, and going on straight to the topic. So just an introductory remark that this cervicogenic headache is nothing but a secondary headache that has a pain generator in the upper cervical spine. And the most common pain generators of these are the C2, C3 facet joint, which are the culprit in approximately 70% of the cases. Also contributory are the atlantoaxial joints and the ligaments and muscles of the neck. The more uncommon, the ones which are uncommon culprits are the atlanto-occipital joints, the C2, C3 intervertebral disc, and the C3, C4 facet joints. Actually, if I had adequate time enough, I would have liked to detail you on this, the theory of trigeminal-cervical convergence and the theory of trigeminal-occipital convergence, which explains to you regarding the logic behind why things present the way they are, and why the interventions are on the neck actually help the patient to deal with the pain in the head which they are having. Many number of times the patient do ask, if I have pain in the head, why are you poking a needle in my neck? So, but that's the explanation that you have in your mind. Okay, and so these are the common interventions which we are doing. That is dry needling, Botox, the different types of blocks on the greater occipital or the third occipital nerve, the facet innervations, and very many, which I am very sure an advanced interventionist must be doing day in and day out in his clinic. But then where is the evidence? How do you gather the literature or the evidence for whatever you have, whatever you are doing? Basically, if you are well aware with the mechanism of pain that is being generated, you definitely have a reason to do that. But then without an evidence, it becomes a little risky for you, as well as you don't have a sound footage over which you are performing the procedure. So these lacunae still exist in the context of cervicogenic headaches, mainly because there are a lot of guidelines which are lacking. We don't have adequate amount of guidelines in the existing knowledge of management of cervicogenic headache. And even if there are guidelines, there is no consensus amongst the guidelines. So suppose some guidelines say that it has got a strong recommendation, other guidelines say that it has got a moderate recommendation. So what I have done here is I have tried to bring out some moderate to high quality studies here, which are known as landmark studies in the context of cervicogenic headaches. So what in my practice, what I have done, what I do is I make my algorithm or my protocol based upon these landmark studies and practice. So in the subsequent slides, I am just going to go through these landmark studies and give you a reason to make your own protocol and start whatever you are doing. So coming on to the basic management that we do, that is the dry needling. So I have a paper from 2017, and it is based upon the dry needling of the suboccipital and the trapezius muscles in the patients of cervicogenic headache. Now, what they did was they did two types of needling. One was a superficial dry needling, and then there was deep dry needling. That means the dry needling involving the muscles and the suboccipital and the upper trapezius muscles. So in this, they had approximately around 30 patients, and what finding they obtained was that deep dry needling was much better compared to the superficial dry needling in terms of the range of motion and the functional rating scale. So they found significant difference between the deep dry needling and superficial. So their recommendation was definitely to go ahead with the deep dry needling rather than superficial dry needling. And there was yet again previous article in cephalgia. So if you guys know, cephalgia is considered as the journal of choice for the interventionist, for the neurologist regarding headaches. So whichever neurologist you ask who's who's doing headaches, they will swear by cephalgia. So in 2014, there was this nice systematic review involving a system database search from 10 databases. And in these 10 databases, they found 3 relevant studies concerning the cervicogenic headache. So, and the conclusion that was drawn from this systemic review was that there is insufficient evidence to strongly advocate for the use of dry needling. Okay, but then what they said was it could be a useful addition in addition to the conventional physiotherapy. So it contrary to the previous study which I have shown you, they are saying that dry needling could be a procedure of choice, but then you cannot replace it from conventional physiotherapy. You have to add on dry needling with your conventional physiotherapy or the next spinal exercises. Next, spinal manipulation. What about Botox? Now, Botox is fast becoming a very in thing when you are dealing with the cervicogenic headache. But what is the current evidence? What is the latest evidence we say? Whether does it favor Botox or does it not? So we have a study in from Norway in 2000, which was conducted in 2011, and then it was basically a randomized blind double-blind, but it was a crossover study. Crossover study means that 28 patients who underwent Botox therapy, they formed their own control. That means if the patient had Botox first, after 8 weeks, they got an injection of normal saline. Or if the patient got a normal saline first, they got, after 8 weeks, they got an injection of Botox. So that is the way it was crossed over. And then these patients were reviewed for further 8 weeks. So within those 8 weeks, within the minimum interval between the first injection and the second injection was kept at 8 weeks. And the patient said that he has got sufficient amount of pain relief, the interval was extended. Okay. So what were the parameters checked? The parameters checked were pain scores, the neck mobility, and the quality of life. And what they observed was there was not much difference in the side effects. There was no, rather very minor, no side effects at all. So when they compared the parameters, they found there was no significant difference between any of these parameters. So what they concluded was normal saline is as good as Botox. That means there is no significant advantage of using Botox over normal saline. What about the occipital nerve blocks that we perform regularly? So the greater occipital nerve block is the most common thing that we do, what we perform. And so this is a landmark study. This was conducted in 2006 by Naja et al. Anybody who is dealing with greater occipital nerve block would be aware of this paper. There is no doubt about it. So what they found was, what they basically did was they divided the patient into 4 groups. So in one group, they did the greater occipital and the lesser occipital nerve block with this LBFC. So that is lignocaine, sorry. So that is lignocaine, bupivacaine, fentanyl, and clonidine. So in this limb, they again have greater occipital plus lesser occipital, or GON, LON plus facial block. And in the other group, the LBFC cocktail was replaced by normal saline. Okay. To improve the accuracy, what they did was they performed the procedure with nerve stimulator assistance, and they followed up the patient after 2 weeks of injection. So what they found was the block group, that means the LBFC group. In the LBFC group, they found that there was significant reduction in analgesic consumption. There was significant reduction in the VAS and the total pain index. The frequency of headaches had reduced a lot, and along with that, there was a reduction in accompanying symptoms, that is of nausea, vomiting, photophobia, or phonophobia. So they concluded that using accurately guided technique with lignocaine or bupivacaine, that goes in a long way to help the patient with cervicogenic headaches. So if you notice here that this was 2 weeks, they followed up the patient for 2 weeks. So encouraged by this study, what they did was they extended the study to 6 months. Okay. So what their technique was that they observed the patient for around 6 more months, and they saw whether they observed whether they need additional injection. So what they observed was that 45 patients, 45 out of the 47 adults, they saw that 45 patients achieved 6 months pain relief. But then out of 45, there were 40 patients who required more than one injection. So there was a basic need for at least one basic injection. Plus, they also observed that for every 3 years, let us say the patient said that I am having this pain for around 3 years. So they noticed that they needed one basic injection plus one more injection for 6 months. If they said pain duration was for 6 years, so one basic injection and 2 more injections. So that is how they saw that with this regime, they could achieve a 6 months of pain relief for such patients. They also noticed that there was a time the time interval between 2 subsequent injections that increased according to the number of repeated injections. Like for example, the after one basic injection, he needed one injection for after X months. So they noticed that the subsequent injection that was much more than X months. So and that is how the time interval that increased in between the injections. What is the better site for greater occipital nerve block? As you very well know that in our OPD settings, we always tend to perform it at the greater occipital, at the level of the greater occipital protuberance here. Then there is yet another place where we can block the greater occipital nerve, that is in between the SSC and the IOC here. Okay. Now this approach can be taken, that is what is known as subcompartmental approach. So subcompartmental approach can be taken either fluoroscopically guided, or it can be done by ultrasound guidance. Okay. Now what they observed was whenever you do a GON block by subcompartmental technique, they saw that with classical technique, that is the blind technique, the beneficial effects was for 2 weeks. But with the subcompartmental technique, it was extended for around 6 months. Okay, so definitely the subcompartmental technique is the better side for doing a GON block. What about the third occipital nerve block? So I have got a study here which is from New Zealand, and it was done in 2012. So they did this study on 104 patients, and these were done by 2 practitioners who received rigorous training before the beginning of this study. So the successful outcome in their case was defined as at least 80% of pain relief lasting for at least six months. In their study, the practitioner A, he had around 74% of result, whereas practitioner B had 61% of successful outcome. And they saw that the relief lasted for approximately around 1.5 years. Okay. And after 1.5 years, whenever the patient came to their clinic, they gave another shot. And then they saw that it is lasting for around 1.25 years. So that was yet a boost for them to continue the injections, continue the repeated injections. And every time they would give a shot, they would see that it extended by another 15 months. So that was one good report from New Zealand. And there was yet another report from in 2016. The number of studies here, it was a systematic review, and the number of studies taken here was 8. Okay, so the important thing about the systematic review was they saw the NNT, that is numbers needed to treat, and they saw that for achieving good relief, the number needed to treat was 2. That means, let us say that you have done around 10 procedures, and in those 10 procedures you are having some three good results out of 10. So in this case, you need to relook at your technique, because if your technique was nice, you should have, or flawless, you should have at least a success rate of around 5 patients in 10 patients. So that is what is the conclusion from this study, that the numbers needed to treat was 2, and you should have at least that much of response before saying that whether this procedure you're doing it in a correct way or not. But then there are various reports about failures after doing a proper radiofrequency ablation of third occipital nerve as well. So what is the basis behind this? There was this study undertaken in 2016, and this was done on 5 cadavers. So 5 cadavers, 2 third occipital nerves, that means around 10 occipital third occipital nerves were there. So there were 2 groups. In one group, they used 0.3 ml of methylene blue, and in another group, they used 0.5 ml of methylene blue. So what they observed was, in 0.3 ml methylene blue group, the spread to greater occipital nerve from the third occipital nerve, that was around in 60% of the times. But if you are using 0.5 ml, you would see that the greater occipital nerve is based around 100% of the time. So it is a very common thing that when you are doing an injection for third occipital nerve, you will give a volume of around 5.5 ml or more than that. So in that case, what happens is that greater occipital nerves also get covered. But then when you are doing the RF, that time you are only targeting the third occipital nerve. You're not doing anything about the greater occipital. So that escapes. And in the post-operative period, the patient has recurrence. So subsequently, you have to do a greater occipital nerve RF as well. Okay. Now, what about cervical facet joints? We were dealing with the C2, C3, that is the third occipital nerve. But then they also went on to do went on to see whether the other cervical facet joints, treating other cervical facet joints also helps. So in this study, they saw that the though the side effects were minor, the effect was also minor. That means they saw the effect was not more than 3 months. After 3 months, they did not see too much of an effect. So this was done. You can say that it was done, which was way back in 2004. But then, yet again, there was this systematic review which was done in 2015, and this was again a systematic review. So it was again a systematic review, and it was according to Cochrane score, it was a good grade systematic review. Okay, and in that, what was the conclusion? In that. They had 4 randomized controlled trials, and there were 4 non-randomized controlled trials. Okay. The results, the 4 randomized control trial, of that 2 were high quality, and the other 2 were moderate quality. 3 techniques were related to the conventional radiofrequency, and one was related to the pulse radiofrequency. And of those studies, they finally arrived at a conclusion that there is no strong evidence for the procedure to be effective. That is the radiofrequency of the cervical facet joints. I'm not talking about the third occipital now. I'm talking about the cervical facet joints. But in the non-randomized controlled trial, that means which were the trials which were of moderate quality. All of these were of moderate quality. The previous one, at least 2 were of high quality. So because these were of moderate quality, and in this, the outcome was effective. However, we cannot rely on the non-randomized trials which are of moderate quality. So the recommendation from this systematic review was that there is limited evidence for conventional radiofrequency or pulse radiofrequency of the facet joints for the cervicogenic headache, and there is need for high quality RCTs, or if non-RCTs are done, then it should be a multicentric, and it should be without methodological flaws. So, and before you go over to do a cervical facet joint RF, you need to confirm regarding the pain generator with by doing a blocks first, diagnostic block first. What about the atlanto-occipital and the atlanto-axial joints? So Dreyfus et al., they in 1994, they did a study to locate the pain patterns of the atlanto-axial and the atlanto-occipital joint. So what they saw was, if you are distending the atlanto-occipital joint, you will have a wide range of, there will be a lot of variation. So this is a total extent in 5 subjects that they have studied. Some patients, their pain was of this map. It was restricted to the temple area. Some people had shorter amount of occiput and the subocciput. So that was the whole range. But in atlantoaxial, the patient had been confined to the suboccipital area, suboccipital area here. And to add on to that, Norozi et al. In 2007, they did a steroid injection, the study on steroid injection into the atlantoaxial joint. What they saw was, and it was a good study because it had got around 32 patients, and they saw that more than 50% of the patients, they are having good relief. Okay, and the pain scores and pre-procedure and the post-procedure pain scores, it had improved a lot. But then the duration of relief, as you would see, that it was in 3 months. At 6 months, again, the p-value was not very significant. So they concluded that the intra-articular steroid injection into the atlantoaxial joint will provide a short-term pain relief, not a long-term pain relief. So what do you do for that? What do you do to extend that? So you can do a intra-articular radiofrequency, but unfortunately, we don't have any papers on intra-articular radiofrequency. I mean, any studies. There have been case reports, individual case reports, but we don't have any high quality, even moderate quality studies are not there for doing intra-articular radiofrequency ablations. What about cervical epidural injections for cervicogenic headache? It is something like doing a carpet bombing. You do not know where is the pain generator, which nerves are, and you simply inject a cervical, steroid inside the epidural space, thinking that something or the other will get affected. But that is not in clinical scenario. That is not. It can help the patient out. It can help the patient out, and that too. I mean, the paper which I have cited here, that has, if you go through this paper, you will see that the pain relief was only for 4 weeks. So what is the patient going to do after that? So so my personal choice will not for using cervical epidural injection will be something which would be a desperate measure just to relieve the patient of the pain. Same thing was done by Ming Wei in China, and it was with a difference. Okay, and some people, they cite, while just for the argument's sake, some people cite this reference that see, I had gone through a Chinese paper and they said that the relief they have is for 6 months. But just see the difference in the design. What these people did was they put using a steel wire, they inserted the epidural catheter into the anterior epidural space, and they sent it upstairs in the C1, C2 around cervicomedullary junction. For 1 month, they kept on giving this infusion continuously. So this infusion consisted of lignocaine, it consisted of dexamethasone at the rate of 5 ml per hour, continuous infusion for one month. And every week they would call these patients to their clinic and they will give a shot of triamcinolone. So they were receiving loads and loads of steroids. And then at the end of this month, the catheter was pulled out and the patient was followed up. So they followed for around 6 months and they saw that the patient is having very good pain relief. But that is not what happens in, I don't think that anybody beyond studies would perform such an intervention. So and even they saw that after 6 months, again, the things came back to square one. So by 12 months, the patients did not have any significant difference in outcomes. So what are you going to do next? You cannot do anything. You cannot explain anything to the patient right now. Okay. Now, what cervical ozone dyscholysis? Some people are very fond of this thing because it is the. Some people say that if discs are perforate, can we do something about it? Okay, let us because we are putting ozone in the lumbar space or we are putting in the cervical disc space, so we can do that for cervicogenic headache as well. So I did not find any paper or any good study which says which describes cervical ozone dyscholysis of C2, C3 disc. Please note, because here even this study it is highlighting on the results of cervical ozone dyscholysis for neck pain, not for headache. Okay, so it was a good study, no doubt. There were 44 patients and they observed the patient for 6 weeks. 2 weeks, 6 weeks, and 6 months. And they found that the VAS score were different and significantly reduced. But then that was for neck pain, not for C2, C3 disc, which is a cause for cervicogenic headache. Similarly, I don't have any paper.
Ashish,
yeah, I'm going to wrap up. In a way.
Okay.
So there was this there was no good reports, good papers on cervical intradiscal RF. What about neurostimulation? Very in thing now. So everybody would be asking, if I don't mention this, people are going to ask me about this question. So this was done in 2017. It was a 3-year retrospective study, and they found that, and there were 16 patients taken into consideration who were having pain for around 15 years. Okay, and what they saw that after 1 year of placing the doing the neurostimulation, they had around 69 responders. Okay, they had 69 responders. But then at 3 years, only there were 6 responders. But good thing was, at 3 years, there were 5 patients who were amongst those 69 responders, and there was 1 patient who had not responded to at the end of 1 year. So the conclusion was the procedure is definitely safe and effective, but then just because they had less number of responders at 3 years, they said that further studies are warranted. Okay. We all also know that in addition to occipital nerve stimulation, we can place the epidural.
To maintain time.
I'm just wrapping up in 1 minute. So we can also do a cervical stimulation, but then it was found that cervical stimulation is not a better choice when compared to the occipital nerve stimulation. So this is a protocol which I follow according to the studies which I have shown you just now. I would have loved to elaborate on this protocol, but then because we are lacking time, we will just wrap it up.
Thank you very much.
Thanks a lot. Thank you.
It is actually over. We're sorry.
Thanks a lot.
Thank you, Dr. Ashish, for your excellent and evidence-based presentation. And next, I would like to request our BSF President, Professor Bonik sir, please introduce third speaker, Dr. Shantanu Mollik. Before that, I would like to request to every speaker to mention your presentation time, please. Sir, Bonik sir, please.
Now, our next speaker is Shantanu Mollik.
Yes, sir.
From India.
Yes, sir. Yes, sir. Yes, sir.
It is a very important topic since cervical epidural. I think it's a very interesting topic. Please, Shantanu.
With your permission, I would like to introduce Dr. Shantanu Mollik. He is a
introduce.
He did his FIPP in 2011, and he's a pain physician and anatomist, Fortis Hospital, Navi, Mumbai. Associate Professor, MGM Medical College, Navi, Mumbai. Please continue, Dr. Shantanu.
Okay, am I audible?
Yes, sir. You're audible. You can
proceed.
You
see the presentation?
Yes, sir. We can see your presentation.
Yeah. Can you see the presentation now?
Yeah.
Okay.
Go ahead, sir.
Okay. Good evening, everybody. First of all, I would like to thank Bangladesh Society of Anesthesiologists to organize such a huge gathering of the leading pain physicians from different parts of the world, even in this unusual pandemic situation. And also, I'm highly thankful to be a part of this conference. And my special thanks to Dr. Kausar for this leading role of this conference. So cervical epidural anesthesia in present-day anesthesia practice is very much limited. It was first reported by Dr. Dogliotti in 1933, and the use of the cervical epidural anesthesia was much more prominent before the technical advancement of inhalation anesthetics, IV anesthetics, regional anesthesia was made safer and easier to use. I feel cervical epidural anesthesia is one of the most complicated and the risky procedure in anesthesia and pain practice. But if you see, lots of surgeries have been done, like carotid surgery, artery surgery. Yeah, am I audible? No. Carotid artery surgeries, thyroid surgeries, breast surgeries, upper limb surgeries, even head neck, other head neck surgeries. Even a recent report demonstrated that increased cancer-free survival in laryngeal and hypopharyngeal cancer surgeries when the combined cervical epidural anesthesia was used, but subsequent controlled trial also have shown negative results with positive with the prostate and the colon surgeries. But the complications, which are very well known in the cervical epidural, we know this: the dural puncture, the respiratory difficulties, even to complete paralysis because the phrenic nerve is there that can get blocked, serious hemodynamic and cardiac complications, neurological complications like spinal cord injury, epidural hematoma, infection. But there was no death reported. However, significant long-term morbidity and cardiac arrest were reported. It is seen that number of literatures have been published before the year 2000, but after that, publications on cervical epidural anesthesia has been tremendously reduced. I feel I have some personal thinking also. I have different causes are there. Limited practice in teaching institutes, rarely it is taught in anesthesia residency, rarely fluoroscopy is used in anesthesia practice for giving epidural spinal, because many times huge obese patients and vertebral column deformity, they are having some problems, but if they use the fluoroscopy, it will be very helpful. But most of the anesthesiologists, they spend time, is my personal experience, they spend time to learn ventilators, typical intubation gadgets, USDR blocks, but rarely they learn fluoroscopy for giving spinal epidural in their practice. And few seniors are still using blind technique, which doesn't permit to teach and describe the procedure in a proper way. And the blind technique, what we know, the false positive is almost 53% there. And the ligamentum flavum, which is considerably thin in compared to the thoracic and the lumbar this space, and the epidural space is quite thin, or very, very less, almost more than, not more than 2 to 3 millimeter, even at the C71. If you're giving at higher level, C4, 5, 6, or C7, so then it is more or less. And dreadful complications happen in the spinal cord injury, epidural hematoma, and they are the most common reasons for the claims. Maybe because of this, it practices very less, but that's why the board and the standard committee of the International Spine Commission Society, they have declared that cervical interlaminar epidural injection should only be performed under image guidance. Some people may say image guidance doesn't absolutely protect the patient from complication, but it reduces the risk by providing a third-party verification of various stages of the procedure in objective and quantifiable terms. When we talk about cervical epidural, we can think of cervical interlaminar epidural as well as cervical transforaminal epidural, like what we see in the thoracic level, lumbar level. But because of this tremendous complications of this injury to the vertebral artery, cervical transforaminal epidural is totally stopped. We'll only restrict to the cervical interlaminar epidural. So, so if you see, these are the indications of the cervical epidural nowadays, because currently cervical epidural are predominantly performed by the intervention pain physicians. From cervical radicular pain due to the disc herniation and the nerve compressions, epidural adhesiolisis for post-laminar syndrome, chronic pain management for other non-cancer pain and cancer pain, then spinal cord stimulation, and what I personally feel very, very selected cases for anesthesia with proper airway protection, it combines cervical epidural. And the most contemporary part, another important contemporary part, what I used to say, that we don't know when this quarantine situation of this live workshop will be over. That is the most. Am I audible? Am I audible?
Yes, sir. Yes,
okay.
Sir. Yes, sir.
Okay. Okay. Another most contemporary part, why I was telling that we don't know when this quarantine situation of this all live workshops will be over. That's why I restricted myself to discuss about the technical part of this interlaminar cervical technique, so that the young generations can start learning this in their institutes under the guidance of the senior people. Okay. So let's see. When we see the cervical spine, cervical spine is very peculiarity. Yeah. very peculiarity here that the lamina that is almost 45-degree angulated ventrally with the coronal plane. And that's the beauty of this anatomy here. So if somebody is doing cervical epidural in the midline approach, so if you see it is in the midline, it is in the top view and is a lateral view. And this pictures I did personally. I hold the single vertebra and took the X-ray. So this is the lateral view. What you will see, this will be the lateral margin where the silhouette of this lamina, this is the lateral margin. That is the margin. Just crossing this, you will enter into the this epidural space. But if anybody is trying to give epidural just little lateral to this midline, so the needle is lateral to midline, though he is in the lamina, but if you see the lateral view, it is showing that it is already inside the vertebral canal. So that is the scary part in the lateral view. What will misguide the and it will be very scary to the physician who is giving. He may feel I'm already into the spinal cord, I've already punctured, but that is not. So this disparity, the oblique view is the most important thing. So once you do the oblique view, because we know if you see this, the lamina is obliquely placed. So if I am doing almost 40 to 50 degree contralateral oblique, okay. So if your needle placed in the lateral part of the lamina, so now you are 40 to 50 degree, you are rotating the C-arm up to what level? You can see this anatomy. Superiorarticular process and the lamina, they are in the same line, and maximally foramen is open. Now you see this picture. Here, I have taken this separately. So this is actually the lateral view where the lamina is. But when it is obliquely turned 40 to 45 degree, so this is the silhouette of the lamina, and this is the superiorarticular process. Now you see how much foramen is open and how much foramen is open here. Here, foramen you cannot see, very less. But when you are in the particular oblique view up to that limit, you can reach there. So you will see the lamina, silhouette of this lamina and the superiorarticular process, this in the same line, and the foramen will be maximally open. This picture there in the ISIS book. So there, once your needle is placed in a little bit lateral on the lamina, so you will never see this. It is gone already inside. Falsely, it is showing already inside the spinal cord. So that's way you can actually reach the epidural space, even if you are in the lateral to the midline. So that is the most tricky thing that has to be followed if you can safely give the cervical epidural. Let's come to the needle plot. Needle. Different types of needles are used. We know there's 70. Some people they used to favor the blunt needles, thicker needles, 70 to 20 gauge, and some they can favor the 22 to 20 finer needles. But blunt, larger needles are better to feel for the resistance as well as the loss of resistance. So they are less likely to penetrate the dura. They instead to inland. And some people used to think that injecting viscous contrast medium may not be smooth in the finer needles. And those who are after doing lots of lumbar epidural, thoracic epidural, once you are trying to learn the thoracic cervical epidural, so you are already practicing the blunt needles, so they prefer more the blunt needles. But if you are very much experienced in the image guided, so you can use the spinal needles because you are totally depending on the image. And spinal cord injury is more common, even seen in the opposite side that with the larger needles, but the technique was always the blind technique. Okay, so next part is the patient preparation. So always you have to rule out the red flags before performing the cervical epidural. Okay, so particularly contraindications are there, and not the relative contraindications. You can say the canal stenosis, disc herniation, they will reduce the epidural space. So that time you can try 1 or 2 levels below, and you have to be cautious about those patients who are already on the anticoagulants and previous laminectomy patients. In those cases, you should not try at the same target level. You should start at 1 or 2 levels below, so that because the anatomy is already distorted, you can anytime puncture the dura. And regarding the patient positioning, best position is the prone position, or you can do it in lateral decubitus also, because in those cases, in those positions, you can easily see the image properly. But like in blind technique, sitting is not at all recommended for this cervical epidural under image guidance. So regarding the techniques, it should be done. It should not be done above C6, 7, that's 5, 6. but you have to be very, very cautious because space is very reduced. So that to be restricted to C6, 7 or C7, T1. Even some people are doing at T1, T2 because theoretically or legally they are doing at the thoracic level, but they are actually reaching to the cervical through that T1, T2. Primary target, after the squaring, the primary target always should be the upper part of the lamina. Once you are touching the lamina, then you rotate the CM contralaterally 40 to 45 degree. Up to that limit, you will get the maximum widening of the intervertebral foramen, and the lamina and the superior articular process should be longitudinally aligned. And after reaching there, you manipulate the needle and you enter into the epidural space by loss of resistance and simultaneously the oblique view of the, and then you see the contrast. I will come to the contrast part in other slides. So there, now coming to the paramount precautions. So if you have any doubt during the procedure, during the needle, so just stop, don't keep on going ahead. You again try, you go, then you repeatedly check the image in lateral view, oblique view, epi view, then only you go ahead. If the patient reports any questionable symptom, so immediately you stop and recheck. And if after doing that, if you're getting the leakage of the blood or CSF, if you're getting CSF, better to abandon the procedure. And if you're getting anytime sharp sensation, which may trouble to the hand or unusual sensation, most of the time there is a chance of spinal cord injury. You should withdraw the needle and better you should abandon the procedure. Now coming to the different dye spread, which is the most important thing. The first point I should say, always inject contrast medium on continuous fluoroscopy, because many times you are injecting a contrast, then after that you are asking for the fluoroscopy. It should not be done. Whenever you are injecting contrast medium, you should always continuously do the fluoroscopy. Okay, so when the needle is perfectly placed in the epidural, what we'll see here in the epi view, we can see clearly the nerve roots, and the most important thing that this irregular reticular pattern is inhomogeneous presence of the fat globules. You can see here the small white dots, small and medium-sized globe. So that these are the fat globules. They are very important. You can see the nerve roots, dye is going through the foramen, so they are very clearly seen. And lateral view, the dye spread in the linear pattern away from the tip of the needle, anterior to the anterior margins that you can see here. So nicely it is gone up and down. So this is the typical and correct placement of this epidural space. But if it is not correctly placed, first, when the needle is into the multifidus, because multifidus muscles are there, just anterior to the upper border of the lamina is the ligamentum phlebum, and the posterior border is the multifidus. So sometimes when you are getting false positive, so there your needle is into the multifidus, that kind of this contrast spray will get with the direction of the multifidus muscles. And when the needle or catheter is in the epidural vein, when you do, that's why again I'm telling, always inject contrast medium on continuous fluoroscopy. You will see how the venous, through the veins, the dye is passing, and you can confirm with repeated fluoroscopy. And if you have digital subtraction imaging, you can see the better picture. But you, it's
maintain times.
Okay, so another one slide. Okay, so needle can be redirected and to be continued if the dye space is satisfactory. Okay, and if the need injection is in the subdural space, there the epi view, you will see the lat, because here the subdural space means it is in between the arachnoid and the dura. So if you are reducing the pressure, immediately spread will be less. So it will be stopped there, and you will not get the nerve roots, you will not get the epidural fats there. And the oblique view, very interestingly, you will see this bulbous collection of this contrast where the tapering end, because once you have reduced the pressure, so there the space will not open. Okay, so this is the subdural space. If you want, you can aspirate it, and you just redirect the needle, and if you get the satisfactory dye spread, you can continue. Last is the subarachnoid space. Here the dye will spread away from the needle and flows out. Once you reduce the pressure, still you will see the flow is there because it is inside the fluid. It's a CSF. You can get this no root sleeves there, but you will not get no fat globules. In the lateral view, you can see the whole spinal cord, and posterior view will definitely be abundant. So I have finished. I will request the organizer, if possible, just a 2 minutes video is there. It is with the audio video people. It is not possible with the Zoom because I am simultaneously an anatomist. So I will show the cadaveric demonstration of the cervical epidural. It is there. If possible, if you can show this 2 minutes video. So that is there with the audio video people. If you can show it, it will be great help to the new generation people. Thank you.
Thank you, sir. Thank you so much for your excellent presentation.
Yeah.
Mazhar, moderator, Mazhar.
Yes, sir.
We are now more than half an hour behind the time.
Yes,
So
sir,
we can maintain the time.
So this is
yes, sir. Every speaker would like to request to mention.
Major,
his-
Major,
Yes, sir.
you can allow 2 minutes time for Shantanu. This is my request because this is very important part for the young pain physicians. So let's enjoy this part. It's the cadaveric part. This is very important to learn.
Yes, sir.
switch.
Our first motto is to learn something. So
Yeah. Carry on for 2 minutes.
So it is gone inside. Okay. Okay. Now we can see the cord. Okay. Now there is no CSF. That's why so much space we can see. But we can see this is the needle tip. Try to put the catheter.
Yes, fantastic.
Now here I can show you the different routes. You can see here, so this is the brachial plexus. So this is C5, C6, C7, C8, T1. Here you can see the T2. So I have taken out the dura. So now I can see all the sensory roots. Okay, rootlets, I should say sensory rootlets. See, so here, this is the T1. This is C8, C7, 6, 5, 4, 3. Okay, this is the vertebral artery. Here is the C1. So here is the C1, C2 joint. So this is the C1, C2 joint. Okay, so you can see all the sensory rootlets.
excellent video. And I hope Shantanu Malik sir will provide such type of more video for us in future.
Many thanks.
Thank you so much, sir. Our next speaker, Dr. Mohammad Jamil Sabit from Pakistan, with the permission of chairperson. Yes, sir.
Majhar, just I want to interrupt here a little bit.
Yes,
and there is a serious emergency for a Sherry from the Egypt. She fall in a serious emergency. So just a little bit chance, and with my apology to Jamil Sabit and Mehran, just allow Sherry first, then Jamil Sabit, then Mehran. So just allow the Sherry first. Just a little bit change here because of serious emergency in outside. Please.
Okay, sir. Okay. So apology to Jamil Sabit, sir. Please allow Dr. Sherry and Fanas. Sherry, are you here, ma'am?
Yes.
It will loudspeaker.
And she is a consultant of interventional pain management, head of pain management department, St. George Hospital, pain management consultant, at Karma Diabetic Medical Center, Egypt, and founder of Dr. Shri Nabil Fanas Pain Management Clinics. Please proceed, ma'am.
Okay, thank you very much for the invitation. I'd like to thank all the organizers and for such an amazing conference, which has not just 1 or 2 faculty members, but more than 60 faculty members from different backgrounds. So thank you for allowing me to be here. So. My presentation today is about knee pain diagnosis using ultrasound. I'm consultant of interventional pain management, and currently I'm working in Egypt. I have no conflict of interest. So for the knee anatomy, I'll just go for the knee anatomy directly. First, you have to know that there is clinical examination, but I'll skip this part because the lecture itself is very, very large to cover within 15 minutes. So to know your own anatomy, first you have to know your anatomy. For the knee, there is 4 main compartments: anterior knee compartment, medial and lateral and posterior compartment. For the anterior compartment, what I'm looking for? First, I'm looking for the quadriceps. Here is the quadriceps tendon and the patellar tendon, and the hyphus fat pad, which is underneath the patellar tendon. For the effusion, I'm looking for the suprapatellar effusion, which would be appreciated if there is fluid in it. Without fluid in it, you can't really see the bursa, and you won't be able to appreciate it. Another thing in the anterior compartment is the medial plica. Actually, there are 4 medial plicas in the knee joint, but the main one is the medial plica because this is the one in which, when there is an inflammation, this is the one which appears extensively in the ultrasound. So the plica is a connective tissue in the knee joint. Also, we have to look at the trochlea. It has to be nice and smooth, anechoic in the ultrasound. If there is tissue or if there is effusion in it, I would suspect there is an osteoarthritis. Another important thing I'd like to see in the anterior compartment would be the ACL. Here is the ACL. It comes from the femur and to be attached to the tibia. Usually, the patient with the ACL tear would have positive anterior drawer test. So here is how I apply this anatomy on the ultrasound. Here is how I do it for the anterior compartment. First, as you see, this is the quadriceps tendon, and this is the patella, and this is the femur. It's very important to look thoroughly on the quadriceps tendon to see that there is no any tear. It's smooth, lining parallel to the femur. And my probe, as you see here, is longitudinally. Underneath it would be the quadriceps fat pad. It's also very important to use color Doppler to make sure that there is no hyperemia. Hyperemia indicating that there is inflammation in this tendon. And this is a prefemoral fat pad. Here is also the patella and the femur. You have to go up and down on the longitudinal direction. Now I'm going a little bit lateral. I can see the vastus lateralis. As you know, the quadriceps muscle is a four-headed muscle. So on the lateral side, you can see the vastus lateralis. You have to make sure that it's smooth with no tears in it. And go back and forth. Then I'll go back again to the midline. Here is the patella, and here is the very interesting medial plica, as you can see it. it's a whitish hyperechoic line from the patella reaching to the femur, and this is indicating that there is tissue inflammation in the knee joint itself. Here I can see the effusion. As you can see, it's anechoic, and there are tissue and debris here. Very important to measure the effusion. The effusion, it might be at the lower, it might be one hand breadth from the knee joint, or it might be more than this. Measuring your effusion is very important in order to follow up with your patient. Here is the effusion. This effusion was about hand breadth above the patient's knee joint. So tissue debris here is indicating chronicity. So I know that this is not an acute effusion, because acute effusion, for me, it's a ringing bell. Some reports have indicated that leukemia can present with an acute effusion. And actually, I have faced a patient with leukemia, and he was diagnosed from the acute effusion. So by finding the tissue debris, this means that it's a little bit chronic, not acute one. Here is the plica, medial plica, indicating irritation in the knee joint. This is another scan. Here, look at the quadriceps tendon. It's smooth with no irregularities. It looks very good. Here also I can see the suprapatellar bursa filled with fluid and effusion. And here I can find lots of debris parallel. And this would be very difficult if you are going to aspirate this effusion. Your needle might be entangled with this debris because it's actually aligned longitudinally within the bursa. As you can see, it's a very big effusion. Here is another scan with the medial plica, and here you can find calcification. How I knew this is calcification? Because it doesn't allow ultrasound beams to pass underneath. As you can see, there is a gap underneath the calcification. Quadriceps tendon, and this is the effusion. Also to make sure that this is effusion, not anisotropy, because anisotropy is error in the scanning. So, and this is very common in the shoulder joint and knee joint. To make sure that this is not anisotropy, you have to do as I'm doing, you have to be compressing all the time to make sure that it's bouncing. So whenever there is effusion, it would be bouncing effusion. Also, there is tissue debris. It makes me think that this is a chronic patient, not an acute one, not acute effusion, as you can see. I'm compressing all the time, as you can see. I'm compressing, making sure that this is compressible fluid to make sure that this is effusion, not anisotropy. Now I'm going lateral. I have also to assess the effusion on the lateral side. This is the vastus lateralis, and this is the patella. Also, I found here there is effusion. Sometimes the effusion won't be central. Sometimes the effusion would be lateral or medial. So you have to look all the way from lateral to medial. So here I found effusion on the lateral side underneath the vastus lateralis muscle. Then I have to scan in the transverse. This is the rectus femoris, vastus intermedius, and femur. I'm here scanning in the transverse scan. I'm going now lateral. The vastus medialis started to appear, rectus femoris and vastus intermedius. All the time, you have to make sure that there is no tear in the muscles. Here is also the vastus medialis and the femur. Now I'm on the medial side, the vastus medialis. I'm going back to the midline, vastus medialis, rectus femoris, and vastus intermedius. Now I'm going to the lateral side to check the vastus lateralis. So this is the vastus lateralis. It started to appear, and I can see on the my right-hand side, the rectus femoris and the vastus intermedius. Now I'm looking for the genicular nerves. I have to put my probe at the junction between the femoral condyle and the femoral shaft, and I look for pulsations. Here I can find genicular vessels. The genicular nerves is just beside the vessels. So just put your probe between the femoral condyle and the shaft and start looking for pulsations as I have done, and your nerve would be just beside the pulsation. So this is the genicular vessel, and my nerve will be just beside it. Now I'm moving to the longitudinal again. I'm here in the patella. I'm going down. This is the patellar tendon, half-was fat pad, and the femoral condyle. If I'm going up again, this is the quadriceps tendon. So the quadriceps tendon is cephalad and the patellar tendon is caudal. I'm looking at the patellar tendon. It's smooth, running parallel, and with no tear in the tendon itself. Half-was fat pad, I can also use color Doppler to make sure that there is no hyperemia here. And then I would like to look at the ACL. At the end of the patellar tendon, I'd find a line going down, and this would be the ACL. It has to be smooth line running down. Then I'm going to make a transverse view, and here is my trochlea. It's anechoic, surrounded by two hyperechoic lines, and this is the quadriceps tendon. It looks very smooth with no tissues inside it. So now I'm moving to the medial compartment. For the medial compartment, I have to look for the medial collateral ligament from the femur to the tibia. Also, I have to look for the medial meniscus and the pes and stream bursa. For the pes and stream bursa, it's underneath the three very famous tendons, which are the sartorius and then the gracilis. And then you will find muscles which is very posterior. It's not among the complex. It's the semimembranosus. It's not a part of the complex because it's very posterior. But the one who was anterior is the semitendinosus. And then you would find the medial collateral ligament and the pes and stream bursa. Pes and stream bursa, for me, when I find it, it's normally can't be detected when there is no effusion or when there is no inflammation in this complex tendons. But whenever there is inflammation, you will find that this bursa is filled with fluid. And sometimes if you have a high resolution machine, you can really see the tendons, three tendons, very rounded or oval tendons on the medial side of the leg. So this is a scan for the medial compartment. Now I can see there is a huge effusion on the medial compartment. And if you look here, this is the meniscus. There is a tear in this meniscus. This is not a normal meniscus. And the medial collateral ligament is extending very high. The meniscus width has to be 0.65. If it's more than this, it means that there is a tension on the medial collateral ligament. As you see here, this is not a normal medial meniscus. And there is effusion on the medial side, and there is also tissue debris inside this effusion. So now I'm moving to the lateral compartment. For the lateral compartment, I would be looking for the lateral collateral ligament. It lies from the femur to the fibula. I'd also be looking for the lateral meniscus and for the knee effusion. So this is a scan for the lateral compartment. As you can see, this is meniscus. It's not a normal one. It doesn't take the normal V shape. And above it is the lateral collateral ligament. It's very extended, and definitely the width is beyond 0.65. And you will see here effusion. I have to scan up and down, cephalad and caudate. The lateral meniscus is very distinguished with a branch, genicular branch of the popliteal. Usually this is not found in the medial, on the medial meniscus. As you can see here, there is a branch of the popliteal, genicular branch of the popliteal. And this is the iliotibial tract. If I track it up, I'll track it to the fascia iliaca. You can see this wide band. This is the iliotibial tract. I can track it to the fascia iliaca and gluteus maximus. Here it's nice and parallel to each other. So my last compartment would be the posterior compartment. Here I'm looking for the Baker cyst. There is 3 criteria to say or to diagnose a Baker cyst. First, it has to lie between the medial head of the gastrocnemius and the semimembranosus muscle. Second, it has to be a cyst. Third, it has to have a neck. Fourth, it has to be attached to the joint. There are 4 criteria. If one is missing, this is not a Baker cyst. Another thing I'd like to look for the posterior cruciate ligament. This is the gastrocnemius muscle. I removed it, and here is the posterior cruciate ligament. As you can see it. Also, I have to look for the knee effusion. This is a scan for the posterior compartment. This is the gastrocnemius muscle. This is the popliteal artery. It's pulsating, and when I apply color Doppler, and this line is the knee capsule, and this is a knee capsule, and this is ideal to do the IPAC injection between the popliteal and the capsule. So now I'm moving up and down. Here is the knee trochlea, posterior knee trochlea. Here is the popliteal. I'm starting to move up and down. And then on the medial side, I started to find an anechoic appearance. I don't know what is this, so I had to put color Doppler. I put color Doppler, it's not pulsating. So I had to track it. I tracked it, it took me to the medial side of the knee, and it took me to an area between the medial gastrocnemius and the semimembranosus. So it's an anechoic, and it's between the medial gastrocnemius and semimembranosus. There are missing 2 criteria. It has to be a cyst, and it has to have a neck attached to the knee joint. Let's see. I can find that it's a cyst. It has a neck. It's a cyst. It has a neck. I followed this neck. As you can see, it's attached to the knee joint. The neck is attached to the knee joint. Cyst, neck, and it's attached to the knee joint. So this is definitely a Baker cyst. Thank you very much. I hope that I kept my presentation within time.
Thank you, ma'am. Thank you, Dr. Sharif, for your great report. And special thanks to you, as you have finished your presentation within given time. Thank you so much.
Thank you.
And this is the time. And this is the time for Muhammad Jamil Sabit from Pakistan. With the permission of our chairperson, I would like to introduce him. And he's holding MBBS, DMSc, and FIPP. And he's a director pain management services, Al-Raji Healthcare Lahore. And he is the first Pakistani pain physician appointed as a FIPP instructor and examiner by the World Institute of Pain. Sir, please proceed your presentation. We have a very
Assalamu alaikum. Can you hear me?
Yes, sir.
Hello?
Yes, sir. We can hear you. Please proceed.
Okay. Okay, it's okay. Thank you. Actually, I'm in a very remote part of my country for my monthly pain clinic, free pain clinic. So maybe we have problem with the internet here. So anyhow, I will try to be concise and stay to the topic. And initially, I am thankful to Professor Kausar and his team. I congratulate them for such a nice mega event being held in this difficult time. They really deserve and good applause. These are the few pictures showing my contacts and my mentors here from whom I learned all these, and especially the Professor Gabor Rags, James Evener, and Rock and Iris, and so many more. And it was wonderful time being with them as a trainee. So this is Professor Ganchoi, from where I learned my endoscopic spine procedures. So before I start my presentation, I want to discuss few cases here just to show the importance of this epidural adhesiolysis with the RAGS procedure. You can see here, this patient had left-sided L4, L5, S1 radiculopathy. And when we did the epidurogram, there was no dye going in those nerve roots because of the adhesions and fibrosis. So if we give a simple epidural injection there, blind or under fluoroscope, maybe we won't be able to solve his problem. So this is the RAS catheter in the left L5 foramen, and we do the adhesiolysis in lateral picture showing that it is anterolateral, and you can see gradually it is opening up all the stenosed left-sided L4, L5 and S1 foramen, and at the end of the procedure, the Christmas tree is very much evident, which is actually our desired picture, showing nice anterolateral opening of the epidural fibrosed areas. So same can happen in the cervical area because of the failure of simple epidurals, blind or under fluoroscope guided, is that most of the time, due to the fibrosis, we cannot reach the desired levels of foramen where we want to decompress those roots or adhesions. So here you can see most of the dye was down there, and then we started giving, then we guided in the catheter and we reached, and you can see on the left side, we have nicely opened all the closed foramen. And same way on, we can go to the other side also and open the desired right-sided foramen also. So you can see the foramen on both sides are nicely open. And by putting the catheter inside, when we do neural flossing exercises like flexion extension of the neck, you can very nicely open the foramen. Chances are relatively high that each of us will experience low back pain at some point in our lives. The usual course is rapid improvement, but 5 to 10% developing persistent symptoms. Treatment typically begins with conservative measures such as medication, physical therapy, and may even include minimally and highly invasive pain management interventions. Surgery is sometimes required in patients who have progressive neurological deficit, or those who do not respond to conservative treatment sometimes choose surgery. A quandary sometimes arises following a primary surgery as to whether repeat surgery should be attempted or another alternative technique should be tried. This is the exact problem that the epidural adhesiolysis procedure was designed to address. Epidural adhesiolysis was given an evidence rating of strong correlation to a 1B or 1C evidence level for the post-lumbar surgery syndrome in the most recent American Society of Interventional Pain Physician evidence-based guidelines. Even the CPT codes are given to these procedures. It is very important to understand the pathophysiology of epidural addusolysis for a successful intervention and successful treatment of this problem. The etiology of chronic low back pain with radiculopathy after appropriate surgery is not well understood. Kochelik et al. Address this issue when they studied 193 patients who had undergone lumbar spine operations given local anesthetic into the epidural space. It was postulated that the sciatica could only be produced by stimulation of a swollen, stretched, restricted, that is scarred or compressed nerve root. Back pain could be produced by stimulation of several tissues, but most common tissues of origin were the annulus fibrosis and posterior longitudinal ligament. So we have to remember local pain is mostly because of annulus fibrosis and PLL. The contribution of fibrosis to the etiology of low back pain has been debated. There are many possible etiology of epidural fibrosis, including surgical trauma, annular tear, infection, hematoma, or intrathecal contrast material even. Understanding of pathology is very important. Keep in mind, LaRocca and McNabb demonstrated that invasion of fibrous connective tissue into the postoperative hematoma as a cause of epidural fibrosis. Cooper et al. Reported periradicular fibrosis and vascular abnormalities occurring with herniated intervertebral disc. McCorn et al. Investigated the irritative effect of nuclear pulposus on the dural sac, adjacent nerve root, and nerve root sleeves, independent of the influence of the direct compression of these structures. That's why many times there is we don't find any compression, but still the pain is there. So this is the chemical irritation of the area. Park and Watanabe showed significant evidence of adhesions in cadavers with lumbar disc herniation. It is widely accepted that post-operative scar renders the nerve susceptible to injury by a compressive phenomena. Scar tissue is generally found in three compartments of the epidural space. The dorsal epidural scar tissue is by the resorption of the surgical hematoma, ventral epidural space by the dorsal defects of the disc, and the lateral epidural space susceptible to the lateral defects, facet hypertrophy, and neuroforaminal stenosis. So we have to keep in mind all these anatomical landmarks. Kochelik et al. Summarized that the presence of scar tissue compound and the pain associated with the nerve root by fixing it in one position and thus increasing the susceptibility of the nerve root to the tension of compression or compression. They also concluded that no other tissue in the spine are capable of producing leg pain. This is important to understand. Ross et al. Demonstrated that subjects with extensive periradicular scarring were 3.2 times more likely to experience recurrent radicular pain. The evidence also parallels to the new studies by the Gilbert et al., in which lumbosacral nerve roots were identified as undergoing less strain than previously published during SLR, and in which hip motion greater than 60 degrees was determined to cause displacement of the nerve root in the lateral recess. So now come to what is actually the process we do inside the epidural space. The relative of functional foraminal root entrapment syndrome secondary to the epidural fibrosis with corresponding nerve root entrapment is frequently evident after an epidurogram, and signified by lack of epidural contrast flow into the epidural fingers, projection at those levels. The lysis procedure effectively serves as fluid foraminotomy, reducing the foraminal stenosis caused by the epidural fibrosis. In addition to increasing the foraminal cross-sectional area, adductor lysis serves to decompress the distended epidural venous structure that may exert compression at nearby spinal levels and inevitably cause needle stick related epidural hematomas. So this picture is showing the engorged nerves which are compressing upon the nerve roots. So diagnosis is very important. Thoromusculoskeletal and neurological examination is important, but dural tension or provocative dural tension or dural tug is very important finding for the diagnosis of epidural addusolysis. To perform the test, the patient should be instructed to sit up with a straight legs bent forward, flexing the lumbar spine until the back pain starts to come evident and the head and neck flex rapidly forward. During this maneuver, the dura is stretched, cephaloid, and it adheres to the structures such as PLL, the most heavily innervative spinal canal structure. The movement of the dura will elicit back pain that is localized to the pain generator. A positive dural tag maneuver has been observed to resolve after the percutaneous neuroplasty. So this is the dural tug maneuver being performed by Professor Gabor Rags. So this is the post addusolysis flexion of the neck, which is pain-free now. So this girl has T9, T10 dural adhesions, which went away after the addusolysis at that level. So commonly at the mid of the back pain with positive dural tug, it is mostly the addusolysis procedure that is very successful to perform. MRI and CT are diagnostic tools. Sensitivity and specificity are 50 and 70% respectively. CT myelogram may also be helpful, although none of the aforementioned modalities can identify epidural fibrosis with 100% reliability. In contrast, epidurography is the technique used with considerable success, and it is believed that the epidural fibrosis is best diagnosed by performing an epidurogram. It can detect the filling defects in good correlation with the patient's symptoms in real time. A combination of several of these techniques would be undoubtedly increase the ability to identify the epidural fibrosis. So there are multiple indications, especially the failed back surgery syndrome, post-laminectomy, disc disruption. So we have a lot of indication for this, and the contraindication, as you know, the sepsis, chronic infection, coagulopathy, local infection, patient refusal, syrinx, and Torlov cyst also one of the contraindication for the caudal epidural approach. Relative contraindication can be arachnoiditis. So regarding the caudal epidurography, the epidurogram is performed using 10 ml of non-ionic water-soluble contrast. Confirm a negative aspiration for blood or CSF before any injection of contrast or medication. Accidental subarachnoid injection can lead to serious forward unwanted events such as seizures and possibly death. Slowly inject the contrast agent and observe the filling defects. There must be normal Christmas tree if there is no adhesions, which we already saw. And if there is vascular uptake, needle should be redirected. So this is a picture showing both the filling defects and the post-epidural addusolysis Christmas tree appearance in the patient with fibrosis. So the caudal approach, vascular uptake is very important. Sometimes there is a little bit of vascular uptake by the engorged veins. So after adhesiolysis, that goes away. What is the role of, we also use the hyaluronidase in that. We inject 1500 units of hyaluronidase dissolved in 10 ml of normal saline. The role of hyaluronidase is debatable, and mostly it causes the good spread of the medication in the fibrosed areas. We use also local anesthetic and steroids in that. So hypertonic saline infusion is also very important because it causes the numbing of the area, the sclerosis of the C fibers nerve endings. But the important point in giving hypertonic saline is that it should be given at least half after 20 to 30 minutes after the local anesthetic. If the patient feels motor block, don't give anything else, or even not the hypertonic saline, don't give it. If the patient is normal, doesn't feel any motor loss, then you can infuse the hypertonic saline into it. It helps in softening the area and reducing the inflammation of the inflamed nerve roots. We can also give transforaminal radiculopathy. For that, if we can reach the target area from the caudal area, we can go transforaminally as well, and to break the adhesions like this. And this picture is showing the adhesiolysis. And because there was a tear in the disc, so it has taken up the dye also. So first sacral foramen, as you know, L5, S1, anterolateral epidural space is frequently occupied in epidural adhesions, which are associated with pain and a lack of contrast filling on epidurography. The volume of this space is measured to be 1.1 mil anatomically and 0.9 mil surgically. The lysis of adhesion via caudal approach may be difficult in patients with epidural adhesions at this location. So we use the posterior S1 foraminal approach to break the adhesions directly from this area. Cervical lysis of adhesion, cervical epidural, very nicely elaborated by my friend Mr. Malik. Very nice presentation on this. And we as anesthesiologists can perform these procedures with confidence, and in the presence of a C-arm, it is very easy to perform. So we as a pain physician, we mostly choose the T1 or T2 or T2, T3 areas commonly because the epidural space over here is the maximum and is the safest area. Above than C6, the area is smaller, and sometimes the sudden movement of the patient's neck can cause any injury. But if we use these lower areas, upper thoracic, we can nicely address the C7, C8 nerve roots very nicely. So we use mostly T1, T2, or T2, T3 areas for chronic pain. The 3D techniques, direction, depth, direction is very important, but sometimes it is very difficult to see the lateral view in the lower. So we do the oblique view for that, as mentioned by my friend Mr. Malik, in 45-degree contralateral oblique, keep in mind, contralateral. So as with caudal epidurogram, look for the filling defect. It is extremely important to visualize the spread of contrast in the capillate and caudal direction. Loculation is one of the most important thing. You have to be careful. If you find some loculation by giving the dye in the catheter, take care that because it can compress your spinal cord and can cause neurological problems. So never give injection if you find a loculation of the contrast in the cervical area especially. So this is a patient, and most of the time the operated cases we go from in the lateral gutter, we use this route for entry of our catheter for sliding in the catheter, which is steerable, and we can reach our target area very easily. The complications like are bleeding, infection, headache, and like this. The most important complication is subdural or subarachnoid injection of local anesthetic or hypertonic saline. So we have to avoid these complications by being vigilant, and if we find any contrast going into that area, we must stop immediately. And subdural injection is just like intrathecal, because it will definitely go intrathecally, and only the sign is that very small amount of contrast will give you a very long line of appearance, sharp line on posterior epidural space. So we have to avoid it and be vigilant. Don't perform the procedure if you find any doubt in the spread of the contrast. So although the potential list of complication is long, the frequency of complication is very rare. A subdural spread is a complication that should always be watched for when the injection of local anesthetic is given. During the caudal adductor artery, particularly, the catheter is advanced along the midline, but subdural catheter placement is at risk. So avoid going along the posterior midline, because it's the most scarred area you will come across. So this is a showing the intrathecal spread of the dye. This is our Manchikanti et al. They had a good study on this, and they found it very effective. And there are so many other studies already done, which I am not going to mention because of the short time presentation. So the take-home message is epidural adhesive lysis very effectively in most of the failed Ségy syndrome patients with strong evidence. Care must be taken in advancing the catheter in lateral gutter of the epidural space, because the posterior epidural space has maximum adhesions and subdural puncture is very common. Loculation in cervical area must be avoided, and neck and rotation exercise can be helpful for good fluid runoff. Hypotonic saline must be given after ensuring correct placement of the catheter. This is the targeted technique and must be learned by all the interventional pain physicians. Thank you very much. Long live friends of Bangladesh and all over the world. Thank you.
Thank you so much, sir, for your informative presentation. And this is the time for our last speaker, Dr. Mehran Kauchek from Iran. I like to show my lobby. If wrongly, I wrongly placed your name spelling. It is the Department of Anesthesiology, Shahid Beheshti University of Medical Science, Imam Hussein Hospital, Tehran, Iran. And he is a FIPP examiner since June 2017. He is a member of World Institute of Pain Educational Committee since October 2017. So please proceed your presentation.
Hello. Hello, do you have my voice?
Sir, you need to increase your volume, sir.
No sound.
Is that better?
Just you adjust your volume.
Is that better?
Yeah.
Can you hear
That's
me?
right. Yes, that's right. You can sit now, sir.
Okay. Hello, everybody. Thanks for Dr. Professor Sarda for inviting me to this honorable conference. And I would like to thank the representatives, Professor Chris Visser and Oliver. Is everything okay?
The volume is important. Please.
Meheran, just follow my instruction. You just keep at your lip level. Yeah. Raise it up to your lip level.
Okay?
Yes, this is all
Can
right.
you hear me now?
Yeah, better.
Okay.
Keep it very close to your lip. Yeah.
I would like to thank everybody, our colleagues, our lecturers, and Professor Sardar, Professor Chris Visser, and Mark Oliver. After more than 1 hour delay, I would like to go through to my lecture very fast. Interventional pain management for frozen shoulder, also known as adhesive capsulitis, is a condition characterized by stiffness and pain in the shoulder joint. Signs and symptoms typically begin gradually, worsen over time, and then resolve usually within 1 to 3 years. So from orthopedic point of view, there are 3 stages for this problem: freezing or painful. Pain increases gradually, making shoulder motion harder and harder, and pain tends to be worse at night. And the second stage is frozen. Pain does not worsen and it may decrease. The shoulder remains stiff, and the last stage is thawing. Moving gets easier and may eventually return to normal. The shoulder is made up of bones like clavicle, scapula, humerus, joints, glenohumeral, acromioclavicular. The capsule envelopes the joint and attaches to the scapula and humerus and head of the bicep. There are important ligaments there: coracohumeral, glenohumeral, and semicircular humeri, and the transverse scapular, which separates the suprascapular nerve and artery. And there are the muscles. The most important one is the rotator cuff, consists of supraspinatus, infraspinatus, teres minor, and subscapularis muscles. And the nerve that we are going to talk about is the suprascapular nerve, which is comprised from C5, C6, and sometimes some branches from C4 from the brachial plexus. So you see here the joint, the glenohumeral joint, and the AC joint here. And you can see the diagram here. And you can see the roots of C5, C6, and sometimes C4 coming to suprascapular notch and coming to the joint and the muscles of this area. So frozen shoulder management, first we should have a good history taking and physical exam, the shoulder test. We need some imaging, plain X-ray and MRI. Our goals are to decrease pain by pharmacologic issues on the basis of the patient's past medical and enduring history and drug history, some physiotherapy, and then the interventional techniques, of course, after the written contact. And we have the goal to increase the range of motion after the suprascapular nerve block with the specialist physical therapy. So now the indications of this block, the suprascapular nerve block, are frozen shoulder, suprascapular nerve, compression neuropathy, palliation of acute pain, especially after trauma, shoulder postoperative pain, bursitis around the shoulder joint, pain related to cancer, and sometimes for adjunct therapy for aggressive physiotherapy to improve range of motion in CRPS and adhesive capsulitis. The contraindications of this block are local or systemic infection, coagulopathy, and if the patient takes a blood thinner that should be held, and the anatomic anomaly. So techniques for this block is started in 1941 by Wertheim and Robenstein, and by blind technique. Sometimes we used during the time the nerve stimulator, nerve locator, under the fluoroscopy and under the ultrasound guidance. The fluoroscopic techniques should be under the strict recommendations of American Society of Anesthesiology. The patient is in prone position after correcting drape. We use AP cephalot and IPSI oblique, each 10 to 15 degrees, and our spot will be the suprascapular notch. This is one of our patients with the right hand decreased range of motion and severe pain, and this is the after suprascapular nerve block. Under the fluoroscopy, you can see here beautifully the suprascapular notch and the traverse of the needle spot the suprascapular notch, and we have used the contrast media here. So the medications that we can use after the correct needle placement and aspiration, that there should not be no blood and no air. We will use some contrast, and then 10 cc ropivacaine 0.2% plus minus steroid is suggested. Sometimes we use neurolysis after acceptable diagnostic block, long-lasting block. We will need for some types of neurolysis, which is chemical, 6% phenol. We do not usually use it. That could be dangerous, but usually we use pulse radio frequency. It is very important that it should be pulsed, because the conventional radio frequency may make the shoulder drop for the patient. So after sensory and motor stimulation, we will use 2 to 4 cycles, 42 degrees centigrade, 120 seconds in 2 directions. Complications could be vascular injury, local anesthetic toxicity, infection, and the most important and dangerous one is pneumothorax. By the ultrasound guidance, the patient is in sitting position, and we use high-frequency linear 6 to 13 megahertz probe. And after identifying the pleura at the 4 centimeter depth, we move the probe cephalot and the lateral, and we locate the suprascapular notch, and we see hyperechoic nerve and the pulsatile artery by Doppler technique. So you can see the anatomy and this suprascapular notch. The suprascapular.
Mehran, a little bit closer. Yes. Yeah.
Excuse me?
Yeah, yeah. Now it is
you
okay.
You have my voice?
Yeah, better.
It's better, okay. And here I've used the Valkman atlas of ultrasound. This is the position of the probe and the needle. And now you can see the suprascapular nerve here, and the transverse ligament here, the supraspinatus muscle, the coracoid process, and the trapezius muscle. So you can see by Doppler the artery. We should be very attentive not to puncture this. And sometimes we have the supplemental blocks, the technical 3-in-1 block. And you can see here, we mark the AC joint, and then we'll traverse the needle directly to the joint. And after the needle is in the joint, we will use the contrast media to fill up the capsule. And then here you can see by withdrawing the needle, you can see the fill up of the capsule around the humerus head. So if AC joint is impossible to traverse, we can use directly the needle into the subacromial space and use the contrast and inject R. And we should specifically monitor the patient for the stability at least for 2 hours. After the procedure, we should use chest x-ray for ruling out the pneumothorax, and tenderness and swelling after 24 hours should be attentive. We should be attentive for that. Or is not a problem, we should use ice pack. And if the tenderness increases and shortness of breath, very important sign, we will find near the patient should call MD. Thank you very much.
Thank you so much, sir.
You're welcome.
Now, very quickly, we will hear comments from our chairs of the session. I have already told, today we have 3 great personalities for this session, Chair. I'd like to request to speak Professor Moinul Hussain, sir, and Professor Mohammad Abdurrahman, sir, respectively. And last but not least, our BSA president will give concluding speech of the session. Professor Moinul Hussain, please.
Thank you very much. First, the second speaker, actually, I was the chairperson of that speaker, Dr. Oshit Chakraborty beautifully described in a step-ladder pattern the different evidences which can be done in the current and following the current guideline for the interventional cervicogenic headache and evidences in that. One proverb is there, that is either you follow a guideline or you create a guideline. He created beautifully the step-ladder pattern, the different steps which can be taken, and he compared the different steps beautifully. I am very much, we are thankful to Ashish Chakraborty for his presentation. The last speaker which I followed is the Meherin Kosek from Iran, the interventional pain management for the frozen shoulder, and he beautifully described, and is really presentable, the fluoroscopy guided which can be done or ultrasound guided, the suprascapular nerve block, or which can be sometimes, if failed, the neurolysis can be done. The voice was disturbing initially, but later on it's okay. I think he beautifully described the supraclavicular block with the ultrasound guided. We are thankful to Dr. Kosek. The third, another speaker is Jamil Savit from Pakistan. Is one of the examples that what is the importance of the ultrasound guide, and in case of he described the advanced interventional procedure for after especially the laminectomy, the fibrosis which can be occur. He beautifully expressed and shown the slide the different the advantage of giving the epiduroscopy, and his topics is mainly the tips and pulse. The pulse is there, the outcome of the patient. We are also very much thankful and beautiful for his beautiful presentation. Thank you very much.
Sir Mohammad Abdul Rahman, sir. Sir, please give your valuable comments.
Roman sir. Roman sir. Roman sir.
No, he's disconnected. You can carry on.
So may I request our BSA President, Professor Davadik sir, please conclude your concluding speech, conclude your session.
I think it is today is the first session. We are there behind the expected time. Today in first session, all speakers and are very good speaker among good topics, and I think in their presentation and everything is very excellent, and it is for beginner who can practice the pain in the beginning state. They can try and to develop the skill on especially cadaveric stages, because all of the things that today in this presentation are very skill it is required, and also the instrumental support is also required, and so it's a very effective and informative and more skill develop procedural for the management of pain. And this is all our intervention on pain management. I think it is. I thank all of the presenters, and welcome for next hour with more developed presentation in the future. Thanks from BSA to all of the presenter and faculty and speaker and participant for this session. I think this is the my last comment, or it is the end of this session.
Thank you, sir.
Thank you all for your patient sharing. And I must convey my heartfelt thanks to Professor Kausar Sardar sir for his tremendous effort. And we all know sir is the first Bangladeshi pain physician with the honor of Fellow of Interventional Pain Practice from World Institute of Pain, USA. Stay safe and healthy, sir. Our next session will be start soon. So now I'd like to hand over to our beloved Professor Kausar Sardar sir.
Okay, thank you. Thank you, Majer. Thank you very much, all speakers of our last session. It was fantastic. It was fantastic lectures from all of you. And the brilliant comments from the chairs also. So we are moving to our next session. Next session is a big session. There is 6 speakers here. Anwar Sambari from Anwar Rashad. He's from Malaysia. Professor Sang Chu Lee from South Korea. Nicholas from Singapore. And Ibrahim Ashik, Professor Ibrahim Ashik from Turkey. Dr. Rohit Lahori from India. And Laxman Desnaike from Sri Lanka. So these are the 6 speakers. I think everyone has joined here. Okay. So right now I'm moving to our next session moderator. Dr. A.K.M. Habibullah, are you here? Habibullah? A.K.M. Habibullah, you are here? A.K.M. Habibullah, the next moderator. Moderator Habibullah, you are not here.
এইমাত্র তো ছিল এখানে একটু আগে তো ছিল
হ্যাঁ Okay, can you call somebody? Yeah, Majhar, can you call Dr. Habibullah? Can you call by your phone?
Sir, I'm trying
to join immediately. So here we can see our first speaker, Anwar Rashad. Professor Anwar Rashad is here. Make a hi to all. Anwar Rashad, just unmute.
Hi to all. Yep.
Okay, yep. Thank you very much. And next is speak Shang Chu Lee. Okay, Nicholas from Singapore. Are you here, Nicholas? Nicholas. Okay, he will join a little bit later. Rohit Lahori. Rohit Lahori, my friend, you are here. Yeah. Just yes. Okay, thank you. And Laxman Desnaika from Sri Lanka. Are you here?
Yes, can you?
Yes. Okay. Thank you very much. Dr. Habibullah, joined or not? Moderator.
Service joined here, but I think it's not responsive here.
He's in some sorts of problem. Yes.
You can start the session, Dr. Sardar.
Yeah.
I think we can start it. Yeah.
I'll do just.
Can you hear me, sir? Can you?
I can hear you.
Yes, sir. Everybody is okay now?
Okay.
Yeah.
Yes.
Okay.
Good
I will
evening.
join. Okay.
Yes, sir.
Okay. Carry on, please.
Good evening, everybody. I am Dr. A.K.M. Habibullah, consultant of ICU BSMU. On behalf of BSA, welcome to everybody in this session. It is my pleasure to welcome all the participants on day second and the second session in the first international e-conference on pain 2020. I welcome to all the eminent speakers and guests from all over the country and abroad. It is a large session, and to this, the chairperson for this session, Professor Wahiuddin Mahmood, honorable and renowned professor in Bangladesh. Professor A.K.M. Akhtarujaman, chairman of Anesthesia, Analgesia and Intensive Care Medicine, Bangabandhu Sheikh Mujib Medical University. Dr. Nafisa Khanum, ex-senior consultant, Department of Anesthesia, Analgesia and ICU, in charge of Pain Clinic, Bangladesh Medical College. Now I request to honorable chairperson to take their seat for this session.
Okay, already seated.
Yeah, good afternoon. We are already seated. We are already. I think you can start the session, I think.
Yes, yes, sir. Now I request the first speaker in this session, Dr. Anwar Samhari bin Mat Arshad from Malaysia. Chair Malaysia section, World Institute of Pain, consultant rheumatology or pain physician, bone joint and pain specialist center. Professor in medicine and faculty of medicine, AMIST University. His topic on the ultrasound and the carpal tunnel syndrome. Now I request to Professor Samhari to unmute and start his lecture. Professor Anwar. Dr. Anwar, can you hear me?
Okay, I could hear you. Okay, Assalamualaikum,
Yes,
and also good
yes.
afternoon, everybody.
Yes.
My name is Anwar. I'm from Penang, the northernmost part of Malaysia. Today I'll be sharing, it is not new, but it somehow is actually a part that has been neglected, entrapment syndrome. Before I go on, I would like to categorize my talk into about 4 or 5 domains, and I'm not going, well, I'm sure all of you would like me to go straight away to intervention, but it's more interesting topic, but I'll try to make it nice and short so that in the end of the day, I'll be able to convince everybody not to use blind approach anymore. First, before I go on, before I kick off, just an early announcement that the Malaysian Society of International Pain will be organizing our 4th International Pain Congress next year. We are very hopeful that we could actually organize it in the usual way, the physical way, that we could actually come and also enjoy Kuala Lumpur, and then we could meet we call face-to-face, yeah. And those who are interested is actually, you might want to contact msippmalaysia.com to get the further info. Right, okay, so it's actually some background about the carpal tunnel. It's actually, as we know, it's the most busy, the most crowded tunnel, and the border formed by the transverse ligament and also the bone. Well, for me as a rheumatologist, I'm probably more interested on the secondary cause of carpal tunnel, which is tenosynovitis. But it could also happen to the failed carpal tunnel operation because of the misdiagnosis, etc. Okay, first of all, I would like to actually go on for the surface marking, and distal crease is actually the proximal carpal tunnel is actually at the distal crease, and the distal carpal tunnel will be about 3 to 4 centimeter distal to it. So this is the first one, the surface marking. Next one is actually the proximal carpal tunnel. The border in ulna is actually speciform, as you could see here, and the radial is actually scaphoid. For those who started doing ultrasound to get the good image of the median nerve, we need to get this particular image first to study further. Yeah, and we also able to identify to study the Guyon tunnel as well in this particular image. And the next one is actually distal carpal tunnel, where you have a border in medially and also trapezius in laterally or radially. And we need to look out for the branches of the ulnar nerve, because it's actually, that was why we are a bit reluctant to do the injection distally. And we found it a bit hard to locate the tina and hypotina because of the different in that the retinal canal is getting thicker and thicker. And this is the most part that we look for mostly secondary cause, such as ganglion. Well, I mean, it's actually, let's study also the longitudinal or long axis part. The orange color is actually pre-tunnel, and then the red is actually proximal tunnel, and the yellow is actually distal tunnel. Okay. Well, I mean, carpal tunnel syndrome itself is the most common compressive neuropathy in the body. It accounts about 90% of the entrapment syndrome in the body, and I think it's actually one of the entrapment syndrome we should know in and out, I would say. Yep. Causes is actually, we could divide into so many causes. Metabolic, it's actually trauma kind of thing. But I would like to divide into osseous cause and increased content volume. Yep. The osseous causes, I mean, such as it's actually misalignment of the carpal bone, displaced fracture, hypertrophic bone changes, and increased volume, such as the pressure from the synovitis and hypertrophic muscle, and sometimes increase in fat or obesity. Well, I mean, you could actually divide, in the work-related as one of the etiology. And mind you, as a sonographer, for those who are doing ultrasound daily in and out, they are also having a risk of having work-related carpal tunnel syndrome. Yep. Pathophysiologically speaking, I think we are talking about the flexor tendon moving up and down, causing some sort of pressure on the flexor retinaculum, and this sort of a repetitive maneuvers loss and causing some edema, perineurial, and then subsequently cause axonal loss and demyelination. And of course, it's actually in early carpal tunnel syndrome, Doppler might be positive, and that's why it's actually you could actually guide your intervention, which is more effective at that time. Investigation one, well, do we need one actually? Well, it depends on which specialty are you talking about. Mostly it's actually our clinical judgment is about 80 to 85% specific and also sensitive. I think meaning that we cannot actually ignore our hunch as a clinician, because more of the time we are correct. Electrodiagnosis, well, it's slightly more, it's about 85 to 90%, but it's invasive and sometimes it's expensive. So, of course, ultrasound is slowly keeping pace with diagnosis, yeah, but mostly it's a clinical diagnosis. We might not know this because I just in clinical neurology, there are specific criteria for carpal tunnel. It's a long and laborious, but we might not need to go through all of it. Okay. And what is advantage of ultrasound for carpal tunnel? Of course, it's that there's a lot of disadvantages. Advantages. The most is actually one, to guide injection to find the secondary cause. Yep. I'm not going to go through everything because we just have 15 minutes and behind time also. Okay. Disadvantages, learning curve, operator dependent. Yep. Cost. And hopefully it's actually we are able to do, hands-on physical workshop, and we could actually teach, hands-on teaching, so that we should actually will learn this particular easy technique. Okay, there are also ultrasound criteria for diagnosis, yeah, subjective criteria as well as objective criteria. But I'm going to go through the objective criteria. The first one is actually it's been described by the Berger in 1991, yeah, and the first one is actually the first criteria is actually the mean cross-sectional area of the middle nerve measured at the pisiform is about 10 millimeter squared. Yeah. The second one is actually delta CSA, the difference between pisiform CSA, cross-sectional area, CSA is cross-sectional area, minus the distal radial CSA, 4 millimeter. Well, the other three is probably more academic for research purposes. But again, for the sake of presentation, I'll just probably just share the what we call the slide. Okay, the first one is actually the first criteria. We need to look at two border, the radial and ulnar border, and then try to find a lunate. There will be it's a pre-tunnel sign, and also okay, the next few slides actually show how big is the carpal tunnel. In this case, you could see it's about 54.1 millimeters squared. It's very large. Because it's huge carpal tunnel, huge medial nerve actually. Okay, longitudinally speaking, it's actually it shows flattening of the nerve, as you could see here. Yeah. This is actually the first criteria. Okay, this is second criteria at the level of pronatus quadratus, and also the difference between CSA diameter, meaning that if more than the ratio more than 1.5 or 2, you sort of like you could safely make a diagnosis of carpal tunnel syndrome. And the third criteria is that the flattening ratio of the nerve transverse diameter divided by the AP diameter is greater than 4.1 at the level of hamate bone. It's difficult though at the level of hamate bone because it's more distal, and as you say, insonoration view has become more and more difficult. And of course, the first criteria is volar bulging of the flexor retinaculum. The volar bulging of flexor retinaculum is greater than 3.1 millimeter. Okay, this is also a significant palmar bowing of flexor reticulum. It probably one of the sign of primary carpal tunnel. It's one of the marker. The other sign of primary carpal tunnel would be the thickened flexor reticulum more than 1 millimeter. Yep. Okay, this is actually one of the clue, one of the hints is actually that to diagnose primary carpal tunnel syndrome. Some tip to predict the chronicity of the carpal tunnel, and as you could see, if you could see here, is actually the perineurium fascicle interspersed with the echoic perineurium, yeah, and hyperechoic epineurium as well. So this is to say that this is a chronic carpal tunnel, long-standing carpal tunnel where you have massively swollen nerve. The fascicles are less hyperechoic and Doppler negative, and this is less likely to respond to our injection. This is where usually I'll ask my orthopedic surgeon to have a look in view of the surgery. Okay, radial cause of the carpal tunnel, increased pressure within the tunnel ganglion, tenosynovitis. I've got some video for it as well. And persistent median artery and persistent median artery and also thrombosed median artery. It's one of the rare causes of the carpal tunnel. And infection at the subcutaneous level resulting in carpal tunnel syndrome. And sometimes it's actually persistent carpal tunnel because of the poor surgical technique, I would say. That can cause a secondary carpal tunnel as well. Okay, next is actually literature appraisal about the usage of the ultrasound in carpal tunnel. As you could see here, the first work was done, I think, about 3 decades ago by Dr. Berger and colleague. And at that time, they were limited with the technology, and they have to verify the finding through the MRI. And as we know, it's MRI is something a bit difficult for just a small hand just to be put in the MRI in the magnetic field. So because they're a bit limited in terms of technology. And as you see, define for the carpal tunnel syndrome. I think all of them, this is the next slide. Yeah, all of that is actually, they agree that it's actually the best place to measure the CSA is at the pisiform. Yep. And if they were to measure at the hamate, the sensitivity become less. It's about 70 to 80%. So it is now established that it's actually where is pisiform is the best place to measure the CSA. Well, somehow in 2011, there's a bit of controversy there. And so Dr. Fowler et al. And colleague in 2011 did a systemic review, reviewed about 323 papers about ultrasound in carpal tunnel, only 19 entered analysis. And this is the finding. It's actually, the first one is actually, as I said before, pisiform is the most commonly measured location. CSA more than 14 rules in carpal tunnel. Less than 8 rules out carpal tunnel. Well, I'm not going to dwell on delta CS. It's not really important in clinical practice. Yep. Well, the other finding is that ultrasound should be considered as a first-line screening tool in high test probability because the nerve conduction sometimes might be negative. Yeah. So in any atypical cases of carpal tunnel, ultrasound should be first. I think investigation should be ordered. Right. Okay. Again, this is a slide that I always put before the workshop. Yeah. And but again, it's a shame that we cannot do the hands-on. This is actually the checklist for the ultrasound to study the median nerve. Okay, with the practice, we could do this within 2 minutes or 90 seconds, I would say. Yeah, we start with our distal forearm, and we go on assessing the proximal carpal tunnel, and then distal carpal tunnel, and we go for the longitudinal, and then we go for the specific special test. Right. The first one is actually you might want to actually just sit patient comfortably, and you also need to be comfortable. Patients and exam need to be comfortable, and wrist on the table, slight extension about 10-20 degrees. You need to use a general gel, a very generous gel. Yeah. And then this is actually the view of a distal forearm where you can get pronators. Muscle striated, and but the tendon is a bit less hypoechoic, and fascicle is a bit hypoechoic here, and epidural tend to be more hypoechoic. And tendon, we could actually distinguish tendon with the muscle with anisotropy. And you slide down distally until the corrotus become hypoechoic at distal wrist. Yeah. And this is the inlet. Yeah. We need to actually try to locate carpal tunnel and also try to locate pisiform, the border, and also the scaphoid. And as you could see here, it's actually there are 10 structures altogether in the carpal tunnel. Very busy, very structured then. And then of course you need to locate the palmar cutaneous branch of the median nerve, because it's one of the reasons that we seldom do injection on the radial side. Yeah, because we try to avoid the nerve. And the tunnel outlet, tena and hypothena, is superficial to the bone. And well, I mean, this is the clue. Just use the bone as a caustic window. Median nerve might be flattened here, and then, well, we are not looking at the nerve at this area, at the distally. We're probably more looking for the secondary cause, such as accessory lumbricals, ganglion, whatsoever. Okay, this is a longitudinal view. As you could see here, the most prominent structure is actually the third CMC. Yeah. So this is actually the longitudinal view. Okay, this is actually my slide. It's actually the protocol. Yeah. You start at the distal third of the protus chondroitus. You actually slide distally, go looking for the proximal inlet and looking for the pisiform, looking for the scaphoid, and try to identify any causes there, and try to look for the palmar cutaneous branch of the median nerve, which are located radially. Yep. And then, of course, you go distally to look for the secondary cause, accessory lumbricals, yeah, accessory muscle, and ganglion as well. Yep. Okay, so as I said, with practice, we could do this just within less than 2 minutes. Yeah. So this is actually one of the tests that we are doing, dynamic testing to look for the secondary cause. The first one is actually flexor digitum FDS intrusion test. The second one is lumbrical intrusion test. The third one is actually tena digital intrusion stress test. Well, it's not validated, but it helps in a way. Yeah, it helps in a way to look for the secondary cause. The first one is actually FDS, flexor digital superficial intrusion test. We are looking for the muscle bellies of FDS, the superficialis, and also for fundus that may enter the tunnel during the hyperextension, and thus creating the what we call the compression, the compressive neuropathy. So the first test is actually FDS intrusion test. You hyperextend, yeah, with the ultrasound probe at the distal crease. And then you just hyperextend. You could see sometimes this muscle protrude to the tunnel. The second one is actually to look for the lumbrical muscle, accessory muscle lumbrical. You might want to do flexion, hyperflexion at the wrist, as though that you're doing phalanx test, and there's emergence of the hypoechoic mass or accessory muscles. Yeah, just like this. So this is one way. The third one is actually the tena digital flexion test, where you look for the what we call the tena, some sort of, is actually the accessory muscle compressed enough. Yep. It's probably a bit difficult just to look at the diagram, but again, it's actually, this is just not validated. As again, just a checklist. This is actually the first anti-resic. It could be done with practice between less than 2 minutes. Right. Okay. Intervention. Why ultrasound? Actually, there's so many reasons we use ultrasound over blind technique. Yeah. In fact, it's one of the most, as we know, the steroid outcome is about 4 to 6 weeks, and there's one paper claim that it's actually the long-term outcome is possible up to about 4 to 6 months if properly done under ultrasound guidance. Yeah, and it's a report on the case study from what we call Dr. Mori et al. In Italy in 2008 showed that it's actually, if you do hydrodissect together with the steroid injection, it will prolong the steroid effect up to about more than 3 to 4 months. Okay, can ultrasound ultrasound predict treatment outcome? Okay, L. Madini et al. In 2015 showed that it's actually, if CSA more than 14 millimeter and the flattening ratio more than 2.8, with a power Doppler is actually positive, it's a good outcome that ultrasound will actually work. Yeah. Okay. So, okay. What ultrasound guided injection? So with what? So we could there's no RCT is actually comparing head to head with all these modalities. We could go for hydrodissect with stretch source water, steroid injection, pulse radiofrequency. Sometimes we could do ultrasound guided carpal tunnel release, and sometimes, well, I put here PRP, and because some of the studies show that PRP will work, and for me, it's depending on etiology. The two approaches altogether is either in plane, ulnarly or radially, or out of plane, or I call it Grassi's method. It's one of my guru, Walter Grassi in Italy, and described this particular method about 15 years ago. In fact, with ultrasound, it doesn't matter actually, as you could actually approach either way, as long as you avoid, well, I mean, all the dangerous structure, you are fine. The best outcome is actually just to avoid much discomfort to the patient. You might want to reach the target with the least, what we call length of, is actually the length of the length of the needle travel to the target. Right. Okay. This is actually the what we call the longitudinal in plane and also transverse in plane. The transverse in plane is actually there's a space between the median nerve and also flexor carpi radialis. There's a space between that. There's one of the safest space in between that particular structure in proximal carpal tunnel. That we could deposit is actually steroid. And you might want to ask the patient to hyperextend and also flexion just to actually distribute the steroid equally. So this is the way actually you put deposit the steroid. This is the nerve, and this is actually where it's a tiny subtle space that you deposit the steroid. Yep, in between FCR and also the nerve. This is what we call Grassi's method from Professor Walter Grassi, a very famous sonologist from southern Italy. Okay, transverse injection is my favorite method. It's a transverse in plane ulnar approach. Yeah. Okay, this is actually where the injection. This is where it's actually the you could go either below and also above. Yeah, 1 or 2 cc below to hydrodissect, 1 or 2 cc above to hydrodissect, just to retract from the fibrotic what we call tissue around the nerve. And hydrodissect is actually needle inserted is either out of plane. Well, that's a solution about 5 to 10 cc. Well, I quoted this particular paper, 5 to 10 cc, because it's actually they showed it's actually it's efficacious up to about 4 to 6 months. Yep, we need to use that particular volume of the for the hydrodissection. Okay, there's a paper coming from Dr. Smith et al. And published in Journal of Science Medicine 2008, and the ulnar approach. Yeah, the ulnar approach is actually you put the what we call the ultrasound transversely, and transfer is moved until you found the pisiform, as we described before. And if you use ulnar approach, you are able to actually minimize the damage of the palmar to the branch of the median nerve. And then you target the most edematous part of the median nerve. And it's not like a very difficult injection. I mean, you just target the most edematous part of the nerve. Yep. Okay, this is the one
sorry,
of the.
Sorry, Dr. Anwar, we are in shortage of time.
Sure. Okay. Right. Okay. All right, I skipped the video. Well, minimally invasive technique is actually sometimes you're using some sort of gadget. They're probably more on orthopedic point of view rather than us as a pain interventionalist. And this is actually one of the mentor, Josh Brune. And again, I summarize my talk is actually, yeah. The first one is actually we could rule in safely carpal tunnel if more than 50 millimeter, and we could rule out safely carpal tunnel is more if CSA less than 8 millimeter. And again, it's actually complementary to electrodiagnosis. You might want to consider as a first line investigating the atypical carpal tunnel. Again, ultrasound could be done quickly, and there's a lot of potential research for ultrasound carpal tunnel. Thank you very much.
I think we're running out of time.
Yep, thank you very much.
Thank you very much, Dr. Anwar. It was very informative lecture for us. And now I requested Professor Sang Chul Lee from South Korea for his topic on transsacral epiduroscope lumbar decompression. Professor Sang Chul Lee is Professor Emeritus of Seoul National University College of Medicine. He served as the President of WSPC AAF PS, Korean ISSP chapter, Korean Pain Society and Korean Society of Anesthesiologists. He gave lecture at international meeting close to 200 times and published more than 230 articles. Please start your lecture. Professor Sang Chul Lee.
Okay, Saidul, please.
I'm Professor Emeritus Sang Chul Lee of Seoul National University College of Medicine. Before I talk, I would like to say thank you to Professor Sadar for inviting me to this wonderful meeting and also giving me a chance to talk. Today's topic is transsacral endoscopic laser decompression, which is one of the most useful and easy and simple technique for decompression of the lumbar disc herniation. So today's topic is transsacral endoscopic laser decompression. Next slide. So what are the indications for SALDA? So indication is percutaneous disc herniation, down or up migration, in anal-test syndrome, and recurrent HNP or remnant HNP. Contraindication includes bony stenosis, canal, foraminal, or extraforaminal, and foraminal disc herniation, or huge herniated disc, or wound-based herniated disc might be a contraindication in some cases. How can we inject catheter to get to the lesion? So we enter anterior spinal canal through the natural opening. What is the natural opening of the spinal canal in our human body? That's the sacral hiatus. That's the natural opening for the spinal canal. The measurement you have to check just before and right after procedure includes VAS, SLR, motor, epitogram to evaluate disc shape. Here you see the classification of the HMP as canal compromise foraminal involvement by American Journal of Radiology. So mild is the last 1/3, moderate is the 1/3 to 2/3. The severe is over 2/3 of spinal canal. The equipment we use for this procedure includes catheter, epiduroscopy, laser. We use coronary laser, and also we use a C-arm for these procedures. What is the disc herniation? It looks like a stone in shoe. So, stone shoe is very cumbersome and always painful. So, how can we remove this thing? So, we take off the shoes and make it upside down and remove the stone in the shoes easily. Next. So here you see the catheter. So catheter, you can advance it through the sacral canal, and after that we advance to the target lesion. So outer diameter is 3.0 millimeter. And there are two walking channels. One is for endoscope and the other is for laser. In bidirectional steering is possible with this catheter. We use Maltec the catheter for these procedures. So here you see the two vocal channel. The upper one is for endoscope, and the lower one is for a laser. We use lateral approach. This is a very important step. So limitation of time is less than 1 hour. And total amount of irrigation we can use for this procedure is less than 200 cc. And if the patient complains headache or neck pain, we have to stop the procedures. So you have to keep this limitation 1 hour. Here you can see the flexible endoscope from Myotech endoscope, 0.9 millimeter diameter. This is the luminous first P20, which is the Corneal lasers. So energy we use for this procedure is 0.5 to 2.5 joule, and rate from 5 to 15, and test dosage is 0.5 joule. And usual energy we use for decompression of disc is 0.7 to 1 joule. Why we use corneal laser? Because it has low tissue permeability and excellent tissue vaporization, and damage of surrounding tissue is minimal, so it is very safe. Here you see the result of the clinical study. The final clinical outcome at 2 weeks and 3 months follow-up. So we track BOS and ODI. So by magnet criteria, excellent to good is 83.2%, and fair is 9.4%, and poor is only 7.4% after these procedures. You have to remember this, because there are two work channels. So as you can see, scope is on the upper side and the laser is on the lower side. Therefore, you can see this area, but if you shoot the laser from here, then the laser hit this area. So you have to consider this when you perform procedures. So mechanical pain relief in arthroscope lasers. We can decrease size of the lumen disc and adhesiolize the pure space using laser. And mechanical adhesiolize is also possible. And we can burn away the side of the arterial nerve and ingrown nerve. And we can reduce the inflammatory mediators by irrigation, usually with saline. We can decrease size of the honey lumen disc with this procedures. So here you see the shape of the disc after after giving Curtis dye, Curtis medium. So as you can see, there is elevation of the disc to the posterior side of the arterial canal. So we advanced the scope to the lesion. So here you can see the elevation of the disc, protrusion of the disc actually. And we advance it. So here is the shape of the disc. And we advance it gradually, step by step. And we can remove this portion of the disc with laser. Okay, more, and more. Then we can remove the total portion of protrude disc with this laser. Next. So, and also adhesiolize the preneural area is possible with laser. So here is the nerve root here. So this is disc, and this is L4, and this is L5 nerve root. So it must caster just beneath the nerve root and advance it. So adhesion-wise is possible. So you can perform adhesion-wise only severe. And this is the schematic drawing of the anterior pure space. So you can see the dura and neural tissues here, and this is this, and here you can see the PLL here. So we advance the laser fiber.
Its sound is very slow. Sound is
here, like this, and we shoot later. Yeah, you can make a whole lot.
Sound is very low.
Yeah, it just collapse. So this symptom side will disappear. Here you see the example of the procedure. So this patient has the disc material protrusion here, and we perform the procedure. Before the procedure, there is huge protrusion disc, but after the procedure, as you can see, the side of the disc protrusion is decreased. And this is not the case. Here is the disc protrusion here, and after procedure, it's improved already. And here you can see another case. So these patients, when we inject interest medium into the pure space, it was obliterated or blocked by the severe. But after performing the procedure, then it can go higher and higher. There's no blockade anymore. Next. So here you see a ventral pure space shape. So this patient has the BOS 7 and SRL 3rd degree, and we perform procedure. After that, BOS decreased to 2, and SRL was totally free. So here you see lateral and AP view. This 24 years old male has leg pain on the right side, and SL was 40 degrees. But after procedure, it is increased to 60 degrees. This 55 years old man has left leg pain, as a 20, and after procedure, the symptom side improved. And 76-year-old man who has right leg numbness, and after procedures, the result is like this, much better. This patient has the upward migration, sequestration actually of this material here, and after procedure, no more sequestration. Now, 67-year-old female who has left back pain, last night as a 20. So instead, 2 weeks ago. So she received multiple pain blocks, but there was no improvement at all. So what is the best way? So you perform SDLD to this patient, and much better. And 44-year male, old male patient who has right leg pain has this kind of shape of the cyst material here, and it is also improved after procedure. The patient who has axial pain, female, 48 years old, the leg pain for 6 months. So we perform procedure to this lady, and the symptom was improved. So here you see the shape of the view, the ectoscope, when you perform these SL procedures. As you can see it, you can see that this is neural tissue, dura, and this is this material. between two structures, you see a pure space. So we perform these procedures and we observe the structures exactly, accurately, and we can perform any kind of procedures with safety. Here you see the cadet study of the SCLD. So this is the view of, we advance the caster anterior to the neural tissues. So, and we advance the caster to the nerve root here. So you can advance the caster like this. Sometimes you can make pure punctures during inadequate manipulation of the instrument, or sometimes because there is very thick adhesion, and then we can make these kind of pure punctures. Sacral nerve injury can occur during a course.
It is almost inaudible.
We advance these casters, and if it is too hard, then it will be straightened and stretch the sacral nerves from here. So sometimes we think about this. So here you can see a conclusion. If fluoroscopy is the window into the inner workings of the body, which allows for direct observation of the pure anatomy. And this neural decompression by using laser is suggested to be a more active therapeutic modality for treating low back pain or lumbar disc herniation. Thank you very much for your, let's say.
Thank you very much, Professor Sang-Chu Lee from South Korea. Our next topic, intrathecal analgesia for the intractable cancer pain. And speaker Dr. Nicholas Chua from Singapore. Dr. Chua is medical director and consultant, pain medicine and anesthesiology, specialist, Pain International Clinic, Mount Elizabeth Novena Hospital, Singapore. Dr. Chua is the current president of Pain Association of Singapore. He completed his fellowship of interventional pain medicine physician, FIPP accreditation in 2007. Now I invited Dr. Nicholas Chua to start his lecture.
Yes, Nicholas Chua, Nicholas Chua also the right now examiner of the FIPP also, Habib.
Yes, yes, okay. Sorry, I am sorry.
Yeah.
Thanks. Nicholas Chua, can you hear me? Dr. Nicholas Chua.
Yes, can you hear me now?
Yes.
Excellent.
Can you start?
So can I start?
Yes.
Thank you. Thank you, Kausar, for inviting me. It is my pleasure to be invited for your first pain conference in Dhaka. Though it's 1 hour late, it's 7:15 here in Singapore, but it's a great pleasure to be talking to you tonight on a precious Sunday night to all of you. My topic today is on intrathecal analgesia. I've been given 15 minutes.
Yes.
It's a very short time, but I'll try to do my best for this topic. It is a big topic, but I'll try to zoom in on all the pertinent points and keep it interesting. So I've got nothing much to disclose except for some honorarium and 2 consultancies. I will not be presenting anything off-label tonight. I'm the current president of the Pain Association of Singapore. I sit on the board of examiners in the FIPP for the past 8 years. And I'm on the scientific committees for several conferences as well as the editor and associate editors. Okay, this is the scope for my lecture today. We'll first talk about introduction to intractable cancer pain. And then we'll talk about the different types of intrathecal drug delivery methods. I will demonstrate how to initiate therapy, that basically how to start intrathecal therapy, the medications to start with, as well as the dose, and finally how to titrate therapy. So a very brief introduction is that both a systematic review and meta-analysis reported that 52% of all cancer pain patients experience pain regardless of the stage of their disease. And we know from the WHO ladder that interventional techniques or intrathecal analgesia is in the fourth step. So intrathecal drug delivery literally means that you are delivering medications directly to the nociceptors in the spinal cord, thereby bypassing the blood-brain barrier. It delivers medications directly into the intrathecal space and mixing together with the CSF. And this is achieved via an indwelling catheter connected to a programmable pump, which may be implanted or may be external. So what are the types of intrathecal drug delivery methods? I bring to you three main types. The first two types are external, and the last type is implanted. So the most simple method of delivering intrathecal medications is via an externalized intrathecal catheter. In some parts of the world, you have specialized intrathecal catheter, whereby the material is it's more long lasting. But in many parts of the world, we don't have such intrathecal catheters, and some of us actually use or modify the use of an epidural catheter for that reason. Now, it's intuitive that an externalized intrathecal catheter cannot last for long. So if you're dealing with a cancer patient with a prognosis of up to a month, this technique can be considered. Now, the second technique is a Porter cath. Now, a Porter cath means that you are linking an intrathecal catheter to a port that is usually buried in the subcostal margin. Now, that picture B is what an intrathecal Porter cath looks like. So the technique of introducing an intrathecal catheter is no different from method A, but now you're going to tunnel the intrathecal catheter and connect it to a Porter cath. Now, this technique is also partially external because the connector to the pump is via a butterfly needle inserted into the port here. Now, if your patient has a prognosis, your cancer patient has a prognosis that perhaps up to about 3 months of life, then a Porter cath intrathecal technique can be considered. Now, both A and B, whether it's an externalized catheter or an Porter cath catheter, they are connected to an external pump. So your driver for your medication is via an external pump that looks like the one in the picture. In this case, my favorite is a CADD Solace. Why? Because it allows micro dosing, which means a small dosage of 0.1 mil for each bolus. The next and the last technique is a completely internalized or implanted intrathecal drug delivery device. The one that I use is from the company Medtronic, the Synchromed 2. Now, you see this implantable pump here. It comes in two sizes. One is a 20 mil reservoir. The other one is a 40 mil reservoir. It is programmed via a programmer. In the past, it's an Envision. Today, it's an iPad. And then a patient is given a controller if boluses and rescue doses are required. So the three methods ways to deliver intrathecal drugs into your patient's intrathecal space. So I always use a case study because that's the best way we learn. We learn from stories, right? So Mr. Su is a real patient of mine with hepatocellular carcinoma. He's a 74-year-old Chinese male, stage 4 hepatocellular carcinoma, non-resectable, underwent 2 courses of cytotoxic chemotherapy already, and immunotherapy trial also 2 cycles. You can see that he has metastasis to the sacrum. So he presented at this admission with severe lower back and buttock pain, unable to sit, unable to stand. He tells his relatives and his family, "I just want to die." He was already on parenteral oxycodone, 180 milligrams a day. He was on PCA dose and quickly converted to a PCA pump, 180 milligrams a day. However, he was developing a lot of nausea, dizziness, vertigo, and still in a lot of pain. So in your mind, already formulate how would you manage this patient's pain? How would you plan to control his pain better? Well, very good technique is, of course, radiotherapy, because you see that it's a focal, a localized bony mat. So radiotherapy is actually a very effective tool to consider. And that's the first thing that came to your mind. Very good. One thing to note, pain relieving effects of radiotherapy can take up to 2 weeks to achieve that maximal effect. But in this patient's case, he had already undergone 1 round of radiotherapy. And due to the effects on his bone marrow, he was suppressed in all 3 cell ranges. His hemoglobin 7, platelets went down to 35, and his neutropenic as well. So unfortunately, we can't repeat another series of radiotherapy. This is where we have to consider intrathecal opioids. In the past, intrathecal opioids had been viewed as salvage therapy, meaning when all else fails, it's something to consider. However, we need to know that intrathecal therapy can improve pain care and increase functioning in patients who do not obtain adequate analgesia after a reasonable course of systemic opioid therapy. So, what are the indications for intrathecal opioid therapy? High tumor mass, chronic post-surgical pain in some cancer patients. We have patients with diffuse metastatic disease, patients who responded to systemic opioids but were unable to tolerate the doses required for sufficient pain relief, and poor response to systemic opioids, but may benefit not only from a change in the route of administration, but also a change in the mechanism of action. There's a 6th point that I would consider, in that maybe it is not only a nociceptive component, but a neuropathic component as well. So how to initiate therapy and what medications do we start with? So this is a picture of how the pump being inserted, and usually we choose the left lower quadrant of the anterior abdomen. This is the tip of the catheter. This is when the stellate is still in situ. That's why you can see a radio-opaque image here. Now, one question that in the past many didn't answer is that, does the level of insertion make a difference? Because you're thinking, okay, I'm inserting intrathecally. It's probably going to be a good mix into the CSF, and everything is going to just flow, and the whole body is going to get a very nice intrathecal block, for example. But no, recent work into CSF flow dynamics have shown that actually there's very little flow. In fact, there's very discrete regions of mixing, means very localized mixing only, with bidirectional cradiocaudal oscillatory movements of a little bit. So dispersion from the catheter tip within the CSF by slow infusion is very limited, depending on the chemical properties of the drug, as well as the rate and the volume being delivered. As there's very limited bulk flow of the CSF, there is at most 2 segments mixture above and below the tip placement. So therefore, site-specific catheter tip placement is very important for optimal pain relief. So just a ballpark explanation, suggestion if you are dealing with patients with middle or upper abdominal primary cancer. For example, in this a patient with gastric CA, then you may want to consider putting your tip at T8. If you have lower abdominal CA, for example, colorectal cancer with spread in the peritoneum, then you may want to site your tip at T10. In Mr. Su's case, sacral or pelvic metastasis, L1, L2, maybe even L3 may be warranted. So the medications to start with in my practice, I start with morphine, and this is recommendations from a polyanalytic consensus conference to intrathecal intrathecal medications. So morphine is my first line as well. Second line that is approved is bupivacaine, and the third line is clonidine. And the doses that we start with, apart from dose conversion, is 0.1 to 0.5 milligrams per day for morphine, and for bupivacaine, 1 to 4 milligrams per day. Now, mind you that if you exceed 3 milligrams per day with bupivacaine, you're going to get quite a bit of motor weakness. And for clonidine, if you exceed this dose of more than 20 micrograms per day, you're going to get some hypotension. So even though internationally 40 to 100 micrograms per day has been recommended, you probably have to do a bit of preloading for your patients. And you know that some of these patients are already very frail. So you're going to deal with quite a bit of hypotension. So back to Mr. Su. Parenteral oxycodone, 180 milligrams per day. This converts to morphine about 270 milligrams per day. Intrathecal conversion is about 2.7 milligrams per day. So if you opioid rotate, please do not start at 100 to 100 conversion. Start at 50 to 75% of the target dose, which works out to be about 2 milligrams per day. Use about 10% of that as a rescue bolus. And then give the patient some lockout time, give the patient sufficient doses to rescue his breakthrough pains. So in total, he may use up to 2.8 milligrams per day. Still pretty safe for Mr. Su. How do you titrate therapy then? So of course, if on a stable dosage of 2 milligrams per day, and if he doesn't use his breakthrough bolus, you're probably going to be pretty safe. But Mr. Su did use up to 2 doses per day. Mind you, you can start bupivacaine as your second line. Very often, I add bupivacaine already as together with my morphine when I first begin my intrathecal cocktail. Now, combination therapy. This is because combination therapy has been demonstrated to reduce the rate of dose escalation of your opioids when initiated at the onset of intrathecal therapy. And we know that bupivacaine is actually opioid sparing. So the higher the relative dose of bupivacaine, you may provide more stable pain relief. But of course, you bear in mind the need for some patients to still want to remain functional and ambulative. Pain relief outcome in intrathecal therapy, if you are mainly nociceptive because of the opioid intrathecal efficacy, is about 78%, almost 80%. But if it's primarily neuropathic, it's about 60%. Pain in the trunk, thorax, abdomen, pelvis being the most responsive intrathecal therapy compared to distal or peripheral limb metastasis. So Mr. Su, he used 1 to 2 boluses per day. You add that to your continuous infusion, that works out to be about 2.4 milligrams a day. And his boluses have been constant for the last 2 weeks. So after that, he stopped using his bolus when we increased the doses to 2.4 milligrams infusion. And he was still ambulating. He had no urinary retention and no bowel incontinence. Now, this is what the new iPad programmer looks like. So we changed Mr. Su's baseline infusion to about 2.4, 2.5 milligrams. We reduced his bolus dose to about 0.1 milligram, lockout time to about 10 minutes, and gave him about 5 doses a day. Now, this was stable. He hardly used his rescue doses. Now, in some more complex patients, this type of programming may not be sufficient.
Excuse me, Dr. Chua.
Yes.
We are in very shortage of time, please.
Okay, we're almost done.
Okay.
So in some patients, you may need a flexible programming. So to actually preempt certain points in a day where the pain is more severe. So in summary, intrathecal opioids should be considered early in cancer pain management. Type of intrathecal delivery depends much on prognosis and cost. If you're using an externalized catheter, prognosis is about 1 month. If you use a portacath, prognosis is usually about 3 months. And beyond that, you should consider actually an implantable pump. The tip placement is important as a predictor of efficacy. And combination therapy initiated early allows for better pain relief control. Thank you very much.
Thank you very much, Dr. Nicholas Chua from Singapore.
Thank you.
Yes, our next topic, recent development of spinal cord stimulation by Professor Ibrahim Ashik from Turkey. Dr. Ibrahim Ashik, Vice Chair, Turkey Sector, World Institute of Pain, Director of Multidisciplinary Subspecialty Pain Medicine Program and Allergy Department in Ankara University, Faculty of Medicine. He is the founder member of Turkish Neuromodulation Society. Dr. Ibrahim Ashik, can you hear me? Hello? Dr. Ibrahim Ashik.
Can you hear me?
Yes, yes.
Okay.
Yes, sir. Yes, sir.
Okay. Thank you.
Yes.
Thank you, Mr. Chairman. Thank you, all of you. I would like to thank the organizing committee and Mr. Sardar Kausar for inviting me to this distinguished pain conference for the first conference, I think, in Bangladesh and Society of Bangladesh of Anesthesiology. I would like to also thank the committee and the president. So this is my topic, as you already said that, and this is my disclosure. I have relevant practitioner consultancy and honorary relations with the Boston Scientific Company and Neurobio, which is settled in Turkey. So my presentation will be like that. These are the topics, and I'm going to talk about the definition of neurostimulation and mechanism of action, and how the neurostimulation evolved from 1967 to today, until today, and new targets, new stimulation paradigms, evidence, and I'm going to conclude with summary. We all know that the neurostimulation is adjustable, reversible, it causes no permanent damage. It delivers therapeutic electric current to the spinal cord, and it's effective on neuropathic pain. And we all know that it's a minimal invasive procedure. Where does it come from? What's the mechanism of action of electricity? After 46 years after Christ, Scrobius Largus first described the use of torpedoes, torpedo fish, which is aquatic animals capable of electric discharge for chronic pain. And until 1965, you all know that this is Malzac and this is Dr. Wolo Malzac, and proposed a gate control theory, which is very important in the evolution of spinal cord stimulation or DRG and motor cortex stimulation also. If you stimulate the thick fibers here, you can succeed to close the gate to thin fibers, which is pain fibers. You all know the A delta and C fibers, and you by this way you can control the pain and for chronic patients. What else other than mechanism of action of spinal cord stimulation? This is it causes dorsal column stimulation, sympathetic inhibition, spinal thalamic tractus inhibition. It has effects on spinal cord neuromodulators. It has also supraspinal actions. Other than that, it has also orthodermic effects and antidromic effects, which is important in deep layers on dorsal horn, lamina 5 and 10, and it has also pine fiber superficial to dorsal horn. The evolution of neurostimulation for pain started in 1967, which Shelley first implanted the first spinal cord stimulation. There was, between these years, there was only one company and 4 contact leads. And between 1999 and 2007, there were 3 companies and 8 contact leads. And after that, between 2007 and 2013, there were improvements in battery leads programming. And then between 2013 and 2015, paresthesia-free stimulation introduced. As you all know, that the Neuro company introduced the paresthesia-free stimulation. And after 2016 and beyond, you know that DRG stimulation, tree modulation, ultra-low energy, high-density stimulation, and other forms of stimulation are in the market right now. What's the how evolved the leads for SCS? First there were 2 contact systems, then 4 contact systems, and 2 4-contact and 2 8-contact systems. 16 contact leads were in the market, and finally percutaneous laminotomy leads. This is from Abbott, St. Jude, and DRG leads are on the market right now. I don't want to talk about all the specifications of IPGs here, but you know that there are 3 main companies in the world, which is from all of them from the United States, and it's Boston Scientific, Medtronic, and Advanced Neurology Systems, which is now Abbott. And Medtronic used constant voltage, and Advanced ANS used constant current, which is Abbott, and Boston Scientific used both of them. There are also new companies occurred in the market right now. And you know that between 2013 and 15, the Neuro has emerging, and they used high frequency 10 kilohertz stimulation. And Saluda is from Australia. They used closed loop systems, which the brand name is Evoke. And the Nuvectra is Algorita, the brand name, and 24-channel SCS in the world. This is the first 24-channel SCS. And finally, there's Stimwave, which has a wireless system. They use wireless system, and they both can conventional stimulation and high-frequency stimulation also. I know this slide, and I think that you know the slide more than 10 years. And this is the feature indications right now on the right-hand side. You see that, and most of them are already in use in the 2020 right now. When should we implant and think about spinal cord stimulation? We should think about spinal cord stimulation if everything fails, which means after level one pain therapies and level 2 pain therapies, you should think about spinal cord stimulation at the level 3 therapies with neuroablation, surgery, and implantable drug pumps. This is a good website for patient selection. This is scstool.org. You can check your indications with your patients here. It's high quality implant techniques, good follow-up arrangements and programming. You can also find choice of available SCS equipment there. We have actually 2 major indications, which is first is failed back surgery syndrome, and the other one is CRPS1, which is reflex symptom dystrophia. These are the most evidence-based indications right now. And the contraindications are, as you know, that use of anticoagulant, infection, and estimated survival time, physical or mental disability to use the device. What our treatment goals are, we want to specifically stimulate those areas of neuropathic pain, nothing more, nothing less. We want to cover all of the neuropathic pain areas, and we want to selectively stimulate the pain fibers, no more. And we want to control the therapy over the long run, which is sustainability, and predict the most possible outcome in our treatment. These steps in neurostimulation, as you know, after diagnosis, you put trial electrodes, first of all, for 2 weeks or 4 weeks, up to 4 weeks. And then if everything's okay, you can implant the IPG, and after that, you can adjust and follow up. We have to choose the right device for the right patient. If the patient has simple and unilateral pain here, as you see, and it needs low energy consumption and less patient compliance, you can choose non-rechargeable IPGs. If the patient has complex multifocal pain, as here you can see, and it needs high energy requirement and more patient compliance, if everything okay, and you can choose rechargeable IPGs. What are the indications of neuromodulation, and then what are the targets for chronic pain? The first, you can stimulate motor cortex and brain stimulation, and peripheral nerve stimulation, and peripheral nerve field stimulation. And the main target is the spinal cord stimulation, which can, here you can stimulate the dorsal column, stimulation of the interspinal nerve roots, and stimulation of dorsal root ganglion. This is the new era of first part, and our targets are DRG, as I mentioned about that, vagal nerve stimulation, sphenopalatine ganglion stimulation, trigeminal system stimulation, neuroevolution for joint pain, occipital nerve stimulation, and application of novel waveforms for 2 peripheral targets. These are the alternate intraspinal targets for spinal cord stimulation, and you can stimulate cervicomedullary junction stimulation, which is evidence-based method 2C+ here, for management of head and facial pain. And you can also stimulate DRG, which I'm going to talk later. And this is conus medullary stimulation 2C+, and you can get pain control for pelvic pain and no undesired paresthesia. So what's DRG stimulation? What you do is dorsal root ganglion houses the primary sensory neural cell body. When stimulated, it can block or help to filtrate the transmission of peripheral pain signals to the central nervous system. When you stimulate the DRG, it has upstream vasodilatory effects, and downstream the activation of synthesized wide dynamic range neurons, and stabilize effects at the peripheral synthesized nociceptors. And it also modulates the supraspinal brain regions. It's approved in 2016, and indications are various indications, especially post-surgical groin pain, and knee pain, post-mastectomy syndrome, chronic visceral pain, post-tracheotomy syndrome, and so on. You need to know the fluoroscopic anatomy in order to implant DRG. This is the pedicles here, and these are the DRG roots, DRG L2, L3, L4, and 5, just beneath the pedicles. So in order to be successful before the implantation of the leads, you have to get the relevant stimulation with the classic stimulation in the same relevant dermatomes before the implantation of the leads. An electrode is placed right here on related spinal ganglion, just here. With one electrode pressed, this is achieved only one single dermatome. Don't forget that. For wider painful areas, multiple electrodes are needed. For example, for here and for here and for here, that you need four contacts electrode. On average, the DRGs, an implanter needs to perform between 5 to 10 cases to become fully proficient with the implant technique. This is very important. After dorsal column stimulation, at least I think that for at least 50 cases, you need to try DRG stimulation. It's also good for painful patients with monoauricular or limited numbers of affected dermatomes. This is the accurate study. This is the most known study in according to DRG for CRPS, and it's here DRG is compared with tonic stimulation, And the responder rate is 3 months is 81%, and for DRG, and for 12 months, 74% of greater successful compared to tonic stimulation. So DRG greater improvements in quality of life, and it causes less postural variation and less reduced aberrant stimulation in painful areas. This is about these studies about non-operative discogenic low back pain, which DRG were used, and it found to be very successful. I'm not, as I'm going short of time. I have no time to talk about that. But just to remind that DRG is used for T12 for axial low back pain here, and for 17 patients, stimulation results in reduced pain and disability while improving quality of life. And DRG is also used for chronic hip and knee pain. These are the studies, and most of them are found successful in these indications. And DRG for peripheral neuropathic pain also found very successful in these studies. The StimWave, you know, StimWave is wireless systems. There's a standard antenna and the remote antenna. There are two systems. And when you compare the conventional stimulation to the wireless system, conventional has 3 components and wireless have 1 component. Conventional is MRI compatible. Wireless has 1.53 Tesla compatible. There's IPG here. There's not IPG here in wireless systems, and of conventional you need to use 14G needle, tunneling, anchor, and IPG packet. But in wireless system, all you do use 14G needle and anchor. So this is the 4 contacts StimWave electrode, and there's antenna is here, and this is a microcircuitry, and this is a transmitter that can talk to the electrode. You see here. What else is new in spinal cord stimulation or peripheral nerve stimulation? This is a peripheral neuromodulation system. This is BioStim router. This is also wireless. An FDA cleared implantable device indicated to treat chronic pain of peripheral nerve origin. It's a minimally invasive lead implant procedure performed under oculus anesthetic, and no implantable pulse generator, and its pain management is also controlled by the patient. So this is a new system. This is the evolving area. And you can use it for shoulder pain, ankle pain, and knee pain, and hip pain. What's the new era? Second new era is device programming in electric fields with SCS patterns, type of tolerance, of feedback control of neurostimulation. System miniaturization is very interesting, and optogenetics is also very interesting also. We all know that spinal cord stimulation waveforms. This is conventional tonic stimulation, and this is burst stimulations, and this is a high frequency stimulation. And we know the programming, we can resemble the amplitude, which is current intensity, volume control, pulse width with the number of speakers, and frequency is bass treble control. And this is a high frequency spinal cord stimulation. It's the company is Nervo, and the sensor studies utilize the stimulation frequency of 10 kHz found superior pain relief when compared with tonic low frequency stimulation. So pain relief was maintained 2 years, so very important. You know all burst stimulation. What this burst stimulation is? After 5 burst stimulation, there's a latent period. Interburst frequency is 500 Hz, and it's effective in axial pain, and it causes no paresthesia. Here, the studies indicate that the result of the study, stimulation of 40, 50, and 500 and 1,200 Hz and bursts are equally effective in relieving neuropathic pain related to CRPS. And relevantly, Dr. Ritter found that 10 kHz and burst SCS might both modulate the medial pain pathway and could be fundamentally similar neurostimulation designs, and they are both effective, similar effective. Burst stimulation is the Sunburst study is the largest randomized controlled trial comparing burst versus tonic stimulation for treatment of neuropathic pain of the trunk and limbs. And they found that burst SCS to be significantly more effective than conventional SCS. 60 versus 51 success rate. After 1 year, 88 subjects had improvement in VA score that persisted for both groups, with 68 of patients, using burst stimulation as the most used program. I'm going to talk about the high density stimulation. What's high density stimulation? It's the percentage of stimulation, density of stimulation during the stimulation time. Here you can see this is 2% frequency, and this, if you increase the frequency, you can get 10%, and if you increase the frequency, you can get 20%. And if you increase the pulse width, you can get from 2% to the 25% or 50%. If you combine both of them, you can get 25 to 24% of high density stimulation, and it is really increased the decreasing of pain by this way. And in the study, the neuropathic pain suppression is significantly enhanced with high density stimulation in 30 patients with failed back surgery, CRPS, and neuropathic pain over a measured period of 12 months. I want to talk about closed loop technique, and this is, you know, that this is Saluda. Its company is from Australia.
Excuse me?
Yes, sir. Yeah, I'm going to, yeah, first 3 or 4 slides.
Yes.
This is uncontrolled fixed output stimulation without regard to dorsal column response. This is open loop technology, and this is a closed loop technology designed to maintain target DC activation of levels continuously, which is optimized for maximum SCS inhibitory effect and reported pain relief. So this is how it works. It captures the ECAP, evoked compound action potential, and compare amplitude with the set point, and calculate new stimulation current, and it generates a new stimuli. So every stimuli is changing one by one and every second. And this is a study that found that it's very effective. System miniaturization is another topic. Is that you see that a neural dust miniaturization of systems that can be powered externally can be used, and optokinetic approach to modulate specific cells can be used also. And do you see that this is a sphenopodin ganglion stimulation, all in one small stimulator designed specifically for this disease. And optokinetic approach to modulate the neural functions, and you see that we stimulate the electric stimulation and inhibit the pain fibers, and you can, by using specific wavelengths of light by optokinetic inhibition. For example, for here, the yellow light inhibits the pain. Optokinetic excitation is to make the pain here. As a summary, PNS and DRG promising techniques alternate spinal targets for new stimulation parameters, burst and high density, and high frequency is another option. We all know that. Closed loop technology propose another point of view to us, but further studies are needed. And miniaturization optokinetics are exciting. You know that. These two therapies are provided templates for increasing the smaller devices or non-invasive therapies that do not require surgery. So, what's the future? As you all I think that all of them are watched the trilogy of Back to the Future trilogy, which is the actor Michael J. Fox in 1965. The future was 2015, which is 5 years past already, and he was remember that he's going to future and back come to the normal life, right? No, but he doesn't know that he's gonna be get the disease Parkinson and stimulators implanted in his brain for DBS. Thank you for watching.
Thank you very much, Professor Ibrahim Ashik, for his excellent and very informative lecture. And our next topic is knee pain and role of the radiofrequency. Now, our next speaker is Dr. Rohit Lahori from India. Dr. Lahori, in charge pain and palliative care, Government Hospital, Gandhinagar, Jammu, India, Nodal Officer for Palliative Care, Jammu and Kashmir, Faculty to Interventional Pain and Spinal Center, Delhi. Can you hear me, Dr. Lahori?
Yes, sir. Yes, sir.
Yes, please start your speech.
Am I audible?
Yes.
Right.
Yes, you are audible.
Okay. For inviting me to conference. It has been really a great time. Since last year, I was in Bangladesh attending the same conference.
Yes.
Okay. So my topic today is the knee pain and the role of RF. As you know, there are a lot of causes for the knee pain, and main causes for the knee pain are because of the aging, injury, repeated. Am I audible? Am I audible?
Yes, you're audible.
Okay. The main reasons for the knee pain are aging, injury, and the repeated stresses. Okay. Here, there could be a lot many causes for the knee pain, but we are focused today only about the osteoarthritis of the knee pain. So the three large categories are the conditions that block the normal synchronizing motions, and the conditions that produce the abnormal pathway of the motion and condition, and the condition that causes the stress concentration resulting into the changes of the articular cartilage. So if we see the pathophysiology of the osteoarthritis, we can see here there's a degenerative joint changes happening in that is characterized by progressive loss of the articular cartilage, followed by the attempted repair of the articular cartilage, remodeling and sclerosis of subchondral bones, and in many instances, formation of the subchondral bone cysts and osteophytes. So if we go to the exact ideology of the chronic pains in knee, that is osteoarthritis, if we talk about the chronic pains, it's a major public health problem. And the symptomatic knee osteoarthritis present to around 20 to 30% of the elderly population, around at the age of 65. And out of that, also there's a Dutch study which says around 20% of the females are affected with the osteoarthritis above the age of the 60, and around 13% of the males are affected also. So what are the symptoms of the knee osteoarthritis? Could pain, stiffness, joint instability, functional limitation, and muscular weakness. So if we take the three things in together, so the lateral tibiofemoral here, the patellofemoral, and the medial tibiofemoral. So you can see the patellofemoral component is more. The medial femoral component comprises of the 10%. The lateral tibiofemoral component about 1%. So the maximum is the patellofemoral component, but they are all overlapping each other. So the patellofemoral and the medial tibiofemoral component, they overlap each other and make a 50% of the bulk patients into it. So if you find the medial tibiofemoral osteoarthritis, anteromedial pains will be there, and the pain will be more on the walking. And in case of the patellofemoral, there will be a localized anterior knee pain worsening and negotiating on the stairs while climbing or coming down of the stairs, and the sitting that is relieved by standing and stretching of the legs. And the posterior part of the knee pain usually are coming from the posterior cysts. So you can elicit the tenderness here. If the tenderness to palpation is there, and if you can find the tenderness to the palpation along the joint line, and it could be more a issue of a capsular or intercapsular origin, or the point tenderness, if you find on the side, it could be more of a periarticular lesion. So the clinical diagnosis, we all know, the clinical diagnosis are very specific. You can do an röntgenogram and you can find out the exact grading of the osteoarthritis. Here we have labeled as grade 1, grade 2, grade 3, and grade 4. Exactly what happens, there's a doubtful JSN and the possible of osteophytic lipping here. But in grade 4, you can see the large osteophytes are there already, and the space is sclerosed. And not only the sclerosis is here, there's a definitive bony deformation also.
So they are the grade from grade 1 to grade 4. So conservative approach, if we take off, the conservative approaches usually are weight loss, physical therapy, analgesic drugs, intra-articular injections, steroids, prolotherapy, ozone therapy, PRP, viscosupplementation. But they usually fail at the later end of the day. Some of the patients might be responding for some time, but usually they come up with. So we have what new technique coming up before total surgical intervention, that is a TKR. So what we are going to do is a radio frequency ablation, or what we call as a genicular neurotomy. So this is one of the favorite topics of the newcomers in the pain medicine. So what are the indications for the radio frequency ablation? This is usually the high-risk cases with multiple comorbidity who are poor candidates for TKR. Remember again, I am repeating this again. The high-risk cases with multiple comorbidity who are the poor candidates for TKR are one of the main indications for the radiofrequency ablation. The patients want to avoid the TKR, or the patients fail to respond to the conservative treatments, long conservative treatments, and are still reluctant to go for any other invasive procedure other than the radiofrequency, or persistent chronic knee pains post TKR. This is very important again. The last one, the persistent chronic pains post TKR. So in 1982, Candy et al. Proposed the articular nerves of the knee and said there are two form groups in the articular nerves. So one group is called as the anterior group, the other is called the posterior group. Anterior group anatomy is very important if you are going to do a radio frequency ablation. So when we are talking about the anterior and the posterior group, so anterior group is femoral nerve, common peroneal nerve, the saphenous nerve, and the posterior group is obturator, tibial, and sciatic nerve. This is again, I have given a representation, a diagrammatic representation. According to the Hilton's law, the joint tends to be innervated by the articular branches of the nerves that supplies the muscles that are crossing over the joint. So if we say the sciatic nerve is usually, it extends along the thigh and up to the popliteal fossa. So what it gives at the popliteal fossa, it gives two branches. One is called as the tibial branch and the other is called the common peroneal branch. So tibial branch further gives the projections which usually give the innervation to the articular surfaces. And in common peroneal nerve, the articular branches are usually from the inferior lateral aspect of the articular capsule and anterior lateral side of the articular capsule. So this is one of the diagrammatic representations I have given here. So this is different nerves that are supplying the joint. So here, this one view is a medial view. This view is an anterior posterior view, and this view is a lateral view. So you can see the articular branches coming down and they're innervating the joint along the articular vessels. So if we have to do a radio frequency ablation or genicular neurotomy, so what are the two techniques that we can use and apply? So one is a fluoro and the other is an ultrasound. There's a lot of debate on the fluoro and the ultrasound. Should we go for the fluoro or the ultrasound? Both have their benefits, and there is certain limitation for both also. If we go for first of all, what we need to do is, before doing a radio frequency ablation, we always have to go for a diagnostic block. So for diagnostic block, we do the same genicular nerve blocking, but the diagnostic block has to be either done by under fluoroscopy or under ultrasound guidance. And what we do is we anesthetize the branches of genicular nerve. These genicular nerves are exactly just near the periosteum of the bone, and we focus our nerve, have a tunnel vision, and put our needles there, and to anesthetize the genicular nerve, we put about 1 ml of 1% of bupivacaine or 1 ml of 1% lidocaine can be injected here. The important thing is the pre and post operative assessment of the visual analogous scale from 0 to 10 has to be taken where 0 represents the no pain and 10 represents the maximum pain. So pain relief of more than 50% is always considered positive for the neurotomy. Based on the results of the nerve block, the patients can be taken for the further RF of the genicular nerve. So this is the role of the RF. If we This is one of the studies I want to share with you. This was a prospective randomized comparison of the effects of ultrasound with fluoroscopic guided genicular nerve blocks. And it was a study was done and published in Pain Physician 2019. And the study shows that there was no difference of NRS and WOMAC scores. They were observed between the two groups at the baseline and during the following up follow-up periods. And the complications were also same. So if we are going to do a genicular radio frequency ablation, we have a standard radio frequency and we have a pulse radio frequency, and then we have a cooled radio frequency. Here I'm talking about the standard radio frequency. So in standard radio frequency, what we are doing is we put a 22G RF needle in the active tip of 100 mm, and it is inserted for the predetermined entrances, which I have already mentioned. The needles were advanced while maintaining the contact with the bone. The position of the needles are confirmed in the lateral fluoroscopic view, because you always have to do an anterior and the posterior viewing, because the needles, when you are putting the needle, it always have to be in the mid diameter of the bone. So insertional point is 2/3 anterior and 1/3 posterior of the femur and tibia. So electrodes are placed in the RF needle and is connected with the RF generator. Motor and both sensory, motor at 0.5 volts and sensory at 50 volts, stimulations are applied to each genicular nerve to ensure the correct positioning of the needle. After ensuring the motor stimulus was not received until the 2 volts, the RF frequency degeneration is done. So before RF application, 2 ml of 2% looking at both the sides. In fact, on the 3 sides, what we are doing is superior medial, on the both superior medial, superior lateral, and one on the inferior medial side. What we do is we have to inject the 2% of lignocaine administration at all the sides, and this is before the RF, and you have to do the RF at 80 degrees centigrade for 60 seconds. I usually give dexamethasone 10 milligram per ml with at each sides to prevent the post RFA neuritis.
Excuse me, Dr. Lahiri.
There's a lot of controversy.
You have only 2 minutes.
Yes.
You have only 2 minutes more. Yes.
Okay. So there's a controversy between the cool RF and the standard RF. So if we take the cool RF, there are a lot of studies that are coming up for the cool RF. I just want to give you a brief summary of the 3 studies. One study is this. Another study has been done in cool RF again for the chronic osteoarthritis knee. And the third study has been done for the radiofrequency ablation of chronic pain in the total knee orthoplasty. So if you see all these studies, so the summary of all the studies and the resultant outcome of all these studies is that the radiofrequency, particularly the cool RF, has done really good, and the pain has really decreased. They have assessed the pain at 1 month, 3 months, 6 months, and 12 months. The pain score has virtually gone down. The WOMAC score for all the patients have virtually gone down. The visual analog score has virtually gone down, and the mobility of the patient has increased. The confidence of the patient has increased. The muscular strength of the patient has increased, and the patient is somewhat pain-free. His WOMAC and all those scores have drastically come down. So in the summary, what we can say is that RF is a very good and a new innovative modality for the treatment of the knee joints. So these are my references.
Thank you very much, Dr. Lahiri, for his nice and very informative and very scientific presentation. And now our last topic in this session, the post-surgical chronic pain. Our speaker, Dr. Laxman Desanayak from Sri Lanka. Dr. Laxman Desanayak, consultant anesthesiologist and in charge of pain management unit, National Hospital of Sri Lanka.
Hello.
Laxman?
Yeah, can you hear me?
Can you hear me? Yes. Yes, sir. Okay. Can you start it?
Yeah.
You can start your lecture, sir.
Hello. Hello,
Yes.
good afternoon. Good evening, everybody. 1 second, please. I would like to thank College of Anesthetists Bangladesh for giving me the opportunity to do a presentation with these eminent speakers from all over the world. My topic is post-surgical pain management, chronic post-surgical pain. Being an anesthetist, I'm very interested on this topic. So in my short presentation, I would like to talk about the epidemiological evidence of chronic post-surgical pain, and I would like to describe the mechanism of chronic post-surgical pain and transmission from acute to chronic post-surgical pain, and what are the early interventions we could do in terms of prevention of this problem. And I also would like to give some evidence, what are the available current evidence in prevention of post-surgical, chronic post-surgical pain. So what is chronic post-surgical pain? It's a system, it's a disease in the central nervous system, can present either as intractable pain post-operatively or persistent pain after surgery. It's actually epidemic, which is not well recognized almost all over the world. Is well under-recognized problem. So about million of people worldwide affect this problem. So why we should be worried about this problem? Disease prevalence has not been changed over the decades. It is increasing, and no difference between outpatient and inpatient patients as well. So only positive is in minimally invasive procedures can reduce the incidence of this problem. So like any other chronic pain conditions, diagnosis should be made accurately. So diagnostic criteria is published by International Association of Pain. It defines the chronic post-surgical pain as pain should be developed after surgical procedure. And it should be a chronic problem, lasts more than 2 months. Some book describes 3 months duration. So in addition, we should exclude other pre-existing pain-related problems like fibromyalgia. So other causes for the pain should also be excluded. For example, malignancy, chronic infection, which can mimic the post-surgical pain. So why we are worried about this problem? It is a common problem, but Sri Lanka, we don't have our figures in March, but in the UK figures, patients coming for pain clinics, about 22% patient post-surgical patients are suffering from chronic post-surgical pain syndrome. In our national hospital figures, in my pain clinics, it is about 2% of people coming to as post-surgical pain, maybe under-reporting and under-estimation. So the risk factors, what are the risk factors for this problem? So easily we can divide preoperative risk factors, intraoperatively and post-operative risk factors. Preoperative risk factors are intensity of the preoperative pain. If the patients are suffering pain preoperatively, the chances are very high for patients like who are having fibromyalgia or patients coming for acute cholecystitis for the cholecystectomy. And patient age, extremes of age are more prone to develop this problem. So book also describes genetic susceptibility, though there are not very conclusive evidence. And patients' cognitive and behavioral pattern, anxiety, fear, or anger also important as a predisposing factor for the post-surgical pain syndrome. Some people have unrealistic belief about the outcome and negative mental setup for the surgery. So these patients also at a higher risk. Intraoperative risk factors, the type of surgery, because the problem are different from type to type of surgery. Each and every surgical procedure does not get a similar incidence of post-surgical pain syndrome. Complicated and low surgery at a higher in the list. If the surgery take more than 2 hours or 3 hours, the risk is higher. Repeated surgery and unnecessity of the surgeries has to be decided. Most of the surgeries, if you are doing repeatedly, they develop post-surgical pain syndrome. So unnecessary surgeries sometimes should be avoided to prevent this problem. Post-operative factors also important. Out of these, severe unrelieved pain, post-operative pain is the main factor, the determination of the outcome. Bleeding, infection, and adjuvant therapy also matters. So little bit about the pathophysiology of post-surgical pain syndrome. So like any other neuropathic or chronic pain conditions, there's a peripheral sensitization, central sensitization important in the pathophysiology. When there's damage to the nervous tissues, there's a release of mediators, so many mediators, and there's a continuous irritation of the nociceptors, which sensitize the peripheral nerves, which cause the peripheral sensitization by reducing the threshold and increase responsiveness of the nerves. So these nerve impulses cause continuous bombardment of the dorsal horn and the spinal cord level. So, and it also inhibit the inhibitory impulses coming by A beta fibers and descending inhibitory pathway, so that pain get exaggerated and become central sensitized. So there's a progressive increase in the responsiveness on the second order neurons. This is called winding up phenomenon. It is a crucial factor in chronic post-surgical pain. So winding up is play the major role in chronic development of chronic post-surgical pain. So in addition, there's ongoing activation after injury, so that receptive field of the neuron get expanded, so leading to spreading of the pain. What are the factors very important in conversion of the acute post-op pain into chronic post-surgical pain? They say about 10% increase the time spent in severe post-op pain is associated with 30% increase in the chronic pain after 12 months after surgery. So as I told earlier, the persistent pain during perioperative period is the main factor in developing post-surgical pain syndrome. There are so many articles published, development of risk indices and prediction of chronic post-surgical pain. So important factor is preoperative pain lead to acute post-operative pain. So pain is the main predictor, nothing else, for the development of post-surgical pain. So this graph shows you that what are the main factors. In fact, acute post-operative pain shows highest risk of developing chronic post-surgical pain. So in addition, other factors also contributing to a lesser extent. So rather than treating this condition, prevention is very important. So prevention-wise, preemptive analgesia and preventive analgesia is the main important factors. Preemptive analgesia means we block the signals, pain signals reaching the central nerve system before the injury occurs. So that we can stop the development of central sensitization. So preventive is use aggressive multimodal analgesia, including nerve blocks, throughout the perioperative period and to the post-operative period for the prevention of development of post-surgical pain syndrome. So preemptive analgesia remain attractive hypothesis, but there are no conclusive evidence regarding the effect on CPSP. Preventive analgesia has a very good evidence, including using multimodal drug therapy and epidural and the peripheral nerve blocks. It started during perioperative period, continued to the post-operative period. So in the preventive analgesia, there is multimodal analgesia. We can use the drugs which can peripheral level, which can act the central level and the spinal cord level. So there are so many options we can try, including local anesthetic, infiltration, non-steroidal anti-inflammatory drugs, and the epidural analgesia at the spinal cord level, and the central level, the tricyclic antidepressants, SSRIs, serotonin reuptake inhibitors, and that this brain level modulation and the cognitive behavioral therapy. So these are the type of the blocks and the interventions we can do during perioperative period to reduce the incidence of chronic post-surgical pain. So transabdominal blocks is used for the abdominal hysterectomy and cesarean section, even any other major bowel surgeries. Brachial plexus blocks, including interscalene blocks for the shoulder pain, shoulder arthroscopies, shoulder surgeries can be used, and axillary blocks, as you know, for the hand surgeries. Sciatic and the femoral blocks can be used, and paravertebral block for the breast and the thoracic surgeries has shown very good outcome.
Excuse me.
Yeah.
Dr. Tisanayak, we have been shortage in time. You have 2 minutes more.
Yeah, okay. I'll finish it quickly. What are the clinical evidence of the current evidence of preventive techniques and medication? Use of gabapentin has good evidence to reduce the postoperative chronic pain syndrome. There are several studies done on this, and they have shown that reduce the incidence at 10 weeks postoperative period. Gabapentin can be used as a single dose or a multi-dose in with multimodal analgesia. Also, continuous paravertebral block with acetaminophen has been used successfully. Has been used in the breast and thoracic surgeries and has shown a significant effect. So, in addition, effective use of perioperative epidural analgesia reduce the acute and chronic pain, especially the thoracotomy and laparotomies, major abdominal surgeries. So epidural analgesia is shown to be superior to the PCA, patient controlled analgesia, in the thoracotomy and colectomy and amputation surgeries. So there are no conclusive evidence about the cognitive therapy and psychological interventions in prevention of chronic post-surgical syndrome. But there are important evidence in careful dissection and nerve sparing techniques and the minimal invasive surgeries such as laparoscopic surgeries and using the lightweight machine inguinal herniatomies. So these are the techniques can be used to reduce the surgeons can use these techniques to reduce the incidence of chronic post syndrome. Colonoscopies, hernias, breast colectomy, these surgeries, laparoscopic and minimal invasive techniques has to be used. Right. At last, about the treatment option in this, like any other conditions, the chronic conditions, treatment is very important for the improve the quality of life of the patient. Not only a human thing to do, it is really important in terms of pain, chronic quality of life improvement. So according to the WHO ladder, you can use the analgesics, but it should be individualized plan according to the patient. So it should be multimodal pharmacology interventions. I'm not describing what are the drugs we use. We can use from this, depend on the patient, whether it's nociceptive pain or neuropathic pain, we can select the drug which is suitable. There are non-pharmacology intervention as well, preoperatively psychological preparation, psychological techniques, whole compression after knee surgeries. This methods can be used even though there are no very conclusive evidence. Right. And the other interventions are regional blocks. Regional blocks depend on the type of problem, chronic surgical pain, limb pain or amputation pain, you can use the femoral sciatic block, or if the patient is having after inguinal herniatomy, you have to select the correct type of blocks. Even the breast surgeries, paravertebral block can be used. So in addition, in a severe chronic post-surgical pain syndrome, previous speakers also mentioned about the spinal cord stimulation and intrathecal pumps would be there would be option. Right. At last, I'll like to tell chronic post-surgical pain syndrome is a complex matrix of interacting factors such as psychological, social, surgical, anesthetic, central nervous system, and genetical involvement. So, at conclusion, I will have to say it is an emerging disease, but can be a silent epidemic. Most perioperative management may reduce the incidence of CPSP, such as minimally invasive surgical techniques, aggressive perioperative multimodal analgesia, including epidural or nerve blocks. Appropriate management acute pain is not only human obligation, but also may help to prevent the chronic post-surgical syndrome. Thank you very much.
Thank you very much, Dr. Deshanayake, for his nice presentation.
Thank you very much.
Yes. After finish the all topic, now I would like to request our honorable chair, today's chair, Dr. Nafisa Khanum, to deliberate her comment about this session. Dr. Nafisa Khanum.
Please unmute. Please unmute before you talk. Nafisa.
Yeah. Madam, can you hear me?
Okay, he can't. So.
Hello.
Am I audible?
Yes.
Okay.
Start,
Thanks.
please.
Good evening. I want to thank all speakers for their very informative and excellent presentations. Thank you, Dr. Anwar Samhari, for your excellent presentation on use of ultrasound for carpal tunnel syndrome. Ultrasound guided interventions has brought the pain physicians one step forward. Thank you very much for your presentation. Our second presentation, Professor Sang-Hui Lee, has delivered a very nice presentation on sacral epidural laser decompression of lumbar disc herniation. One thing is very important here. Before doing SELD, we should keep in mind about the contraindications such as calcified disc, foraminal disc protrusion, etc. The disc should be hydrated, and about transsacral laser epidural decompression, he said, according to him, there may be headache or neck pain, and then one should stop the procedure. Thank you, Professor Sang Chui Lee, for your nice presentation. Our third presenter, Dr. Nicholas, thank you very much for your valuable presentation on intrathecal analgesia. For continuous intrathecal analgesia, we should make a choice between delivery system because it is very important. The cancer patients usually want to stay at home, and so it may change the preferred place of death for the patient because external devices can't be, the caregivers can't manage them. So we can choose the delivery system according to the patient. Thank you very much, Dr. Nicholas, for your very nice presentation on intrathecal analgesia. Our fourth presenter, Dr. Ibrahim Ashik, has presented us about recent development in spinal cord stimulation. We should keep in mind about the type of device. The implantable device should be MRI labeled. I think so. It should be MRI compatible because it will remain there for a long time and patient may need MRI. So we should think about that also. Thank you, Dr. Ashik, for your nice presentation. Our fifth presenter, Dr. Lahori, thanks for your excellent presentation on radiofrequency for knee pain. Indication for the radiofrequency has expanded tremendously. But it was once used for only neuropathic pains, and now it is used for mechanical joint pain. Thanks, Dr. Lahori. You have shown us the selection of patients, and it is very important. We should, the post-TKR patients are the most suitable patients for radiofrequency ablation. Our sixth presenter is Lakshman Deshnayak. He has delivered us a very nice presentation on post-surgical chronic pain. It is very difficult to treat post-surgical chronic pain. It is a burden to society, and it is a burden to our family. It is a burden to the patient and also to the surgeon. My experience is there is increased incidence of chronic post-surgical pain in younger patients because peripheral nociceptive function decreases with increasing age. Okay, thank you very much. Thank you, everybody.
Thank you very much, madam, for your valuable comments. Our
thank you.
Next year, Professor AKM Akhtaruzzama sir. I invite sir for his valuable opinion. Professor AKM Akhtaruzzama sir. Sir, can you hear me? Sorry, you are not able.
I think Akhtar is not here.
Yes, sir. At last, I requested the more honorable and renowned Professor of Anesthesiology and our mentor, Professor Wahiuddin Mahmood sir, to deliver his valuable comments and conclude the session.
Thank you. Thank you, Dr. Habibullah. I think you can hear me. Good evening, everybody from home and abroad. Thank you. We had a very absorbing last about 1.5 hours. More than that, we started in the late afternoon. Now it's quite an evening. Anyway, good evening to everybody. Thank you very much. I think Dr. Nafisa has rightly summed up all the speakers. I will not go into it again. I'll just say a few words just about everybody. Dr. Anwar Ashraf from Malaysia, he had an excellent talk about, though it's nothing, this ultrasound in carpal is nothing new, but he had given something like dynamic testing and prediction of the treatment with ultrasound. That was quite interesting. The second was Professor Chang Chui Sang-Chui Lee from Korea, South Korea, who is a professor emeritus. He's a learned person. His example of the stone in the shoe for this herniation was very interesting too. But we have the limitation of this, transsacral epiduroscopic lumbar decompression. It has to be limited within 1 hour, and plus you can't use more than 200 cc of fluid, irrigation fluid, and using of the biluminal catheter with the Holcim laser. That was quite interesting. Our third speaker from Singapore, Nicholas Chua, that was also very intrathecal, using of intrathecal opiates, bypassing the blood-brain barrier, using either an internal catheter or an external with a pump. That was also very informative. Dr. Nafis has also pointed out the other points. Regarding our fourth speaker, Professor Ibrahim Azik from Turkey, his topic was recent developments in spinal cord stimulation, which had started back in late 60s and up to 2016. From 16, I think it has come to a stop. It has been developing for a long time. It can be adjustable and reversible also. Indications are all levels of pain, especially chronic regional pain syndrome. And recently, implantable device has been, what shall I say, cleared by the FDA, and different types of stimulation can be given. Our fifth speaker was from West India, Dr. Rahit Lahori. This is also very common thing, knee pain and role of radio frequency. It usually occurs in the aging, osteoarthritis. Most people who are more than 65, they have 30% are suffering from osteoarthritis, and diagnosis is clinical and radiological both. Interesting is the choice is those who don't want to go for total knee replacement, or the pain persists after total knee replacement. This is a very good, this ablation, genicular radiofrequency ablation is very good for that. And you can use both the standard or the cool RF, both. Then last but not the least was Dr. Lakshman Disnayak from Sri Lanka, who talked about post-surgical chronic pain, which is now almost in epidemic form. I was really from his talk that it's 22% in UK, which is quite interesting, but we don't have, in this part of the world, we don't have much statistics about that. He said that in Sri Lanka, it's only about 2%. Maybe it's underrated or it's underreported. Same, I think, in our country also, it's underreported. We don't have very statistics of that. And every treatment is individualized. He talked about different modes of analgesia, and everything is individualized. I think overall we had a very absorbing session from everybody, and thank you all the participants, thank you all the speakers. I think from my end, I would like to thank you again and say good night to you. Thank you.
Thank you, Professor Wahiduddin Mahmood, sir. Thanks all today's chair and all the eminent speakers and the guests from all over the country and abroad. Thank you very much to participate in this session. Now I would like to request Professor Kausar Sardar to start the next session.
Thank you, Habib, for your nice conduction, and special thanks to all the speakers and their very nice topic selections. And it was a fantastic lectures from all of you. And my apology from the organizer side, because we are 1.5 hours down from our schedule, and at the same time, my apology to the next speakers also. We could not maintain the time properly. It's a very difficult job to control the speaker, actually. It's a universal problem. So we are moving to our next session. This session, we have a very renowned faculty in this panel. We have 6 speakers. Just I'm looking for their presence. Professor Duraja sir is here. We are very delighted for your presence. Thank you very much to join us. And next, Thamasi Mokolo from Sri Lanka. Are you here? Just make a hi to all. Are you here? Or come on. Okay. Okay. So next is Abdullah B. Abul Khair from Saudi Arabia. unmute and just make a hi to all.
Hello.
Abdullah.
Hi.
Okay, thank you very much to join us. Next is Esalab Abdul Gadir. He will not join because serious problem about the internet service in Sudan. He is not able to join us this time. Next, TCT Nobi, are you here from Indonesia? TCT Nobi, just make a hi and open your video, please. TCT Nobi, I think she's here. Okay. Just open the video, please. TCT Nobi, you are unmuted, but can you open the video? Okay, I'm going to next. Gayani Walpola from Sri Lanka.
Hi, I'm here.
Okay, thank you very much. TCT Nobi, yes, we can see you right now. Thank you very much. Okay, good. So, Mohammed Shamsul Arifin is the moderator of this session. And I'm requesting Dr. Mohammed Shamsul Arifin to conduct this session. Arifin, please.
Thank you, sir. Thank you, sir. Assalamu alaikum and good evening to all pain physicians of Bangladesh and abroad. I'm Dr. Mohammed Shamsul Arifin. Welcome you all in this wonderful autumn evening to the 5th session of the second day of first International Conference on Pain 2020 organized by Bangladesh Society of Anesthesiologists, Bangladesh. I am excited to see so many pain physicians attending in this session. This conference could not be happened without your team support. Thank you very, very much for your great support. In this session, we have 5 topics for presentation, which will be delivered by speakers from abroad. Every speaker will get time for 15 minutes. I will give a reminder to every speaker 2 minutes before the ending of the session. If you have any questions, please put into the chat box and specify the speaker. And at the end, we have few minutes to discuss the question and answer. In chair, we have 2 honorable teachers. First, we have Brigadier General Razia Khanum Madam, MCPS, DA, FCPS. Madam completed her graduation from Chittagong Medical College. She was the advisor, specialist, and chief of anesthesiology, Bangladesh Army. She has special interest in management of critical pain. She published several journals in national and internationally. She is the author of textbook, The Essential of Anesthesiology, that I have read also. Other than that, she composes rhythms for children and admire beauties of nature. And second, we have Professor Mahmudur Rahman Khondokar sir. We usually know him as Laju sir. Sir has completed DA and FCPS. He is one of the beginner of pain management practice in Bangladesh. Professor Rahman sir trained advanced anesthesia and pain medicine in Japan in 1995. He first introduced thoracic and cervical epidural in anesthesia and pain in BSMU. There it was known as IPJMR in 1995. Founder member of BSSP, member of IASP since 2002. He attended first international course on pain medicine organized by IASP and ESSP in Spain. Works with NYSERDA from 2012. Now he is working as a professor and head of Northern International Medical College, Dhaka. He published 20 journals in pain and special interest in cancer pain management. Now I am seeking permission from our honorable chair to start the session. Raja madam, please. Can we start?
Yes.
Sir, will you start the session? Thank you, madam. First topic will be presented by Professor Dr. J.P. Durija sir on complex regional pain syndrome and update. Sir is the director of Delhi Pain Management Center. Dr. Durija was the first person to start dedicated pain management clinic at AIMS, New Delhi in 1984, where he worked for 20 years and later established Delhi Pain Management Center. Many of us went to his pain center and obtained fellowship from there. Now I'm requesting Professor J.P. Durija sir to present his session. topics.
Thank you.
Professor J.B. Dureja, sir.
Thank you very much, and good evening, everybody, all the delegates. It's a hybrid conference, and I must congratulate Dr. Kausar Sardar for organizing such a conference. Very, very important conference, and I think I must appreciate him. In these times when everybody is struggling with COVID, he could organize such a highly academic conference. And as his name is Sardar, in India we call Sardar is a person who is a leader. So he's a fantastic leader. So hats off to you, Kausar. Hats off to you. My topic is CRPS, and although it's a topic which, like all of you very well know, but I thought that there are some updates there are some things which have changed in the last few years. So I must tell you, and these updates have been in terms of hypothesis and in terms of management of complex regional pain syndrome. Now, all of you who are practicing pain would come across such patients in your day-to-day clinical practice. Like this is a patient whom you can see. It's a 48-year-old male who has complaints of severe wrist pain, and he gives history of trauma. He had a distal radius fracture, a very minor fracture. He had a POP cast, and after the removal of the cast, he has been suffering from burning pain, numbness, and tingling in the wrist area as well as going up to the elbow. And this happened immediately after the removal of cast. And such is the pain that it increases on touching the hand, and you can see the hand is dark. It is as compared to the other hand, swollen, and there is a weakness in the extremity. So this is like a classical patient. You can see two other patients who have complex regional pain syndrome. And as the name suggests, why it is called complex regional pain syndrome? Because it's a very perplexing, very challenging, painful syndrome of the extremities, and usually follows a very, very harmless event. Complex, why it is called complex? Because there are varied and dynamic clinical presentation. Why it is regional? Regional means if there is no dermatomal distribution, there is a non-dermatomal distribution of symptoms. And pain is out of proportion to the inciting event. So somebody twists your wrist and you get this very severe painful syndrome. And why it is syndrome? Because there are constellation of symptoms and signs. It is not just one symptom, but there are varied systems which are causing symptoms. So a typical clinical constellation, that is what the reason why it is called syndrome, is pain. There are sensory changes, as you see, paresthesia. Then there are autonomic, that's like vasomotor changes, edema. Then motor, atrophic changes. There is loss of muscle, there is a muscle wasting, loss of muscle mass, and weakness. And they cannot be explained by the initial trauma. That is the one challenging aspect of complex regional pain syndrome. These symptoms may spread distally, but are not limited to the innervation therapy. So very important that the problem may be in the wrist, but it can go up to the shoulder hand syndrome, which we classically call it. A word about the person who really thought about it, Professor Surek, and that's why in the initial days of my training, we used to call these patients suffering from Surek's atrophy. But very important that even in the 19th century, he suggested an exaggerated inflammatory response. And in 2020, we are coming back to the inflammatory response as the causative factor of CRPS, not just sympathetic nervous system, which we always believed in the last 20 years. John J. Monica, as you all know, is the father of pain medicine, and he was a person who promoted the term reflex sympathetic dystrophy. Although in the initial part of our training, we used to believe that it is a sympathetically mediated pain, but now we have started seeing patients, majority of patients may not be just sympathetically mediated pain, and that is very important. That's why I thought I'll talk a little bit about this so that you are very clear that what is causing complex regional pain syndrome. International Association of Study of Pain, which is one of our organizations which lays down the diagnostic criteria and definitions, had classified CRPS into two types. There, type 1, there is no nerve lesion, but a tibial injury, history of tibial injury, or maybe there is no history of tibial injury. But CRPS type 2 is one where there is a obvious or verifiable nerve lesion. And they have also said in the recent changes in the pathophysiology that 70% of patients report a primarily warm subtype. When you say warm subtype, that means there is inflammatory response or exaggerated inflammation. And remaining 30% are primarily cold, which could be because of the sympathetic overactivity. And this is what you see when you see your patient in the outpatient department. Patient may be having redness, swelling, and a lot of pain, allodynia, and hyperalgesia. And in the type 2, you will be seeing patients like with dystrophic changes, with atrophic changes, and such a severe allodynia that this patient, if you can see, is covering his wrist and hand with a cloth and putting water all the time, because that's the only thing which is giving him some relief. So that's a classical causalgia, where there is such a severe allodynia that even a whiff of air is causing pain. So what we have now understood, that there are two phases of this disease, which we had not understood earlier. And this has made our management little comparatively easy. One is the acute or the warm phase, where there are classical symptoms of inflammation. So if the patient has come to you in the first, second, third, fourth week of developing symptoms after a fracture, after a trivial injury, that's the warm phase, and you will feel all the signs and symptoms of inflammation. And that is the time when you take action against inflammation, you can get a better response, and you will not let this patient go into the cold phase. Cold phase is one which is characterized by atrophic changes in the soft tissue and bone. So the inflammation subsides, but it is overtaken by the atrophic changes, by the atrophy, by various deformities which happen in the joints. And of course, the localized osteoporosis, which we normally see in such patients. And that's one factor which really sort of troubles us when we are managing these patients. International Association of Study of Pain, in one of their meetings in Budapest, Hungary, they laid down these criteria. I think you can go to the literature because you may not be able to read all these slides. To say that at least one out of these three of the four categories, which has sensory, vasomotor, pseudomotor, and motor, and one sign. These are one symptom and one sign at the time of evaluation, two or more of these categories. If you have these one symptom in three and one sign in two of these categories, that means you are having a patient with CRPS. And then we have a CRPS severity score, which is again a latest addition to the complex regional pain syndrome, where there are self-reported symptoms and signs. So if there are self-reported symptoms and you count them, like temperature asymmetry, skin color asymmetry, sweating, so you just give one score to each of these symptoms. And these are 10 signs which you can give one score. And if your addition is 16 or above, then this is definitely a complex regional pain score. But if it is 10 and below, then that means you have to look for a differential diagnosis for the symptoms which the patient has come. So this is again a very important severity score. To confirm, although I mean we all believe that complex regional pain syndrome is a clinical diagnosis, and you have to sort of take a history and confirm it by your clinical signs and symptoms. But there are certain diagnostic tests which you have to do, which is basic like CRP to see inflammation, ESR to see inflammation, ANA. Because if I look back 30 years ago, most of these patients used to go to a rheumatology department because they used to have swelling in the joints and there was trophic changes. They couldn't move the joint. They thought it is rheumatoid arthritis, and they used to go to rheumatologists. And rheumatologists were perplexed that it is not fitting into the criteria. RF factor anti-CCP is negative. So that's why it is very important that you must rule out those important conditions and see. But the important tests which are useful to us is the triphasic bone scan, the three-phase bone scan, which really helps us, and then a simple X-ray of the hands and feet. And this is what you see. If you see the X-ray, you will see these are the osteoporotic changes which are happening at the level of the joints because the joints are not able to move. And in the triphasic bone scan, you can see there is in the third phase of the bone scan where you put in a dye and you take pictures, first phase, second phase. Third phase, the dye should have gone, but there is a pooling. This pooling is because of local osteoporosis. And this is particularly diagnostic of complex regional pain syndrome. So if you have any doubt, go for a triphasic bone scan. We have another test available, which is an infrared thermography, which is more used in research rather than clinical diagnosis. But this is one test which can really help us to see the affected limb, which is warmer, which is normal in the acute stage, and later it becomes cooler. So you can feel the skin temperature. It is very good for the prognosis for use using as a tool for your treatment. Like if you're given a stellate block or a lumbar sympathetic block, you do infrared thermography, you will see difference in color as compared to what it was earlier. So this is an important diagnostic test. But yes, we have problems in availability of this this machine. But once you have it, then it is a boon for patients of complex regional pain syndrome. So just to sum up, when there is an insult like a trauma, surgery, stroke, stroke is also a very important cause of complex regional pain syndrome. And you would have seen patients with stroke when they're sent for physiotherapy and they shout once the physiotherapist touches their arm. And initially we had no inclination or no knowledge that this could be CRPS, but nowadays post-stroke syndrome is almost similar to CRPS, is another thing which is coming up, and we have to treat those patients who are in severe pain as complex regional pain syndrome. So as you see, there's a classic inflammation in the first phase, which is called the acute phase, warm phase. Then there is a neurogenic inflammation, autonomic dysfunction, yes or no, maybe, central nervous system plasticity in the later stages, and of course the psychological factors. And all these constitute the signs and symptoms or the constellation of symptoms of complex regional pain syndrome. So again, this is just to emphasize that the initial pathophysiology is inflammatory. That's why your all treatment modalities in the acute phase should not be towards blocking the sympathetic nervous system, but allaying inflammation through the help of various pharmacological agents. And we have seen that there are like inflammatory mediators which are released. So exaggerated inflammation, not only by clinical observation, but in a lot of systemic reviews and meta-analysis, there are presence of pro-inflammatory state in the blood, in the blister fluid, in the CSF in patients suffering from complex regional pain syndrome. And not only one inflammatory profile, but different inflammatory profiles like TNFR2 or TNF bradykinin and lots of interleukins. Everything was found, which again signifies that there is an exaggerated inflammatory response. Yes, if I go back to 1985, when we used to treat CRPS as a simple sympathetic nervous system overactivity and target only the sympathetic nervous system. Any patient used to come, we keep putting stellate blocks, or keep giving lumbar sympathetic blocks. Yes, it is an important factor, but not in all patients. It is only in 30 to 40% of patients that sympathetic overactivity is a major cause, but in 60% patients, it is the inflammation, which is the primary cause. And that's why we have a sympathetically mediated pain and sympathetically independent pain. And of course, if you're not adequately treating, then the nociceptive sensitization, central in the spinal cord and brain, reorganization, and all these implicit learning processes, they develop. Inflammation moderates, and that adds on to the various morbidities which we see with the CRPS. For decades, as I said, SNS overactivity. Yes, clinically, it is supported by the presence of normal patterns of skin temperature, skin color, and sweating. And most of these symptoms can also occur, like edema, vasodilatation, can also be signs of inflammation. So maybe we were flawed by seeing these symptoms and only relating it to sympathetic nervous system. So that's very important. So one should not just simply target sympathetic nervous system. One should also look into the pathophysiology, measure some variables, and go in for management of inflammation.
Excuse me, sir, we have only 2 minutes left.
No, I have been given 20 minutes. You asked the organizer. So sympathetically mediated pain, multiple discrepancies undermine the possibility, like plasma catecholamines are lower. Most CRPS patients do not obtain significant relief from sympathetic blocks, and skin temperature does not correlate with the activity of the sympathetic system. So when we come to the management, it is if you have a variable pathophysiology, it cannot be just one simple management. So you have medical and non-medical, both for acute and chronic phase. Of course, physiotherapy, occupational therapy, anti-inflammatory therapy, psychological therapy, and of course, in patients with sympathetically mediated pain, sympathetic nerve block. Just to highlight, there's a very important role of steroids, bisphosphonates, calcitonin, and vasodilators such as nifedipine in the early phase. Antineuropathic agents like gabapentin and pregabalin also. And in the later stages, what we do in our clinics is continuous long-term ketamine administration, which is doing wonderful results in patients.
Sir.
Bisphosphonates are one drugs which can be given orally as well as intravenously, and they have to be used very, very early on. And then, of course, calcitonin, gabapentin, nifedipine can be used. And as regards intervention, because pain clinicians are always fond of intervention, like I said, sympathetic blocks, ketamine infusions, even in our time we used intravenous regional anesthesia like Myers block with guanethidine and beryllium. For the occupational therapist, we have the mirror therapy, which is doing wonders for graded motor imagery and, of course, spinal cord stimulation device. So, yes, repeated stellate ganglion blocks, repeated lumbar sympathetic blocks, and outcome of stellate ganglion blocks with a multiple therapy. The same patient you can see who had severe crossalgia is now pain-free and he's able to touch his arm. A word about ketamine therapy. Ketamine, there are lots of studies done and published in the literature which have shown beneficial effects, statistically significant reduction, not only in pain but also in other parameters. And that's how we have devised a protocol, which is important for all of you to know, that we give 1 milligram per kg in saline over 4 hours, and every day we escalate the dose by 0.5 milligram every day to a maximum of 7 to 10 days. And this is one particular ketamine infusion protocol, which really helps the patients, and we can reduce up to 40 to 50% of pain. This is for the old timers. If you have had guanethidine and serpine, you could give it in the regional areas and fantastic results. But obviously, we do not have guanethidine now, so we can't use it. Mirror therapy involves learning to adapt the mirror image. And this is one particular photograph which will show you that person tries to imitate the affected limb, has to imitate the normal limb, and they slowly and steadily, the brain changes takes place and they start moving the affected limb, which is very helpful in rehabilitation of such patients. So to sum up, this is the treatment algorithm for CRPS. Start treatment early, and then of course psychological pathways, rehabilitation pathways, they all constitute. But very important that in the acute stage, the inflammatory component, whenever there is edema, there's a role of corticosteroids. And if the pain becomes severe, then you have to use sympathetic blocks. If it is a sympathetically mediated pain, physiotherapy, of course, continues. If it is mild, just physiotherapy can help. But if nothing works, then you have to go for procedures like neurostimulation, etc. So the carry-home message is that complex regional pain syndrome is a constellation of symptoms which I have already highlighted. The CRPS population is heterogeneous and is a mixed pathophysiology. So no two patients of CRPS may have one pathophysiological symptom. Role of SNS as a major causative factor is now doubtful. So you may have 30-40% patients, but not more than that. And the future of CRPS therapy is a combination therapy incorporating pharmacology, psychotherapy, physiotherapy, and intervention. And ultimately, this combination itself alone can give you best results in CRPS. Otherwise, it's a very, very challenging disease, and you have to really work by your experience and get relief to this patient. Thank you very much. Thanks a lot. Thank you, Dr. Kausar, for inviting me. Thank you.
Thank you, sir. Sorry for the interruption. Thank you, Professor Duruja, sir, for his nice presentation. Now I'm requesting Dr. Thamasi Makululua from Sri Lanka. He will speak on established acute pain service in low and middle income countries, Sri Lankan perspective. Dr. Makululua served as a senior lecturer in anesthesia and consultant anesthetist attached to the Faculty of Medicine, General Sir John Kotewala Defence University, Sri Lanka. Now I am requesting Dr. Makululua to present his topic.
Okay, good evening to you. Can you all hear me? Good evening to you.
Yes, madam, we hear you.
Yeah. So I would like to take this opportunity to thank the Bangladesh Society of Anesthesiologists for inviting me to make this presentation in this international forum. So I'll be talking to you in the next 15 minutes on establishing acute pain services in low and middle income countries, the Sri Lankan perspectives. See the screen properly. Okay. Okay, sorry about the interruption. So during my presentation, I'll be focusing on the incidence of acute pain globally and in the low and middle income countries, the impact of unrelieved acute pain, the need for acute pain services in low and middle income countries, the aspects to be focused in establishing acute pain service and the challenges faced in these countries. And finally, the establishing of acute pain services, the Sri Lankan perspectives. If you look at the incidence of acute pain, globally, pain is an underdiagnosed and undertreated healthcare problem. The WHO estimates that 5.5 billion people, more than 80% of the global population, do not have access to treatments for moderate to severe pain. Among them, the majority live in low and middle income countries. We all know that pain is often undertreated and underassessed and undertreated in low and middle income countries. The situation has aggravated by increasing the number of surgical procedures.
Please increase the sound. Sound is very low.
Can you all hear me better now? Is it better now?
Yes, better now. Better.
Yeah. Sorry about it. Yeah.
Now it is very good.
Yeah, very good. Thank you. So this is it's been reported that pain is often underassessed and managed in low and middle income countries. The situation has aggravated by increasing the number of surgical procedures performed with increased requirements for post-operative pain management. So let's very briefly look at the impact of unrelieved acute pain in the population. We all know that pain is a presenting symptom of many diseases and cause suffering, immense suffering to the patients. It can lead to physical and psychosocial problems. Potentially, it can cause immobility and delayed recovery from surgery and trauma, with associated many complications leading to morbidity and mortality. And also, we all know that undertreated acute pain can lead to chronic pain conditions, as shown by one of the previous speakers. Apart from these physical disabilities, the untreated pain can cause psychological and social impact on the individual, the relatives, and on the whole society in different places. Right. Now, this is a study which was done to look into pain management in low and middle income countries. And they have identified few key points for poor pain services in low and middle income countries. And based on what they have found out, they have made recommendations to work towards increasing awareness, improving knowledge and attitudes, and make appropriate treatments available to achieve the best possible health for all these patients. This is another survey done by International Association for the Study of Pain, where they have looked into different barriers to good pain management. And they have listed in the order of priority the main barriers for good pain management.
which include lack of education, wrong government policies, the fear of opioid addiction, especially among healthcare workers and among the patients, and also poor access to different medications and different pain techniques, and also high cost of these analgesics, and also poor patient compliance with the medications and treatment interventions that we prescribe, and finally the limited facilities and resources available in these countries. This is another review where done by ISB, where they have shown a difference between what could be done to relieve pain and what is being done in developing countries, and they have shown a major treatment gap in achieving good results in managing pain of these patients. So they have identified the reasons for this treatment gap as poor education of health professionals, limited facilities for pain treatment, poor access to drugs for pain relief, and in the case of, especially in the opioids, there is often a high level of opioid phobia among the healthcare professionals. Now, this is another study where they have recognized that the solution to the problem of inadequate post-operative pain relief lies not so much in development of new techniques, but in development of a formal organization for better use of existing techniques. And therefore, acute pain services are being increasingly established to provide good quality post-operative analgesia. This again another study which shows the introduction of acute pain services has shown that the acute pain services has led to an increase in the use of specialized pain relief methods such as patient control analgesia, epidural infusions of local anesthetic opioid mixtures in surgical wards. Implementation of these methods may represent real advance in improving patient well-being and in reducing post-operative morbidity. So having seen the evidence in relation to pain services in low and middle income countries, let's see the aspects to be focused in establishing or improving pain services in these countries. We all know having a dedicated multidisciplinary team is very vital in establishing pain services in any setting, and this multidisciplinary team should be consisting of anesthetists, pain specialists, nurses, and all other healthcare professionals who are involved in managing these patients. And all these team members should aspire for excellence and good clinical governance. And they also should focus on the development of protocols, guidelines, the CPD programs, patient and peer education, record keeping, audits, and research in having a very good pain service in place. So this slides I have summed up the areas of focus in achieving a good team effort in having very good acute pain services. The multidisciplinary team is responsible for planning, organization, and delivery of pain services in any setting, and it's also responsible for developing protocols and guidelines for pain assessment and management. And they are also entrusted with the development of continuing professional development programs for the healthcare professionals to improve their knowledge, skills, and attitudes. And also now one should not underestimate the importance of patient education in improving pain outcomes in these patients. So they should be educated to self-assess their pain, and also about the drugs and non-drug treatment interventions they are being prescribed and their side effects, for them to identify them early and to look for treatment. And record keeping is also very important in a pain management service, where we need to maintain records of regular follow-up of clinical services and also all services provided through the pain services, in order to assess later on, evaluate the outcomes of our pain services. The audits are also very important in ensuring quality assurance of our services, and also we can conduct audits to look at the patient satisfaction and also to estimate costs of all clinical services provided through these pain services. So let's see the constraints or challenges in establishing acute pain services in low and middle income countries. Now these constraints again will be in relation to patients, related to society, the healthcare professionals, or to the availability of resources. Now here again I have shown on this slide the kind of challenges or constraints that we have identified in relation to different areas of pain services. First of all, the system. We all know that in low and middle income countries, we need policy changes to change policy changes to change the system to try and improve the services provided through the pain services. So these systems have low priority for pain relief. They lack coordinated services through different institutions in terms of in looking after these patients, and the people who look after these patients, they have no designated staff task, and also they don't maintain data or audits, or they do regular research to look into shortcomings of their services. Now, in relation to healthcare professionals, especially in low and middle income countries, there's a shortage of these healthcare professionals with very high patient to healthcare professionals with very high ratios, and there's a severe shortage with higher workload, and also it's worsened by their poor knowledge and lack of training in pain services. And additionally, some of them have wrong attitudes towards relief of pain. In terms of our patients, in people who live in these countries, some of them have lower expectations towards pain. Some of them are happy to accept pain as something that should be tolerated. Therefore, their false beliefs, myths, and attitudes should be changed through patient education programs, and also they have limited access to analgesics and other pain services, and therefore they tend to have more pain. And in terms of resources in these countries, it all depends on where the institutions are located. And we can see unequal distribution of resources and also limited availability of vital resources to manage the pain of these patients. And on top of that, there are specific issues related to the use of opioids. So any acute pain service model for low and middle income countries should be simple and cost effective to be useful. APS team should be motivated and enthusiastic with having diverse skills to achieve the goals of acute pain services. They should be prepared to have to change their attitudes if they do have wrong attitudes, and also they should accept that the pain relief is a right of all individuals. And they should implement regular holistic approach to pain management. It's not only the assessment of pain, the intensity or the severity, but they have to look at the patients on a holistic manner to try and identify their physical, psychological, and social impact in relation to underlying their acute pain.
Madam, excuse me, madam, you have 2 minutes left.
Yeah, so the patient education again is very, very important, and conduct regular clinical audits and studies, and the communication among different team members again is very important to come to collective decisions. And also quality assurance. In terms of quality assurance, they're supposed to maintain databases. And now in this team setting, the role of pain nurse is very, very important. They play a major role under the supervision of the lead clinicians.
Just look at the Sri Lankan context. Before establishing acute pain services, we had uncoordinated pain services where pain was managed individually where needed. Minimum multidisciplinary inputs were there with no holistic approach to pain management. The protocols and guides were not freely available. The analgesic prescriptions and administrations were irregular and on PRN basis. There was lack of knowledge, expert skills, inappropriate attitudes among the healthcare professionals, and there was no data keeping audits to assess pain outcomes, and no dedicated programs for education, skill, and attitudinal development. So let's see how we establish acute pain services. We identify the needs and areas of focus, and the proposal was developed and it was submitted to the Ministry of Health, and it was commenced as a national project covering all provinces in the country. And we were able to appoint pain teams, especially in the main hospitals headed by the consultant anesthetists. And in teaching hospitals, some of these consultant anesthetists were appointed as pain specialists, and there was a dedicated full-time pain nurses who are trained and appointed to these pain teams through the Faculty of Pain Medicine, College of Anesthesiologists and Intensivists of Sri Lanka. Regular educational and training programs for healthcare professionals were conducted, and initiatives were taken to develop skills of pain nurses as educators of patients and also their peers in other wards and in the hospitals, and encouraged to maintain records of patients, services, and resources, and also promoted the quality control through audits. So basically, here again, this is what we have done. We were able to bring in policy changes into the system by identifying pain management units in main hospitals in different provinces in our country. And we were able to establish pain teams under these pain leads. And then other facilities were made available, the infrastructure as well as other equipment and medications through the Ministry of Health, and we emphasize the need for continuing education of healthcare professionals involved in these pain services, and there were dedicated educational programs, workshops at national and local level were conducted, and we again emphasize the need for continuing with patient education programs to increase their awareness, for which we have promoted the people in the pain teams to come up with posters, banners, and to conduct exhibitions to keep the patients aware of ongoing pain services, and also databases of clinic and patient records were maintained to improve quality and to evaluate the pain outcomes. So this was what we have done in establishing acute pain services in our major hospitals. So in summary, so establishment of acute pain services is recognized as a stepping stone for improving standards of pain services in low and middle income countries. The committed inputs from a multidisciplinary team is emphasized in coordinating pain services while maintaining quality and safety of care. Dedicated skilled pain nurse can play a key role in the team under the supervision of consultant anesthetist or pain specialist. Continuing education and training of healthcare professionals is mandatory in improving the services. Regular evaluation of quality and services of our services is needed. And finally, awareness programs of patients to improve pain outcomes also should be given high priority in staying. These are my references, and thank you.
Thank you, Madam, for your informative speech. Now I would request to Dr. Abdullah be evaluating the pain patient. Dr. Abul Khair is the Deputy Chairman of Department of Anesthesia, Kingford Head Section Chronic Pain Clinic. He has completed his FAPP in 2015. Now I am requesting Dr. Abdullah B. Abul Khair to deliver his speech. Thank you.
Hello, everyone. Can you hear me well?
Yeah.
Yeah, so I wanted to thank you and the organizing committee for inviting me to speak. My presentation today is going to be a basic one about evaluating the pain patient. It's an important topic that I often talk about with my pain fellows and in the pain clinic, and I go back to this frequently. So today's outline, or what we're going to talk about, is the definition of pain, importance of pain management or chronic pain management, parts of successful pain evaluation, special tests you can perform, and investigations, and conclusion. So what is the modern or the latest definition of pain? It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage, and who have had pain for greater than 3 months. I was doing some research on pain in the area of the world where this presentation is going to be taking place, or where we're talking today, and what I could find was there was some evidence about prevalence of back pain. It was about 64% or 64.8% among Bangladeshi patients above 50 years old. And that's also along with what we have in our country in Saudi Arabia. And similar, about 40 to 50% of patients in this age group have chronic pain or chronic back pain. Also, another study saw the one under here, 36.6% among bank employees. Prevalence of low back pain was 46.6%. So it wouldn't be surprising to see that the prevalence of chronic pain was similar, throughout the world, which would be about 30 to 50%. So why is this important, or why is this an important topic? It impairs patients' activities of daily living, ambulation, affects their psychiatric mode, or can cause depression. It's a strain on the economy, leads to polypharmacy, cognitive decline, and also accidents. It's said that one MRI scanner is worth 100 neurologists or pain specialists. Somebody has said that before, and I'm against this, of course, totally. One physician of any specialty willing to sit and actually listen to the patient can be of more practical benefit than 100 magnets of any strength. And that's the truth, especially when it comes to pain patients. When we talk about pain patients, we look at what has happened, and usually the pain clinic is kind of where they end up after going through the whole hospital and having an operation, and then multiple types of intervention, and then they're like, okay, here, can you please take this patient? We don't want to follow up anymore, and it's like a train wreck. Starting with the pain history, it's very important to kind of delineate why the patient is visiting the clinic, or what they're there for. Sometimes it can be very confusing, and you don't know what came before what, but you want to know how the pain started, the location. Chronicity is a very, very important telltale sign of where the pain is going to go from after your visit with this patient. If they say it's been there for more than 20 years and it's on the whole side of the body, then most likely you're not going to make a big difference. However, you can improve their lives a little bit by coping mechanisms. Tempo, duration, and frequency. In trigeminal neuralgia, we see a lot of patients with electrical and lightning type pain that lasts only a few seconds, which is very characteristic. Associated factors are important. The pre-monitory symptoms and aura, precipitating factors, environmental factors. What did the patient do for a living? Family history. The age, pregnancy, menstruation, gender, the usual, different parts of your history that you're going to take. And every part is important. Everyone is equally important. That may give you more information on pain. Usually we use the brief pain inventory in our pain clinic, which is this one on the right. These are pain assessment tools that are used commonly, and they give you a good starting point to look at the pain initially when the patient first visits the clinic. And I think these are very, very important, because when you do an intervention or you give medications, then you want to follow up, and then you want to compare this compared to previous or future logs of this type of pain evaluation. good decisions come from experience, and experience comes from making bad decisions. And I've learned this the hard way. Some patients, you end up giving some medications that cause side effects, and or doing interventions that cause more pain. So it really, with time, I think it's an art. The practice of medicine generally, and also managing pain patients is an art as well. So keys to a successful interview: you want to make sure your surroundings are comfortable, professional, private, appropriately gowned patient, and if it's a female or a member of the opposite sex, make sure that you're chaperoned, sitting upright, eye level with the interviewer if possible. Old records and scans, radiographs, if you're able to obtain this before the patient visits or able to review before you see the patient, it is very important, and you want to try to listen to your patient. This is like the most important piece of advice I can give. Is if you sit down and just listen to your patient, I'm sure you can focus in on what is really, bothering them the most. Try to be non-judgmental. A lot of patients have a certain type of moral, religious, political beliefs. This should not interfere with your diagnosis or with your assumptions. Physician should be honest and open with the patient. You shouldn't hide a diagnosis. One of the cultural things that we see in Saudi Arabia that is very prevalent in our country is, especially when it comes to like end-of-life care and cancer patients, it's sometimes hidden from the diagnosis is hidden from the patient. That it's believed that it may make the patient's symptoms worse, and usually that leads to more unsatisfaction on part of the patient himself and more suffering. That's what I've noticed. So treat misconceptions of the patient themselves. They sometimes are reluctant to report pain. They see pain as a thing to be expected with aging or with disease, and fear of diagnostic tests and addictive medications should also be explained and discussed. Accept pain as an atonement for the past action. Some patients believe it's some type of treatment or bad result of an action that he did in the past. Build rapport with the patient by introducing yourself properly, taking an initial social history, simultaneously assessing the patient's mood, anxiety level. It's all these factors play an important role in developing a good relationship with your patients. And ask and use their name, actively listen, ask questions, show empathy, find common ground, follow the lead, and be genuine. A lot of the patients, they may know that there's no solution to their pain problem, but them coming to visit you and spending time with you shows that you are an important part of their treatment or their management. Most importantly, establish the chief complaint at the outset of the history. A lot of times the junior faculty may have problems with this because the patient will come in and they'll be complaining of all different things, and then when you focus in on one aspect, sometimes you can be able to help the patient, and some people get lost with reading everything in the history. Don't jump to conclusions. The examiner should ask about other doctors whom patients have seen in the past, other treatments that have worked. Determine the impact of the pain on the patient's family life, psychological life, and also compensation and work record. This is compensation is very important. A lot of pain patients may be teachers or construction workers. They may have some kind of secondary gain from getting a long vacation or from getting monetary compensation for the injury itself. May have legal implications as well. Obtain a thorough drug history. You have to know exactly what the patient's medications have been in the past, and side effects and uses and interactions. Some sample questions I've used regularly in the pain clinic, and sometimes when patients have difficulty describing the pain or explaining how it affects their lives, you can use some of these questions that may help. How strong is your pain right now? What was the worst pain over the last week? How many days over the past week have you been unable to do what you like or unable to take care of yourself or your home because of the pain? How often are you able to exercise? Interfere with your ability to think? Does it interfere with your sleep, appetite, energy, mood, personality, or relationships? Do you take, or how often do you take pain medications? And how would you rate your health generally? I just listed some of our common pain medications or opioids that we give, and then the non-opioid medications. These are the Schedule II narcotics are the most commonly given here. I would be, can't emphasize enough being familiar with this list, and what is available in your country and what you give regularly. Also, the common interactions that happen with other medications. A lot of pain physicians, are kind of uneducated or need more information about this type of management. And medications usually are a big mess. But I've used this website. It's called globalrph.com. It's a nice opioid conversion website. And a lot of times when we have patients with very complex opioids and we try to do opioid rotations or try to measure them, I would recommend using this website. Another tool to use when you're initially thinking about prescribing opioids for patients, whatever the opioid, you do an opioid risk assessment tool, such as this one, and you can give them a score of low risk, moderate risk, or high risk for their addictive tendency. And high scoring things on this would be previous substance or family substance abuse to prescription drugs, or alcohol, or illegal drugs. In your pain assessment, you want to believe the patient. This usually is me, and this is the patient. And it ends up, I'm on the floor here, and the patient is standing, and laughing about the things that I missed. The results of your physical exam are, this is just a joke. Results of your physical exam are fine, except for your reflexes. They're more dog-like than cat-like. Okay, so special physical examinations that you can do, and I'm focusing more on musculoskeletal exams that we do commonly in the pain clinic, and straight leg raising, sensitive for lumbar radiculopathy, crossed straight leg raising more sensitive, and we do this very commonly. Faber test for sacroiliac joint. You want to combine for sacroiliac joint inflammation or pain, this examination with others, such as the direct tenderness and Ganslin, facet loading, Sperling for cervical radiculopathy. These are all different physical examination. The basic labs, make sure to review all the basic labs. You can order some basic labs, look at for CBC, CRP, ESR. A lot of the referring physicians may have done all these tests before. Just have a second look, make sure they were appropriately interpreted and explained. Look at all your images. Chest, all the spine and lumbar spine x-rays and MRIs if available. Nerve conduction studies may be needed to determine the site of a nerve compression. So in conclusion, targeted and well-organized pain history is the foundation of a proper diagnosis. Targeted physical examination should be viewed as an extension of insights derived from the history. When you start out managing patients with pain, you kind of, are like an artist, and this is kind of the picture that you draw. And then hopefully with time, you end up drawing something more beautiful and more comprehensive and takes a lot more time and, is appreciated. The devil is in the details. It's very important to kind of nitpick on little details and look at every aspect of the pain history. Make sure to do some research if you can. Research is lacking, and we need a lot of more research in our countries to push the specialty of pain management forward. I encourage you to come to Saudi Arabia. Hopefully after Corona, comes, under control, then we can move around a little bit more. First, I would, go to Al-Ula. This is in the Al-Madina province, and this is one of the tombs of the area in Al-Ula called Al-Hijr or Mada'in Salih, which they recently opened. This is me. We also have some upcoming meetings in Saudi Arabia you may be interested to participate in or to, attend. This is the 14th International Saudi Anesthesia Society meeting on 4th to 5th of December. And it's all virtual. I'll also send the slides to the course organizers in case you're interested to know more about it. We have a Pain Society meeting as well in December 11th and 12th, our 10th scientific conference for the Saudi Society of Pain Medicine. And thank you very much.
Thank you, Dr. Abul Khair, for your nice presentation. Our next topic, piriformis syndrome and make it easy, will be delivered by Teresia Siti Novi from Indonesia. Dr. Novi completed her fellowship of interventional pain practice and certified interventional pain somnologist in 2017. She served as a pain specialist and pain unit Bandung Adventist Hospital and lecturer on Health Science College, Dharma Hudasa. Now I'm requesting Dr. Siti Novi for deliver her speech. Sir, Siti Novi, please unmute.
Can you hear me?
Yes, now we hear you.
Okay. Thank you so much, Chair, for the warm welcoming speech. I'm very honored and happy to be here with you all in the first International E-Conference on Pain 2020 organized by Bangladesh Society of Anesthesiologists. Although we can only do it virtually because of the pandemic situation. Hope that the pandemic will be over soon so we can meet physically. And I want to thank Prof. Kausar Sadar and colleagues who have invited me. I'm very honored and thank you. My colleague here send warm regards to you all from Indonesia. Please visit our country, our beautiful country. But before we stuck in the hallucinations of wanting visiting each other, let's start with the piriformis syndrome. Let it easy. Piriformis syndrome is one of the many differential diagnoses of low back pain, but it is relatively less known and underestimated because very frequently it is confused with other clinical pathologic conditions. As we know, piriformis muscles originate from we see the diagram here. This is sacrum, and this is ilium, and this is femur. Okay, the piriformis muscle originates from the anterior surface of the sacrum here, in between the foramina sacral first, the second, the third, and the fourth, and it will travel to the greater sciatic foramen here, and will insert to the greater tuberosity at the head of the femur. The function of the piriformis muscle is to do external rotation of the hip in the extended hip position and to do abduction in the flexed hip position. But then the external rotator of the hip is not only the piriformis muscle, but also there are 5 other muscles, including the quadratus femoris, the gemellus superior and inferior, and obturator internus and externus, which also acts as external rotator of the hip. So it's quite challenging to determine one patient got piriformis syndrome or other cause of low back pain, such as disc problem or facet problem or vertebral body problem, or even the ligamentous problem or muscles around the lower back and the buttock, including the piriformis muscle, including also the sacroiliac joint arthropathy. The piriformis syndrome caused by the piriformis muscle stiffness due to repetitive trauma from sitting for a long time and on a raw surface, pressing or pinching the sciatic nerve under the muscle. This condition will cause symptoms of sciatic nerve suppression or compression. You can see in the diagram at the right side that the sciatic nerve located below the piriformis muscle, but actually it can be inside the piriformis muscle and also above the piriformis muscle. So that's another problem of the diagnosing of the piriformis syndrome. Patients with piriformis syndrome will present with the following signs and symptoms, such as chronic pain in the buttock and hip area, pain when getting out of bed, inability to sit for a prolonged time, and pain in the buttocks that is worsened with hip movements. In a study of 112 cadaveric specimens, the diameter of the piriformis tendon varied between 3 and 9 millimeters. And we can see at the figure A to B that the insertion of the piriformis tendon to the greater tuberosity is varied also. At the first figure, this is the traditional anatomy of the piriformis muscle or tendon. At the B figure, you can see here that the piriformis tendon share insertion to the greater tuberosity with the gemellus and obturator internus. At the figure C, it shared insertion with the obturator internus and gluteus medius muscles. And at the D figure, we can see that it shared insertion with the gluteus medius. So that's the third problem. In my workplace at Bandung Pain and Rehab Center, we do research since January 2018 till now about piriformis syndrome. And in between August and December 2019, we got 164 low back pain patients. You can see here that we got 82 male patients and 82 female patients. And amongst them, there are 57 piriformis syndrome patients, male 30 and female 27. So it's about 34% of low back pain patients in Bandung and Pain and Rehab Center suffered from piriformis syndrome, and it's quite high prevalence. It differs from other centers, I think, and from the literature also. So that's why we do this research. From the literature, we know that there are several tests to confirm or to lead our diagnosis to piriformis syndrome, such as straight leg raising test, which has sensitivity 0.15 and specificity 0.95. One active piriformis test, the sensitivity is 0.78 and the specificity is 0.80. And the seated piriformis stress test 0.52, the specificity is 0.90. One active piriformis and seated piriformis stress test sensitivity is 0.91 and the specificity is 0.80. But not always that we got the positive test from the so many tests for the piriformis syndrome. So ultrasound appears to be a reliable technique for the diagnosis of piriformis syndrome. You can see here at the figure A compared to the figure B. The A figure is the normal piriformis muscle here, while the B is the piriformis syndrome muscle. It is thicker. At the figure C, we can see also this is the normal piriformis muscle. At the D, this is the bigger piriformis muscle suffered by piriformis syndrome patient, but not always that way. By doing ultrasound, We can also do the treatment for the piriformis syndrome by injecting the substances, either steroid or PRP or Prolo, other medication that is chosen to treat the piriformis muscle, the piriformis syndrome. By using the curvilinear probe, we put the curvilinear probe in long axis view to the piriformis muscle. Here, I will not talk too much about the technique, but the needle will be inserted into the piriformis muscle here. Okay, and it's not so hard to do it, but we must have a certain training to do that. I will show you a case about a male, 74-year-old male who has already retired and whose ADL, activity of daily living, is independent, which has chief complaint pain at the left buttock. The pain was radiating to the left calf since 3 weeks time. There was no numbness, but there's a tingling sensation at the left calf outer side sometimes. The urination and defecation within normal limit. The numerating rating scale of the pain at the left buttock is in between 5 till 6 at the rating numerating rating scale 0 to 10. There is no history of allergy, there's no history of disease, and he has already got potassium diclofenac 25 milligrams a day. From the observation, the vital sign was within normal limit. While sitting, there was pain at the buttock. While standing, there's no pain, and walking is okay also. At the back, there is no pain on movement. Can you imagine? No pain while doing extension, forward bending, lateral bending to the left and the right. No pain on rotation to the left and to the right. And there is no even pain on pressure at the lower back or at the buttock area. And from the lower back maneuver, you can see here that the straight leg resting were negative both sides. The Braga test, negative both sides. The Thomas test, also negative. The Patrick, Contrapatrick, and Piriformis test all was negative. So then, I do ultrasound piriformis scanning here at the right side. You can see here that the thickness, the right side is 1.40 centimeter, and the left side was 0.95 centimeter. Means that it is supposed the patient suffered from piriformis syndrome, but because all other examinations was negative, I gave the patient ultrasound guided interventional pain management diagnostic block to the piriformis muscle using lidocaine 1% only, 1 cc, and then the numerating rating scale become 0/10. So then I proceed with the definitive treatment using lidocaine 1% and triamcinolone 30 milligram, and then the scale became 0/10, and there was no pain when sitting. And I gave him paracetamol 2 times 500 milligrams, only 3 times, and follow up in 1 week. And after 1 week, there's no pain. So the take-home message is piriformis syndrome prevalence might be different from place to place, and the diagnosis is quite challenging, but it can be made easy. Okay, hope this presentation will give insight to all of us that the low back pain can be from the piriformis syndrome, which in our place is the prevalence is quite high. Please feel free to ask if there's a question. Thank you.
Yes, Arifin. Arifin, are you here?
Yes, sir. Yes, I'm here, sir.
Okay.
Thank you, Dr. Novi, for delivering a special and interesting topic. Our last topic will be presented by Dr. Gayani Walpola, Sri Lanka. She will deliver a speech on cancer pain management. Dr. Walpola is the consultant in pain management and pain unit and anesthesia at National Cancer Institute, Mahagarma, as head faculty of pain medicine. She is the author of Pain Chapter Non-Cancer Palliative Care Manual in Sri Lanka. She also contributed for Cancer Pain Management Guidebook in Sri Lanka. Now I am requesting Dr. Gayani Walpola to present her case. Thank you.
Thank you very much for the kind words of introduction, and welcome to the presentation on cancer pain management. Firstly, I would like to congratulate Bangladesh Society of Anesthesiologists for this event, and thank you very much for giving me this opportunity. This is the hospital where I'm working in Sri Lanka. This hospital caters its services island-wide in Sri Lanka. During next 15 minutes, I'll be doing magnitude, clinical presentation, assessment, and treatment of cancer pain. We all know during the cancer trajectory of illness, 55% of patients will get pain at any time. And when they become terminal with metastasis, 2/3 of patients will get pain. Out of that 2/3, 1/3 will get one type of pain, and another 1/3 will get more than 2 types of pain, and the rest get more than 2 types of pain. Unfortunately, in Sri Lanka, we don't have figures in numbers regarding the cancer pain prevalence. But patients present to us with acute pain, chronic pain, and even after referring to palliative care management and from the end of care management, these patients, anytime, they can present with as pain crisis. The origin of cancer pain, mostly 60 to 80% is tumor related, and 20 to 25% is any kind of treatment related, and 3 to 10% could be totally unrelated. Sorry, this is a bit busy slide, but when we try to analyze the mechanism of cancer pain, it could be nociceptive, neuropathic, or even it could be due to neuroplasticity or sympathetically mediated neuropathic, or any combination of any. For example, this patient can present as acute pain, acute on chronic pain, or even nociceptive, neuropathic, or a combination. Once the patient gets the surgery, can go into post-operative pain and can end up in chronic post-surgical pain. If patient needs amputation, can end up in phantom limb pain. Likewise, any patient can present with the metastasis and its as a complication pain, or pain due to paraneoplastic effect, and could be any kind of related surgery, chemotherapy, radiotherapy, or it could be indirectly related or totally unrelated. For example, when they are immunosuppressed, they can get post-activation of herpes zoster and can end up in post-herpetic neuralgia, or as I mentioned, could be totally unrelated. Anyway, when we get patients evaluation of the cancer pain, that it's our responsibility. The history cannot be replaced with anything else. We need to assess the pain, assess the mechanism of pain, assessment of other factors, and need to exclude red flags. When we are assessing pain, there's no any consensus between unidimensional tools versus multidimensional tools. And also among multidimensional tools, we don't have any consensus regarding this is the best multidimensional tool, because each and every assessment tool has its own advantages and disadvantages. So especially when it comes to palliative care pain, it's very difficult to assess even with using multidimensional tools. As I mentioned earlier, we need to assess the mechanism. And as clinicians, it's our responsibility to exclude red flags in all patients. It could be cancer-related or non-cancer related. And we all know chronic pain itself a disease which is described in ICD classification. When it comes to chronic cancer pain, invariably, they will be having physical, social, psychological, spiritual problems. The assessment of biopsychosocial model is very important. It may not only for the patient, and also there are lots of problems with the family too. So treatment, it is multidisciplinary, multimodal, patient-centered, and with best available evidence. And in management of cancer pain, even it should be patient-centered, maybe despite the best available evidence. So as I mentioned, we need a big team for us to manage this multidisciplinary pain management. The treatment could be non-pharmacological and pharmacological. So most of the evidence I'll be talking on acute pain management, scientific evidence by ANSCA. That is the latest edition 2020. There's a level 1 new evidence regarding the music interventions. And there's an unchanged level 1 evidence regarding the patient education about the cancer. There are lots of non-pharmacological methods available, which I'm not going to talk today. And the pharmacological treatment. We all know and we all manage these patients using the WHO cancer pain ladder. So there are, again, it's a busy slide, and there are lots of drugs available in this pain ladder. So what about opioids? Still, out of almost all the drugs, still, opioids has a major role in cancer pain management. Out of all opioids, still oral morphine remains the drug of choice for most of the patients. What about adjuvants? There's no any promising evidence regarding directly on cancer pain. But we all know the involvement of acute or chronic neuropathy with this cancer pain, and also the depression associated with these patients. So we all use most of the patients, anticonvulsants like pregabalin, gabapentin, and tricyclic antidepressants, non-steroid, the SSRI and SNRI antidepressant drugs for these patients. What about ketamine? Ketamine also doesn't give very promising results directly on cancer pain management. But we all know there's a very good evidence in using ketamine as preventive analgesia and to prevent post-operative, chronic post-surgical pain. So most of these patients need procedures and surgeries. So ketamine also, maybe infusion of ketamine also plays a role in cancer pain management. The lignocaine. There are so many literature and evidence available regarding the intravenous infusions of lignocaine in chronic pain management. We, in our pain management unit, we use 5 milligram per kg consecutive 5 days or an hour, and also consecutive weekly infusions, 1 hour infusions for 5 weeks of duration. And we are having very good results with this intravenous lignocaine infusion. And another important thing is, most of the data, it conclude the plasma concentration of lignocaine has never gone beyond the therapeutic level among in almost all these patients. So it's a good evidence that we use without even ECG monitoring these lignocaine infusions. But in our setup, we always take ECG prior to the procedure and exclude heart blocks. And also during the infusion, we monitor ECG in all these patients, but none of them have got the ECG changes. And we all know glucocorticoid steroids treatment has so many its adverse effect, immunosuppression like. But there are certain indications in cancer patients when they come with spinal cord compression and raised intracranial pressure. And bisphosphonate, that is also give promising results with complex regional pain syndrome, bone metastasis, and multiple myeloma. Maybe we have to use with radiotherapy for bone secondaries, and so bisphosphonate also plays a major role in cancer pain management in certain patients. And these patients can present as can have breakthrough pain. It could be spontaneous or incidental. So almost all the patients, it's our responsibility to pay attention on breakthrough pain, prescribe drug for them to cover the drugs to cover the breakthrough pain. When they come to us with acute exacerbation or pain crisis, it's always superior to use intravenous, subcut, and even patient-controlled analgesia for these patients. And though the combination of opioid therapy is not that popular, but some patients, the difficult candidates, we may have to use even when they are on transdermal fentanyl patches, we may have to use other combination of opioids. And certain difficult patients also we used opioid rotations. We all know about these opioid conversions, but the conversion should be carefully done. It is individualized because conversion ratios may be influenced by multiple factors, including the potency, the prior dosing, tolerance, and the patient's compliance as well. So most of these patients need surgery and procedures. So it's my responsibility to just glance through the perioperative analgesics. The most of the evidence are not very conclusive or very good to use in cancer pain. even non-steroidal anti-inflammatories, steroids, and opioids. There are so many studies showing the recurrence and increased metastasis. But at the same time, we know the stress response to surgery, the pain, cancer, everything also there's high risk of the metastasis. So when we are considering this drug, always we need to weigh the benefits and the risk before starting these drugs. But the local anesthetics
left 2 minutes.
Right, thank you. The local anesthetics, almost all local anesthetics are having the good results regarding the direct anti-tumor effects on cancer cells. So in our setup, most of the surgeries for almost all the patients, we do peripheral nerve blocks, plexus block, plane blocks to control perioperative pain, as well as when they come with acute exacerbation of chronic pain and neuraxial techniques. So we know there are so many blocks available. So I think most of the celiac plexus in and out, it is discussed by the previous presenters. So I'm not going to go into details. And out of most the interventions for sympathetic blocks, we practice stellate ganglion and celiac plexus block frequently. We used the celiac plexus block under ultrasound as well as under fluoroscopic guidance. We choose patients depending on the background and other complications. We decide the best method of celiac plexus block for these patients. And once the block is done, depending on the results, and we plan for the radiofrequency ablations. And though there are complications in the written literature, so if you select the patients, we can reduce the complications. And we are having, even after radiofrequency ablation, we got patients a burning pain for few patients, and we had to go lidocaine infusions to control pain in those patients. And our next step is to start epidural or intrathecal drug delivery system in our units. So these are my references. And thank you very much for patient listening.
Thank you, Dr. Walpola, for your nice and informative presentation. Now it's time for the chairs. Now I am requesting Professor Mahmudur Rahman Khondokar sir. Mahmudur Rahman sir, please.
Yeah, thank you. The total session is all presenters delivered their lecture very nicely. And the first speaker, Professor P.P. Tueja, I think it is he delivered a good in every points and the diagnosis and the treatment of the complex regional pain syndrome. And definitely our pain physician will benefit from his lecture. And I think no need to comment on his lecture. He's our close man, and occasionally he come Dhaka, and our people go there for learning. And I think his lecture is very nice. And next speaker, Malulua, acute pain service. It is a very important issue. Acute pain service establishment in every hospital. I think in our setup, it is a bit difficult. One or two hospitals, this program is going on, but most of the peripheral hospital is lacking due to lack of skilled manpower, lack of skilled nurses and equipment, and especially the drugs availability, especially morphine and use of morphine and their fear of use of morphine. That is important. Already she mentioned that it is very important. So this is another problem in our country. In working hour, daytime, manpower is available in hospital, but after daytime emergency period, less manpower. So 24 hours ensure of the acute pain service is very difficult. And our government policy is not clear about the acute pain service. We have done the personal we have the personal care of the patient, and it is very interesting. And every worker should devote it in this program. But otherwise, without devotion, you cannot success the program. I think nice presentation, and she details elaborately described this, and our pain physician will be benefited from our lecture. And another people, Abdullah Abu Khair from Saudi Arabia, is every line is very important. Evaluation of pain patient, and evaluation very important for the treatment and for intervention. And the repeated examination, repeated history is very important. We should give more time to the patient so that the diagnosis should be accurate, so the treatment will be accurate. So evaluation of the patient is very important, and patient history, examination, and the investigation. Very carefully it should be done. It's a nice presentation. Everybody should follow his lecture. And another, Gayani Olpal is a cancer, is very important topics. And I think if you compare the cancer treatment, actually our health provider, the person, the oncologist is the main factor for their maltreatment. Actually, they commonly did not send it to the pain physician, and most of the physician in our country, I don't know the others, I think the scenario is same all over the Southeast Asia. Most of the physicians fear to use narcotics, especially morphine. They don't. They are afraid to use more dose. They use the small dose, but they are fear to use more dose due to already mentioned, due to fear of addiction and depression. I don't think the morphine causes respiratory depression in cancer patient. In my experience, I use individual morphine and home-based treatment for months after months. I did not get any respiratory depression or any complication if I carefully check the epidural catheter before availability of the tablet in our country. But after availability tablet, but not still the lack of availability of morphine tablet in our country, especially some palliative care centers established in our country, and only 6,000 to 8,000 cancer pain patients can be treated with these centers. But we need 6 million people, 6 million people per year to deliver their demand for pain relief or palliative care. And intervention, very little person, very small, few percent population of the pain physician.
It's shorter. Okay.
Intervention. So it is not adequate. It is inadequate for our large population patient. Okay, thank you very much. Thank you.
Thank you, Lazi sir, for your nice opinion. Now, our Honorable Madam Brigadier General Razia Khanum to give her valuable opinion and conclude the session. Madam, please.
Good evening.
I must congratulate all the speakers. They highlighted how to lessen the pain and bring a smile to devotee. Dr. R.P. Dureda from India, he very clearly explained about the complexity of the regional pain. And Dr. Tamashi Makalula from Sri Lanka, she talked about the improvement of the standard of the pain services. And Dr. Abdullah from Saudi Arabia, he has evaluated the pain patients in Bangladesh. I must congratulate him again. And the fifth speaker was the Theresia Siti Novi from Indonesia. She also presented a very important cause of the pain, back pain, especially for those who work in a sitting condition. And Dr. Guani Walpola from Sri Lanka, she has given a very elaborate management of the cancer pain. So I think this was a very rewardable session. I again congratulate all the speakers and thanks them for giving time. And I also congratulate our moderators who has managed
Thank you, madam.
very nicely, and our organizers, and
thank you, madam.
The BSc president and the BSc general secretary, Kaushal Sharma. BSc president, I don't know whether he is here or not. So they all take a lot of pain to arrange this session. All credit goes to them. Thank you all.
Thank you, madam.
Thank you.
Thank you. We are at the end of session. I'm grateful to all speakers for their informative speech, and thanks to our honorable chairs for their giving time. Thank you again all. I think it is time to our next session. I'm giving the floor to our honorable Kaushal Sharma sir. Sir, please take the floor.
Okay, thank you very much, Arifin, for your nice moderation. And thanks a lot, all the chairpersons, and obviously all the speakers. All lectures were adequately brief, clear, and very sharp. And most importantly, very timely landed in this session. Thank you, all speakers. All participants have heard enough. Thank you very much for sharing your knowledge. We have been delighted for your virtual gracious presence. Thank you, all speakers. We are moving to our last session. In this session, most of the speakers from the North America and South America, because of time, it's a good time there. There is a good evening, good morning to all the speakers from US and Mexico. Now here is the good evening time. So in the next session, before going to the session, I'm looking for the speaker. They are here or not. Shri Pratap Singh Rana, are you here? Shri Pratap Singh Rana, my friend.
Yes, I'm here.
Okay, thank you very much. Next is Amitabh Gulati. I think he has joined. Amitabh Gulati, are you here? Just make a hi, hello to you.
Hello, how are you?
Yes, fine. Thank you very much. Okay. Next is Harvey Finkelstein. Sir, are you here? Yes, thank you very much. He was my examiner actually. When I passed my FIPP, in Miami 2014. He was my examiner on that time. Thank you very much, sir, joining us.
My privilege.
Okay, thank you, sir. And we have here Dr. Angel M. Jores Lemus.
Good morning from Mexico.
Okay, from Mexico. Okay. And Muralidhar Joshi, sir. Are you here?
Yeah, sir.
Have you joined? Okay, okay.
Very much with you.
Thank you very much. And we have Onadiotu Ben Jones, sir. He's the executive editor of Anesthesia Analgesia. Have you joined, sir?
I'm here. Good
Okay,
morning.
thank you. Good evening from here.
Good evening.
Okay, can you open your door, please? Can you open the video? Okay. Okay, thank you very much to join us. So I'm requesting Dr. Enamul Haq Milton. He is the moderator. He will moderate this session. This is the last session. Okay. Milton is here?
Yes, sir.
Okay. Okay, carry on, please. Carry on.
Thank you, sir. Dear respected chairperson, faculties and the speakers, and participants from home and abroad. Assalamu alaikum. This is evening in Bangladesh, so good evening to all, and good morning to USA, Mexico, and respective area. Good noon and good evening. And welcome to our last session and the second day of our first International E-Conference 2020. I am Dr. Enamul Haq Milton, consultant and pain specialist, and I am working in Dr. Milton Pain and Regenerative Center. And I would like special thanks to our beloved respected teacher, Professor Kausar Shabdar sir, and also enlight our Bangladesh Society of Anesthesiology for arranging such first international e-conference in this COVID situation. And it is a very great opportunity for our learning and change our visions in pain future. Now I am introduce our delight chairpersons of these sessions and humbly request all the chairperson to join and chair of these sessions. I like to invite Professor A.K.M. Shamsul Alam sir and Dr. Rodrigo Dice and Dr. Shamul Mitre. Can you hear me, sir?
Good evening, everybody. Can you hear me?
Yes, sir. We can hear you.
Thank you. Thank you.
Now I introduce our all the chairperson, Professor A.K.M. Shamsul Alam sir. He's a legendary anesthesiologist and iconic beloved mentor and ex-professor and head of the Department Anesthesia and Intensive Care, Chittagong Medical College. And I also introduce our another chairperson, who is the Rodrigo Diaz from the Peru, Pain Unit Coordinator, British and American Hospital, Lima, Peru, and he is the Medical Director, Center DMRS, Sports Spine and the Pain Center, Lima, Peru. And unfortunately, our third chairperson, Dr. Shamul Mitre, for his familial issue, he cannot attend with us. Sir, I request to Dr. Shamsul Alam sir.
No, Milton, can you make a hi hello from Rodrigo from Peru?
Okay.
Rodrigo.
Hello. Thank you for the invitation.
Thank you. Thank you, sir. With the permission of chairperson, can I start our introduce our speaker and topics? And I want to.
Please.
Okay. Thank you, sir. Thank you, sir. It is a very big session because we have 6 lectures in these sessions. Now, our first lecture. Before starting our lecture, I request to speaker, because it is a very compact schedule. You have got only the 15 minutes. I try to information to call you and at 13 minutes. And at that time and the whole lecture, I request to all speakers and all participants and everyone, please unmute yourself and enjoy the sessions. After that, you can input your any questions in the chat box. We will discuss after complete our whole lectures. Our first lecture, that is ultrasound guided interventions for the GI malignancy, and that is presented by the Dr. Shiv Prasad Singh Rana, India and consultant, Department of Pain Medicine, Pain Management and the Palliative Care, King Ahmed University Hospital, Bahrain, and Oncology Center, Bahrain. And he is a fellow of interventional pain practice from the USA. Now I request to Dr. Shiv Prasad Singh Rana, please share his screen and enlighten us.
Hi, good evening, everyone, and good morning, everyone, from wherever you are. Good evening, and thank you, Dr. Kausar, and the first Bangladesh International E-Conference on Pain 2020. Can you hear me very clearly?
Yes.
All right. And here we go. So we are talking about ultrasound guided interventions for GI cancer. So this is my overview of presentations, indications, technique, what is the evidence, and take home message. If we talk about the ultrasound guided iliac plexus block, then the indication is GI malignancy from gastric to mid-transverse colon, which includes not only from malignancy from liver, gallbladder, stomach, but also from pancreas, spleen, both kidney, entire small bowel, and the first 2/3 of the large bowel. It's a interesting topic, actually, all three, like celiac plexus, hypogastric plexus, and the ganglion empire block, which comes under the GI malignancies related interventions. If we talk about the celiac plexus anatomy, celiac plexus is a type of basically pair of 3 ganglion. This is a diffuse ganglion, so that's why you cannot do the radiofrequency ablation of this ganglion. Only option is doing either a diagnostic block or the therapeutic block. And the 3 ganglion includes the celiac ganglion, superior mesenteric ganglion, and the otorenal ganglion. And you can clearly see here the celiac plexus is formed in front of that is the dorsal of the aorta. There are only 2 structures that comes from the aorta, which is at the level of almost T12 L1, the celiac axis, and below one is the superior mesenteric artery. These are the 2 different structures. When we do the screening of the patients with ultrasound, then we see these structures. Okay. I think there is some disturbance. Are you able to see my slides? Hello?
No, sir.
I think there is some disturbance in.
We can see, but it is blank.
Okay, just let me open again. All right, so if we talk about the celiac plexus neurolysis, the patient's position is in the supine position, and when the patient is in the supine position, you have to do the screening with the translinear curvilinear probe, which is a low frequency probe. Then you have to
can you Shiv Pratap, can you double click on your presentation?
Oh yes.
Screen not share.
Okay. Double click on your ultrasound guided interventions. Yeah.
Are you able to see now?
Yes.
Okay.
Go
Yes.
for slide
You
show.
can just Slideshow.
Okay.
Go to slideshow.
Yet not. Click. Okay.
Okay, so when we do the screening at just below the level of the GP sternum, you see a vertebral body structures here, which is usually the T12 or the L1. This is aorta, and there is one artery coming from the aorta, which is the celiac artery, celiac trunk, which further divides into the common hepatic artery and the splenic artery. So this T-shaped structure is the area of interest for us, and the periceliac fat is the target for doing the right and the left side of the celiac plexus neurolysis for these patients. These are different photographs from one of the very good actually literature I have taken, and these are our pictures, like patient in the supine position. This is abdomen we are seeing, giving a local anesthetic solution using a curvilinear low frequency probe, usually 60 to 70 degree of angulation of the needle is needed. From the right side, you do the hepatic transhepatic approach. So the needle has to traverse from the from anything from the liver up to the celiac axis on the right side, and from the left side it is called the transgastric approach. And this is the dome of the medicine. You can say hyperechoic shadow here, just on the right side of the celiac axis. So this is the medicine we have already deposited there. You can easily project the direction of the needle as well as the tip, where exactly the tip is, because it is near the vascular structures. So the proper patient selection, coagulation profile has to be perfect. You have to choose a right indications to get a better result for these patients. If we talk about the evidence, we have published a few of the literature for doing the okay. We have published few of the literature for ultrasound guided celiac plexus neurolysis of the RCTs done in 2014 and 12, and the evidence is almost like 2B plus. There is one very good literature coming from JAMA 2004, which says like if we do in a well selected patients with carcinoma pancreas, the quality of life of these patients usually gets very much improved. Second plexus is superior hypogastric plexus block. The indication is pain originating from the pelvic organ malignancy, which includes bladder, uterus, vagina, rectum, and prostate. Where exactly is the position of superior hypogastric ganglion? It is in the anterior portion of the L5 and S1 vertebral body. So there are different methods described for CM guided, but for the ultrasound guided, we do the okay. I think there is some delay. For the ultrasound superior hypogastric block, usually you have to visualize the aorta at the level of umbilicus. You see the vascular structures, which is the aorta and the L5 vertebral body. When you see the vertebral body, then you see the common hepatic vein vessels, and you can clearly visualize the L5 vertebral body, which is the bifurcation of the aorta. So using a two needle approach or a single needle approach from anything from right or left side, you can easily target that structure. I think there is some issue with the presentation, actually the slides. It is not going properly, but I can clearly tell like the third plexus is the ganglion impaired block. Usually the technique we use for these kind of block is we go from anything from the transverse coccygeal area. You have to reach up to the anterior portion of the coccyx or the sacrococcygeal membrane. So what you have to do, you have to take either a curved needle, which is usually 120 degree needle, or the other needle you can put a Parker needle, which is usually a more like a 90-degree angulation as well as the 120-degree angulation at the tip. So when you do these kind of ganglion impart block, anything coming from the area from the tip of the coccyx and reaching up to the sacrococcygeal area, usually you have to target at the junction of the sacrum at the coccyx. There exactly is the ganglion. Sometimes you can go up to the C1 and C2, which is coccygeal 1 and the coccygeal 2 bone. So usually with these kind of combinations of different blocks, you can easily achieve a good pain relief following the GI malignancy cases. I had put actually some of the video, but I really don't know, whether there is any time issue. But let me just see. This is select plexus neurolysis, usually do in the supine positions. Probe is here. Here is the aorta, and this is. So you have to hold a steady hand so that to visualize the celiac axis. It's a T-shaped structure. Using a local anesthetic solution, you have to reach up to the target, and target is, so this is T-shape, and this is the needle trajectory coming here, and this is the end point. So when you put your needle up to here, so needle tip is here. When you are 100% sure after negative aspiration, then you do this technique. We have another ganglion, which is a hypogastric ganglion, and hello. So this is hypogastric ganglion block. What we see here is the vertebral shadow of the L5 vertebra. The common iliac vessels are here. You can use the color Doppler just to visualize the vascular structures. And using a local anesthetic solution, you have to go to the either from the inline approach or the out of plane approach for giving this nerve block. This is in plane approach. Usually 22 gauge Shiva needle is perfect to reach up to the target. Once you hit the vertebral, once you hit the vertebral, sorry.
Can you open it again? Your hypogastric block. This is not open. Hypogastric block. This PPT is not opened yet. Just double click on your.
Okay. Are you able to see now?
Not yet.
Okay, just let me do again.
Yes, it's all right now.
Okay, so this is at the level of the L5 vertebral body. You see a hyperechoic shadow here. Usually you see a bifurcation of the aorta. So the common iliac vessels will come into the picture. Either you can do a out of plane technique, or you can do, if you are not in the target of the vessels, you can do an in plane approach. In this patient, we have utilized the inpatient technique. You put a local anesthetic solution and then putting a 22 gauge Shiva needle. You have to reach up to the target, hit a vertebral body, and then you need to aspirate. After negative aspiration, usually in this 10 to 15 ml of 70% alcohol is our choice. So this is some sort of, straightforward techniques, but this gives very good pain relief to patients having pelvic organ or the carcinoma cervix patients or carcinoma genitourinary tract patients. And I think I am sorry because some of the slides I haven't shown to you because of some issues with the PPT. But I think that gives a clear picture that these kind of ultrasound guided techniques, they are safe. I'm doing these techniques for almost like 13 to 15 years. And so far I haven't done, we haven't encountered any of the complications except the routine side effects like the hypotension or diarrhea, which is common practice after select plexus neurolysis. Thank you very much.
Thank you, sir, for your nice space. Now, I like to request our next speaker, and our next topic is the advance in the intrathecal pump medications. I would like to request Dr. Amitav Gulati from USA. Can you hear me, sir?
Yes, can you hear me?
Okay, I introduce our today's speaker, Amitav Gulati, sir. He is the Vice Chair, USA WIP chapter, and the pain physician and working at the New York. And he is the Fellow of Interventional Pain Practice from the USA. Sir, now your time, you present your presentations. Thank you, sir.
Hello, everyone. Thank you to everyone on the committee for having me a chance to speak. And I hope everyone is safe. And welcome from the United States. What I wanted to do was spend a few minutes and talk about how our understanding of how the CSF flow has changed our knowledge of how to deliver the intrathecal medications for pain and for spasticity. These are my financial disclosures. And very briefly, we'll talk about the physiology of the cerebral spinal fluid, the CSF, and then talk about some of the historical things that have happened in our understanding of how some of the medications disperse in the CSF and how computer modeling has changed some of our understanding. And then just to explain how we can better use our intrathecal drug delivery systems for pain relief, both for chronic and cancer pain and spasticity. For those of you that are on a little bit of knowledge with intrathecal pumps, they are a pump with a reservoir. It holds volume of 20 milliliters or 40 milliliters. It's implanted in the patient right above the peritoneum, underneath the skin of the abdomen or the buttocks area. And there's a catheter that will go into the intrathecal or spinal space and at some location of the spinal cord. The benefit is I can deliver the medication such as an opioid, morphine, or local anesthetic, bupivacaine, or other medications such as baclofen, ziconotide, very close to where the spinal cord is, so they have less side effects throughout the body. Now, we are very familiar with how the pain transmission occurs, but just as an understanding of where some of our medications in an intrathecal pump work, this is just a description of the spinothalamic or the spinal sensory tracts. As the pain fibers come into the dorsal root ganglion in a nerve root, they go into the posterior rootlets of the spinal cord, and then they attach to a second order neuron, and then finally cross over to the other side, contralateral side, to go ascend up into the brain. This is important because certain medications can help stop the conduction of these medications, of this current or pathway. For example, if you place local anesthetic, bupivacaine or lidocaine here at the posterior rootlets, you will stop the conduction of the pain and sensory transmission of temperature along this location. Similarly, some of our other medications, such as an opioid or alpha-2 agonist, these connections are both occurring at the second order neurons as part of the descending inhibitory tracts. So if you want to use an opioid such as morphine, you would like it to activate the descending inhibitory tracts here at the second order neurons, similar to clonidine and similar to some other medications in this location. So as a result, it is important that the intrathecal pump can deliver the medication at the location of these neurons. And this is level dependent, meaning that the root number T6 is a different location than the root number T10. And if the local anesthetic is related to where the catheter position of the spinal pump is, that is where the catheter will have to be placed. And I will cover this in the next few slides. So we have had multiple publications just describing all the different medications we can use, all of the different medications in terms of which one is most appropriate first line, second line, third line, and then also for cancer pain, some recommendations. What I will talk about now is how the history of intrathecal kinetics has chosen which drugs we may choose for spinal delivery. And a lot of this work is originally from University of Washington, with homage to our colleagues, Dr. Yaks and colleagues in University of San Diego, California, San Diego. Nonetheless, a lot of this work was done first in the animal model, and this particularly is in the pig model, swine. And what we see here is a catheter that is placed in the dorsal column of the pig, and what you have is 4 different opioids: morphine, alfentanil, fentanyl, and sufentanil. The difference between morphine and alfentanil, fentanyl, and sufentanil is that the morphine is more hydrophilic. It likes water more. And therefore, it is likely to stay more in the CSF and then stay in the spinal cord. A little bit will go into the epidural space, and a little bit will go into the systemic circulation, the plasma as a result. So when you use morphine relative to alfentanil, fentanyl, and sufentanil, more of the morphine stays at the spinal cord. The alfentanil goes into the spinal cord very quickly. It leaves the CSF very quickly, but it goes in the epidural space and the fat very quickly as well. The fentanyl prefers to go into the epidural space and stay in the fat or go into the plasma. And the sufentanil, again, stays more so into the plasma. So what you can see from this chart is that the morphine, if you inject it intrathecally, will stay more in the spinal cord. The fentanyl, if you inject intrathecally, will act more like it's in the intravenous or the systemic circulation. This is just a graphical representation of the similar data. The most important point in this particular study was to show you that as you put your catheter in a certain location, for example, T11, what you will see is that morphine will stay more so in the intrathecal space, but no matter which medication you choose, the further away you are from the catheter, the less the concentration is of the medication, the opioid, in the intrathecal space, meaning that over distance away from the catheter, the morphine, the fentanyl, the alfentanil, and the sufentanil are in less concentration away from the catheter up and down the spinal cord. This is just a rehash of that particular statement, just explaining that as well. So how about bupivacaine, a common local anesthetic that we use for pain? This again is our colleagues at University of Washington in Seattle, Washington in the United States. What we see here is now using the animal model, the pig, and we put a catheter. We put the catheter in the pig. The pig is horizontal. And what we see here is we attach the bupivacaine to methylene blue that will stay in the spinal cord at the location of the spinal cord catheter. What you see here at low flow rates, so 20 microliters an hour, if you put your catheter on the back part or the posterior part of the spinal cord where you would like it to be, you find that the methylene blue stays in the posterior part of the spinal cord. And it does not go much to the anterior part or the front of the spinal cord. And it only spreads a few centimeters, both caudate and cephalate along the spinal cord. So when you think about it, for local anesthetic bupivacaine, the bupivacaine at very low flow rates, at the flow rate of the intrathecal or spinal pump, what you see is that the bupivacaine stays very close to where the catheter tip is. And if you also stays very much posterior if the catheter tip is posterior, but most importantly, if the catheter tip is anterior, it'll stay anterior. This means that if you're selecting to choose bupivacaine as part of your intrathecal pump regimen, you want to make sure that your spinal cord catheter is posterior to the spinal cord, because you want the most of the bupivacaine will stay posteriorly where the catheter is. Also, it will not spread very much anterior and very much posterior caudate or cephalate relative to the catheter position. So this means that the catheter position is very important for the use of bupivacaine in the animal model. If we take this one step further, we as people are not only horizontal like a pig, but we're also stand. But what we see here is taking the study using an actual pump, but having the pig vertical, more like a human spinal cord. What you see here is that even with a hyperbaric bupivacaine solution, and if you are vertical, which is the light circles shown here, the catheter, which is going to be right here at 0 centimeters, more of the bupivacaine goes down or towards the feet because of gravity than it goes towards the head. If you lie down flat, more of it will go towards the head relative to the amount that goes to the feet. So you can see that if you use an intrathecal pump and you're injecting bupivacaine, the position of the patient matters. So for example, if you want to give a bolus through your intrathecal pump and your catheter is posterior, but you want to bupivacaine to go towards the head, you would have the patient lie down and then give the bolus through the pump. This is some of the data from the animal models. And we'll take this one step further. We see that bupivacaine does spread more in the location of the catheter, both posteriorly, and it spreads not very much, a few centimeters, either towards the feet or towards the head. However, the positioning of the spine does matter, so that if you are lying flat, then you're more likely to have spread the bupivacaine towards the head. This is not as much as important for baclofen. So if you're using baclofen for pain or spasticity, what you see is you have slightly more even spread of baclofen where the catheter tip is, on both anteriorly to the spinal cord and posteriorly to the spinal cord, and both cephalad and caudate to the spinal cord. So much so that most people will choose a catheter for the cervical spine, high thoracic for the arm spasticity, and a low thoracic catheter for the leg spasticity. But it seems that the number does not matter that much. You just have a range for baclofen. And now we take the actual pump device and implant this into a pig. So now the actual device, as opposed to an external pump the other studies were for, now we have a true pump, and we see what happens with morphine. And using very low flow rates, 0.48 milligrams per day, which is a relatively reasonable flow rate for a spinal pump, what you see in the animal model is that the morphine concentration is very high at the catheter tip, but within 5 to 10 centimeters away from the catheter tip, which is approximately 2 vertebral bodies above and 2 vertebral bodies below, the concentration of morphine dramatically drops to 1 to the 10th, 10 to the -3 or -4 times what it was at the catheter tip. So it very dramatically shows that morphine acts very much at the spinal cord catheter tip and does not distribute easily in the CSF, both cephalad and caudate, away from the catheter. The lesson here is that the morphine will work where the catheter tip is most. This will be different than the fentanyl, because the fentanyl will go into the will leave the intrathecal space and will go into the systemic circulation, and since the fentanyl will act more throughout the body. So this is the way you can use your two different medications in a spinal pump. There's always been controversy whether morphine still gives you side effect when given intrathecally. This is work from our colleagues at University of California, San Diego, showing that no matter where the catheter tip is in the intrathecal space, there is some metabolites that cause side effect of morphine in the systemic circulation. So no matter if you give very little morphine, you'll still see some metabolism of the morphine that occurs in the body, and you might still have a side effect, regardless of the dose and the location of the intrathecal catheter. So the newer data that has come out more recently really relies on computer modeling data. So for the next few minutes, I will just talk about our understanding of how the computer model can explain how the CSF flows, and then I'll complete the presentation. What we see here is a lot of our colleagues in the University of Illinois, Chicago, Dr. Leninger and his group, really taking a model of how the CSF flows in the spinal cord based on cine MRI. Cine MRI essentially works by taking very fast pictures, MRI pictures of the spinal cord location, and linking them to a vital sign such as the heart rate or respiration, and then looking at the images to see how the fluid moves around the spinal cord. This is very common for the Arnold-Chiari malformations. What we see really briefly is using healthy volunteers and using cine MRI images. This is the cine MRI images shown here. What you see is that the majority of the flow of the CSF is very regional, meaning that it occurs very close to the spinal cord, and it does not flow up and down like we used to think, but instead is pulsating back and forth, and is more related to the cardiac cycle, the systole and the diastole. So shown here is red and green And what you see is a flow around the cervical spinal cord, the thoracic spinal cord, and in the lumbar spine. What you see is that there's more flow anteriorly in the cervical spine relative to less flow in the lumbar spine, and the thoracic spine is in the middle here. Most of this flow is linked to both heart rate and stroke volume. What that means to say is that the faster the heart rate is, the more the pulsation of the arteries that are around the spinal cord will push and move the CSF. The stroke volume means it'll be a harder push, meaning that the pulsation of systole and diastole of the arteries that go into innervating they go into the spinal cord, the pulsation is what's moving the fluid around the spinal cord. What does that mean? What that means is that as your flow rate of the intrathecal catheter slows down, there is less and less flow of the medication in the CSF. So for example, if I am injecting very quickly through the spinal catheter very fast, your fluid will go into the CSF, which is not moving, and mix with the CSF because of the velocity that you inject the medication. However, if you slow down that velocity to very little, what you'll see is that the CSF, the velocity of the solution you're injecting, will not overcome the stagnant or the lack of flow of the CSF, which means that very slow flow rates mean the medication will stay where the catheter is infusing the medication. This is another graphical representation of the computer model, taking it one step further, about 30 minutes, showing that at no injection, this is the flow rate of the CSF. At low volume, at 1 milliliter a minute, which is much faster than an intrathecal pump, you can see some distribution of the medication shown here. And at very high infusion, 10 milliliters per minute, you can see dramatic distribution of your medication at the catheter tip. What you see over time is that the faster that you gave the medication, the more the even spread of the medication that you're injecting in the computer model. The slower that you give your medication, the more it stays in the CSF where you're infusing the medication. A lot of this is based on computer models. And for those of you that I happen to be an engineer, for those of you that are trying to understand what is happening when the spinal cord all the anatomy is entered into the computer model. I'll give you a good example of what I'm trying to say. If you ever go to wherever you see a river and you look at the middle of a river when it's flowing very smooth, called laminar flow. But at the sides of the river, you see lots of trash. No matter how fast the river is moving in the middle, at the side of the river, the water is not moving very much because that flow, there's other reasons why there's not movement. There's attractions of the trash to the land, many other things that are happening. The same thing happens in the spinal cord. In the middle of the spinal cord, away from the in the interthecal space, away from the spinal cord, you see some flow of the CSF. But right next to the spinal cord, or the little rootlets shown here, there's very little flow, very turbulent flow that occurs and mixes just in that location. However, there is not much flow up and down next to the surface of the spinal cord and the spinal cord nerve roots. What that means is that blue here means no flow and red means significant flow. What that means is that at the location of the spinal cord, where the little rootlets are, you see very little flow. And as the shape of the spinal cord changes, you see some difference in flow depending on the location. So what this tells you is that depending on where you place your intrathecal catheter, there'll be mixing that's going to be very regional, and distribution of your medication will be very regional dependent on the catheter. The essential point here is that if you want morphine or your local anesthetic to work on the nerves that go to the arm, you need a catheter that's very high, usually in the location of the upper cervical spine. If you need this catheter to help you with the chest wall pain, you need your catheter at T4, T5, because that's where this regional mixing will occur. And if you need to treat your leg or your pelvic area, your catheter will be lower in the low thoracic spine or high lumbar spine. What this also means is that if you place a catheter in the low lumbar spine and want to use morphine or your bupivacaine, it will not help you if you have arm pain, need to treat arm pain. However, you can change your medication to medication that's spread very easily in the CSF or become systemic. So for example, if you have a catheter in the lumbar spine but want to treat arm pain, you better choose fentanyl as opposed to morphine. What you see also is that if I tell you that if I make the flow rate faster, there is more spread of the medication. That's why boluses through an intrathecal pump seem to be very useful. This is old work that's showing 2 cases by our colleagues in pain medicine, describing how patients tend to like the bolus more. And part of the reason they like the bolus more is that the medication is faster, therefore spreads higher up and down the spinal cord and can cover more area. So if you need to help a patient with pain relief very quickly, and you also need the medication to go more cephalad, you're better to use a bolus through the pump than to increase the basal rate.
I request you, sir, please complete your section within 2 minutes. Thank you, sir.
It's perfect. I'm at the conclusion of my doc. So
thank you,
right
sir.
here is the advice we have for morphine and hydromorphone is the location of the neurons of the spinal cord of the second order neurons. The local anesthetic, you want to target the nerve root location that you're interested in placing the catheter and make sure it stays posterior. Baclofen will either be a cervical or low thoracic for depending on the arm or the leg. Anterior, posterior probably does not matter very much. Ziconotide and fentanyl are likely does not matter where the catheter is. The ziconotide is a molecule that will spread through the CSF, and the fentanyl will go systemic. Thank you very much. I wish everyone safety and for those of you that are Hindu, happy Diwali.
Thank you, sir, for your nice and excellent presentation. Because it is a very advanced procedure in pain intervention, and you try to make it very easily to understand everyone. Now, time for the another topic that is the safety of interventional pain procedures, and it will deliver by our respected teacher, is Henriette Benjo from the US lab, professor of anesthesiologist and the pain physician, Northwestern University, School of the Medicine, and the executive section editor, chronic pain medicine, anesthesia and analgesia, and he is the chair of World Institute of Pain, USA. Sir, now you start your lecture with share your screen. Can you hear me, sir? Benjamin, sir, can you hear me, sir?
Okay.
Thank you, sir.
Can you hear me?
Yes, sir. Very nicely.
Okay. Can you see my slides?
Yes, yes, sir. Yes, sir.
Okay. Good evening. I'm Noor Benson from Northwestern Medical School in Chicago. This is our medical school, and this is the Prentice Hospital for Women. We deliver 13 to 14,000 deliveries, the second most in the United States. So I'll be discussing the following topics: the close claims findings, the central nervous system injuries with transforaminal epidural steroids. I'll be talking about the systemic effects of epidural steroids, then the anticoagulation and infection safety issues as it pertains to spinal cord stimulator and intrathecal pump. Finally, my last slides will talk about how do we avoid these complications. I have nothing to disclose. So the close claims study of the American Society of Anesthesiologists is a compilation of the medical legal cases that were settled. It didn't go to court. So the initial study was by Fitzgibbons et al. From Seattle, Washington. They look at the cross claims between 1970 to 1999, and there are only 284 pain cases versus over 5,000 surgical and OB anesthesia cases. However, the pain claims increased over time, and the payments increased after 1989. Nerve injury and pneumothorax was the most common, but the interesting thing is that epidural steroid injections consisted of 40% of all the cross claims between 1970 and 1999. So the study was updated, and so Jim Ratmel, who is now the chair at the Brigham and Women's, looked at the cross claim study between 2005 and 2008. Again, spinal cord injury is the most common complication. 55% of the injuries were spinal cord damage, and 22% were from cervical interlaminar epidural steroid injections, either direct needle trauma to the cord or infarction of the spinal cord or stroke after intra-articular injection of the particulate steroids. So if you look, when they test out the data, they noticed that 67% had sedation, deep sedation, basically general anesthesia, and 25% of the patients who had spinal cord injury were unresponsive. Only 70% used fluoroscopy or CT, and only 57% used contrast. So they calculated that the use of fluoroscopy or CT or injection of contrast would have prevented injury in 49% of the claims. So let's talk about the central nervous system injuries after transforaminal epidural steroid injection. These injuries are usually involve the cerebrum or cerebellum, brainstem hemorrhages, infarct, blindness, but the most common ones are paraplegia, quadriplegia from spinal cord infarct. So in 2007, I tabulated all the case reports of spinal cord injuries, and you can actually see, you can make two conclusions. One, the injuries can occur with either injection in the cervical, high lumbar, or even sacral epidural steroid injections. The important issue, though, is a non-particulate is injected, then the results are, the injuries are only temporary, but any of the steroids, particulate steroid, will cause permanent paraplegia and permanent quadriplegia. So the mechanisms are either injury to the artery, trauma or spasm, or embolism of the particulate steroids via the several arteries. The radicular artery accompanying the nerve root, ascending cervical artery, the deep cervical artery, the low-lying artery of Adam Kavitz, and the vertebral artery. It's a nice case report by Jim Ratmel. They nicely outlined the nerve root, but I also injected into the radicular artery that connects with the anterospinal artery. Injection of a particulate steroid would have resulted in spinal cord infarct. A nice cadaver study by Mark Anton, who used to be the editor-in-chief of Regional Anesthesia and Pain Medicine. We always use the SAP, Superior Articular Process, as a landmark, and you can see it's always close to either the deep cervical artery or the ascending cervical artery. What Mark Hunton basically showed also is that the ascending cervical artery or the deep cervical artery connects with the anterior spinal artery through segmental medullary arteries. They also showed that the ascending cervical artery anastomoses with the vertebral artery at the lower cervical levels, and the deep cervical artery anastomoses with the vertebral artery at the higher cervical levels. you can then see that if you inject a particulate steroid into the radicular artery, then you can result into a segmental infarct of the spinal cord. Or if you inject into either the deep cervical artery or the ascending cervical artery, if it connects with the vertebral artery, it's going to result in a brain infarct. So what we did was we painstakingly measured every particle size of all the steroids available. We use a laser confocal scanning microscope, and you can see that the betamethasone has the smallest particles here around 5-10 microns. Triamcinolone is moderate in size. The methylprednisolone is the biggest size. It took about 100, 500 microns. That's more than enough to completely occlude all the arteries I'm talking about. So we're talking about complete brain infarct or a segmental infarct of the spinal cord. We now know that dexamethasone and betamethasone sodium phosphate are non-particulate. These are air bubble. We wanted to show the contrast. Now, Celestone contains a short-acting betamethasone sodium phosphate that's non-particulate, and the betamethasone acetates that's long-acting that has some small particles. Now, you can see that triamcinolone is moderate in size, but the methylprednisolone, they not only have the biggest size, but they also precipitate and confluent with each other, causing a big, massive particles there. So we published our recommendations, the multidisciplinary working group in anesthesiology, and JAMA asked me to summarize it, and I also published it in JAMA. Both were published in 2015. Interestingly, the Benelux group, Belgium, Netherlands, Luxembourg, has decided to create another recommendation. It's very similar, but I'm recommending it. I think it's the best review article on the topic right now. So we're gonna look at the differences. For interlaminar epidural steroid, we both recommended that if you're gonna do an interlaminar, it should be at C6, C7, or at C71, but not higher than C6, C7. The reason for that is the capacity of the epidural space is widest at C6, C7, C71, and there are gaps in the ligamentum flavum. And the gaps in the ligamentum flavum are more frequent as you go up. So you do resistance, loss of resistance, well, you're suddenly in the spinal cord. So we recommend that should be at C6, C7, and C71. You can inject particulate steroid, of course, this is no comment, which was understood. You can inject a particulate steroid for interlaminar injections. The transforaminal is another issue. We strongly recommended that digital subtraction angiography should be performed before injecting the steroid. Benelux group didn't think was required. For cervical, we strongly recommended that you do not use particulate, that you only use non-particulate. For the L3 and lower, we recommended that you use a non-particulate first if the relief is very small and if the duration of pain relief is very short, then you can go ahead and do a non-particulate. But if you use a non-particulate first and there's a spinal cord infarct, you're going to have a hard time, have difficulty defending yourself in the court of law. So systemic effects of epidural steroids. What Friedli has done is he looked at all the issues and the systemic effects. They noted that the injection of 200 milligrams of methylprednisolone over 1 year or 400 milligrams over 3 years resulted in decrease in bone mineral density. They also noted that the injection of one epidural steroid injection resulted in reduction of cortisol levels over 3 weeks. And there is an increase in blood sugar levels after one injection of 20 or 40 milligrams triamcinolone, and you have to think about this in diabetic patients. So what's the effective dose? Well, we have a lot of studies here that show that for interlaminar epidural steroid, 40 milligrams methylprednisolone is as effective as 80 milligrams. Yet we continue to inject 80 milligrams, 120 milligrams. It's no reason to. Transforaminal epidural steroid studies have shown that 4 milligrams is as effective as 8 or 12 milligrams. Yet we keep on injecting 6, 8 milligrams per level. 40 milligrams methylprednisolone is as effective as 80 milligrams. Again, we keep on injecting 60, 80 milligrams per level, and do as many as 3 levels at one time sometimes. So I'm going to go to some, I'm going to pick my spots because I simply cannot talk about anticoagulation and infection. I am part of the ASRA anticoagulation guidelines, both in regional anesthesia and in pain medicine from the beginning. And I'm also part of the neuromodulation guidelines, International Neuromodulation Society guidelines on anticoagulation. The only topic I want to talk about was to discuss the NRES paper. They made a comment that after 1,600 transforaminal epidural injections, there was no bleeding at all. So they felt that you ought to continue the anticoagulant. Our response to them is that there's such a small number of cases, 1,600. The incidence of spinal hematoma is 1 to 100,000. Some studies now show that maybe as common as 1 per 30,000 neuraxial injections in the elderly, spinal stenosis in the female patients. So we also made the comment that there are case reports of spinal hematoma, epidural hematoma, foraminal hematoma, perineural along the nerve root. I was the deputy editor-in-chief of pain practice when I accepted this. So these are patients who were not anticoagulated, yet they developed foraminal, epidural, perineural, retroperitoneal hematoma when a transforaminal was done. So we recommend that you ought to continue the anticoagulant. The other comment that they made that when they stopped the warfarin, there were 9 complications: stroke, myocardial infarction, pulmonary embolism, MI. But the problem is that they did not note the INR, international normalized ratio. They did not state whether warfarin was, whether the patient was put on warfarin. So we still cling to our comment that you stop the anticoagulants and put them on low molecular weight heparin breeds. So how do we balance prevention of spinal hematoma on one hand and prevention of stroke, myocardial infarction, venous thromboembolism on the other hand? Well, I think you ought to know the CHAD score. CHF 1 point, hypertension 1 point, AIDS/75 1 point. I'm close to being around the 70s. Diabetes mellitus is 1 point, and history of stroke is 2 points. This predicts the risk of stroke or venous thromboembolism. Now, there's a lot of publications in neurology literature, cardiology literature, internal medicine literature that a CHAD score of 2 to 3 predicts stroke, very high with 4 to 6. A CHAD score of 2 or greater is an increased results in increased risk of coronary artery MI in patients with coronary artery disease, and a CHAD score of 3 predicts venous thromboembolism. So my recommendation to you, it's so easy to do a CHAD score. Just look at the CHAD score. If it's greater than 3, stop the warfarin or anticoagulant, put them on low molecular weight heparin breeds, stop the Lovenox 24 hours before, and you prevent both spinal hematoma and also MI, stroke, or venous thromboembolism. Infection. Well, incidence is 1 to 100,000. One noted an abscess for 1930 epidurals. We know what the signs and symptoms are. We're all clinicians. I'm not going to go through them. There are actually 3 practice guidelines. One is from the American Society of Anesthesiologists, and the other one is from the American Society of Regional Anesthesia. We all know what they recommend: aseptic technique, double gloves actually for the spinal cord stimulation, intrathecal pump, chlorhexidine base greater than povidone iodine. The American Society of Regional Anesthesia, we are presently creating a practice guideline to prevent infection. It's going to be a massive one, both in regional anesthesia and in pain medicine. We started 6 months ago. Hopefully we'll come up with it next year. So spinal cord injury, the signs, spinal cord stimulation infection, I'm sorry. There are 2 sites. We all know, the deep and superficial. The bothersome thing is that the organism is usually Staphylococcus aureus, which means there is a break in the sterility procedures. We know what the risk factors are: revision surgery, diabetes, obesity, smoking. Interestingly, for our peace of mind, there's no difference in the type of lead, whatever prophylactic antibiotic is used, and there's no difference whether the person doing it is a neurologist, physical medicine, anesthesiologist, or neurosurgeon. There's no difference at all. Dave Provenzano surveyed the members of the International Neuromodulation Society, and he was quite disappointed though, because 45% didn't know that the antibiotic is to be weight-based. Very few were double gloving for those procedures. They were not continuing the antibiotic for 24 hours, and he was really worried that only 8% knew the criterion for surgical site infection. So these are the neuromodulation guidelines to prevent infection in intrathecal pumps. First of all, there has to be failure of conservative management. The patient has to be psychologically stable. You reduce the opioids and you take care of the risk factors. They made it a point though that the physician and the staff has to be trained. There has to be an adequate infrastructure. There has to be an on-call coverage, because if there are symptoms, then there has to be someone available 24 hours a day, 7 days a week. The intrathecal pump, we know that infection usually occurs within the first 3 months. I just want to talk about intrathecal granuloma. Signs and symptoms, new or different symptoms, neurodicular pain, new motor weakness, bowel bladder function. And the characteristic thing is that there is frequent or large escalation of the dose, but only results in temporary relief of the pain with increased dose. So the recommendations of the International Neuromodulation Society to use the lowest effective dose, lower the catheter, has to be below the conus, switch to other opioids or sigonotide, and then you monitor them, signs and symptoms, and rate of increase. This diagram is basically a repeat of what I discussed. So my last slide, how do we avoid these complications? Well, to prevent these central nervous system injuries, brain infarct, brain hemorrhages, paraplegia, quadriplegia, we ought to know the multidisciplinary pain working group or the Benelux recommendations. To prevent the systemic effects, we ought to limit the methylprednisolone dose to less than 200 milligrams per year and less than 400 milligrams per 2 years. Interlaminar epidural, 40 to 60 milligrams of methylprednisolone should be adequate. Transporaminal, either 4 milligrams, triamcinolone or 40 milligrams methylprednisolone should be adequate. To balance bleeding, venous thrombolism, stroke, and bleeding in spinal hematoma, we ought to know the ASRA guidelines, the neuromodulation guidelines, and we really start to apply the CHAD scoring in our practice, so we know when to stop it, or can we stop it without any problem, or when do we need to stop it and continue the Lovenox and stop it. Infection, we have to know the CDC guidelines and neuromodulation guidelines. CDC is quite old, but it's the same as the neuromodulation guidelines. IT medication errors, well, training and infrastructure and expertise, we need to update our knowledge. I mean, we just submitted a practice advisory on the problems with radio contrast, and I think we need to keep on updating our knowledge. What are the safety issues with interventional procedures? And we need to be updated with these publications. So these are the topics I talk about. And thank you so much. Greetings from the city of Chicago. Thank you.
Thank you, sir, for your nice and excellent presentation, because in our day-to-day practice, we have to face avoidable and unavoidable many complications regarding procedures. So I think it is very helpful for us, because we are practicing pain and we have to care about the patient's safety as well as the doctor's safety also. Now, I would request to Dr. Harvey Finkelstein for his presentation. Now, his topic is the requested steps organizing an office for doing pain injection procedures. And our beloved teacher, he is the American Society for Advocates of Ambulatory Surgery Faculties and examiner for the FIPP examinations of the World Institute of Pain, and he is the director of the Pain Care Medicine of Long Island, 1992 to 2016, and director, Department of Anesthesia, Plainview Hospital, Long Island, 1992-1999. Sir, can you hear me?
Yes, can you hear me?
Yes, sir. Fantastic.
Fantastic. Oh, it's very good to be here. I'd like to say hello to Dr. Kawar Sadar and thank him for inviting me. It was an honor to give him his FIPP exam, and it's wonderful to see how well he's organized this conference. I'd also like to thank the Bangladesh Society of Anesthesiologists for inviting me to the first International E-Conference on pain. So I know it's quite late at night, so I'm trying to move through my slide presentation quickly, and I'm quite honored that we still have so many people watching this at this late hour in Dhaka. So I retired from anesthesia interventional pain about 2 or 3 years ago. And since then, I've been increasingly involved working as a surveyor for the American Association for Accreditation of Ambulatory Surgery Facilities. And it's only fitting that I follow Dr. Benzon's excellent presentation about safety issues with anesthesia to give you a brief and thorough introduction to establishing a safe office environment. In the United States, anybody that wishes to do office-based procedures, especially when involving anesthesia, needs to be surveyed. I'm not sure how that applies to the countries of all the participants, but one thing I feel confident in saying is that after the epidemic, certainly the stress on all of us of infection control and safety in the office will be increased, it won't be decreased. So hopefully what we talk about today will be reminders of that, how keeping a safe office practice, keeping your staff educated, and maintaining a highly run and clean practice, practicing safe medicine is important. Some of the things we'll mention are dealing mostly with office-based practices and ambulatory surgery centers in which anesthesia services are given. But whatever you can do to increase your documentation, your infection control, and sterility and knowledge of the whole team working together will only improve your outcomes and also improve the confidence your patients have in you, and also decrease your risks of having any complications or untoward interventions by unwanted people in your office. So first of all, this is me, Harvey Finkelstein. If you want an email and ever have any questions on setting up your office, please feel free to write down my email and contact me at any time. It's hsfinkelstein@gmail.com. The objectives of today's program are as follows. We're going to present you today with important written information about what you need to do in your office, including written policies and protocols that the facility should have in place, documentation of medical record requirements, radiation and safety requirements, including sterile supplies and housekeeping in the OR, safe medication practices, especially how it deals with any unwanted emergencies like a cardiac arrest, or if anesthesia services are provided, malignant hypothermia, if you provide any of a general anesthetic type of techniques in your office. Can you hear me? Hi, is that clear? Okay, I assume that's a yes.
It's nice, it's nice.
All right, so let's proceed. So whenever we hear at Quad ASF, that's the organization I work with, of mishappenings that occur in a healthcare facility, the first thing we think of was the staff following protocol. So these are things that we don't usually like to hear. We spend most of the time at these meetings learning about procedures, but in the real world, we have to take care of not only knowing how to do our procedures, but performing it in an effective way. So to do that, we have in our surveys and our standard books, we emphasize the necessity of having written policies that will help everybody and help the whole staff work together in a unified way. Written policies and protocols on how you do your procedures are an important part of our evaluation, and also can be quite helpful to you in making sure your staff knows what to do in case, and just in daily management of their practice, and in case any untoward events happen. It also will help the whole team work together and be a more effective group. Quad ASF requires that all facilities have written protocols for ACLS and cardiopulmonary resuscitation. And if anesthesia is involved, everybody should have a knowledge of malignant hypothermia or reaction to anesthetic agents. In addition, there should be written protocols in your office for situations where surgeon or anesthesia provider become incapacitated. There have been cases where either the surgeon or anesthesiologist has had an event during the case. What happens in those situations should be outlined to the staff in case that happens. There should be definite written infection control policies and procedures such as the proper use of antibiotics, hand washing, if recording any mishaps, any problems with patient responses, any untoward side effects. All of these are things that you should try to write policies about and document them and have the staff well informed about them during your hiring processes. Now, in terms of documentation, no matter what you do, your yes? Can you hear? Documentation is obviously a key. All right, that's important. That's some of the things we look at thoroughly. There's an old saying in healthcare, which I'm sure all of you know, if it wasn't documented, it didn't happen. So the documentation that you create for any procedures, whether they be simple as an epidural steroid injection without anesthesia, to whether your office is a complex one in which you do more interventional procedures like intrathecal drug trials or stimulations, the documentation you have is very important. It is therefore imperative that the medical documentation be very thorough. It's worth the 5 minutes extra every case to document what you do well. It could save you a lot of headaches. So what do we ask people to do in America, and what do we recommend doctors do in their offices around the world? First of all, there should be a thorough pre-procedural evaluation and checklist for the patient. That includes anything about physical ailments, disabilities, or religious and or ethnic concerns. We recommend the facility also publish a Bill of Rights. We have a Bill of Rights with Quad ASF. If you reach out to me, I will send you a copy on the internet so you could use it as a basis for a Bill of Rights for your office. Or if your local Department of Health has recommendations, I'm sure you can get one from your local regional or national services. The physician is responsible always for determining the medical status of the patient and must examine the patient immediately before the procedure and write a thorough note. That's the minimum, okay? And it should include the past medical history, the past surgical history, allergies, and all medications the patient is on. Patient should also, if he's giving anesthesia or if there's an anesthesiologist, there should be a note of the patient's anesthesia history and the family history. These are important things to document prior to the procedure. The anesthesia all materials should be handled in a clean, in a room where there's a sink to clean it, and then to be wrapped appropriately. And then when it's sterilized, that there's the correct controls during the course of sterilization, and that you keep adequate monitoring records of each load that enters the sterilizer, and that it's done correctly, and that all things sterilized are properly dated and not kept on the shelves for longer than 30 days before they're re-sterilized. If we do that, we'll keep out of trouble. So we need to have someone designated in our offices to monitor, to probably have a good in-depth knowledge of sterilization usage and how to maintain a sterilizer, and that should be their responsibility. So then we go to housekeeping in the operating room. We all should keep a written protocol delineating and defining what our infection control processes are. Today, especially after this interesting year we've been living in, infection control is going to be a highlighted issue around the world. So Quad ASF requires strict adherence to our infection control standards, and all facilities should have a knowledge of all facility staff must have a knowledge of the infection control programs that go on in your office. And this includes things like washing with surgical soap to make sure you're cleaned, or an alcohol-based waterless scrub. Some places don't scrub before cases. We use a waterless scrub that is antibacterial in nature. We use in our area Avigard, but I'm sure that's probably available worldwide at this point. But you should always scrub before each case, or have a rapid before each procedure, re-clean yourself with an adequate scrub product that's used, that is operating room safe. You should have a sink somewhere outside your OR for scrubbing. If you only have one sink available in your facility that you use to clean instruments and for scrubbing, you should have a policy where prior to washing, the sink is disinfected. Also, that when you set up your operating room, pay attention to the floor and ceiling cleanliness. Make sure that when you set up your room, the operating room ceiling has, if it has drop-in tiles, that are easy to clean and they don't attract dirt, and they're cleaned periodically. Also, that the floors are covered with a smooth, easy to clean material. And sometimes if there's stone floors and there's gaps between the tiles, make sure they're sealed with an impermeable sealant other than silicone, which can be washed frequently and kept clean. You also should have a written protocol for the housekeeping team, and that should include at least terminal cleaning before and after procedures are done on a surgical day, and they should have a protocol for how your nursing assistants or nurse cleans the room between the cases, and they follow this diligently. So what's involved with turning over a room between cases? So remember, when you're cleaning the room, it's imperative to clean it well and efficiently. You can use a hospital-grade cleaning cloth. In America, Cavicide is used. Ammonia hydrochloride washes like Clorox are beneficial, but they're not hospital-grade because they're not anti-fungicides. So if you can't get something that is not an anti-fungicide, then you could just get an ammonia Clorox type of or Cavicide wash, and follow it up with a hydrogen peroxide wash with low-lint towels, because hydrogen peroxide is effective for killing fungus. So the nurses should clean the room from the periphery of the room to the center of the room, and that should be done after every procedure to make sure that all the countertops, the bed the patient is on, the fluoroscopy unit, the fluoroscope are all cleaned, and after every case. Let's go, keep going. The room turnover we just went through. Remember, before every procedure, a terminal cleaning is done. And that's, that's for your safety and for the patient's safety. And that you clean and disinfect all the floors, including any windows, the ceiling, the floors, and all the machines. We move from the periphery of the room to the center of the room. and it's cleaned with an established protocol. If you have a cleaning service, make sure in your contract with them, you delineate that before procedure days and after procedure days, it is terminally cleaned, and you keep a record of that. The other thing we have to be diligent about is medications. Medication errors are widespread throughout the world and have caused many issues. We use many medications, including steroids, including other antibiotics and other injectables, and those should be kept in a clean area. All drugs and biologicals given to patients must be approved by you, the medical director of the facility. Now, routine medications can be stored under a lock and key, but if you have anesthesia services or if you provide sedation, the standard in the United States for controlled substances, which includes benzodiazepines like midazolam and fentanyl, require them that they be locked in a double lock box, and that there's a record-keeping system in which there is a tamper-proof book which labels once a week the narcotic counts and daily on every use, which is signed off by 2 members of your staff. Inventories of narcotics is critical, and it's one of the signs when anybody you don't want comes in your office, that's one of the things they check first. So if you provide sedation, make sure you have an adequate log, which is checked weekly, and that every time a medication is used or wasted, the wastage is double signed by 2 members of the operating room team. The other issue is the use of single versus multi-dose vials. Even in the United States this year, because of the virus, the ability to obtain single-dose medication vials has been difficult in many office-based practices, and I'm sure that's affected you also. We try to recommend not using multi-dose vials, but in this day and age, this year it's been difficult, and there's been an increase in multi-dose vials. So be sure that whoever uses multi-dose vials, whether it's you or your nursing staff, that they handle these in the appropriate manner, and it's as a policy for how this is done, and that you follow it. So remember, you have to date and time when the multi-dose vial is opened. All right, remember, it will expire within 28 days after opening or on the manufacturer's expiration date. Follow those guidelines. Remember, the initials of the person opening it should be on the vial when he opens the vial. You should always use a new needle and a new syringe every time you enter a multi-dose vial. We recommend at Quad ASF that multi-dose vials, if used, should be handled in a separate clean area and pre-drawn before the case, and each syringe labeled and initialed and timed appropriately if that can be done. If not, then remember, the rubber top must be cleaned with 70% alcohol before entering it with a clean needle and clean syringe every time. When in doubt, get a new clean needle and a new syringe and use it. And clean it appropriately. These are simple steps, and you'd be surprised when you do closed case reviews on a level like we do at ours, how often simple mistakes lead to headaches. The other thing that we urge everybody to do is to have all members of the team that you work with in your operating room, whether they be nurses or nursing assistants, have minimum of basic cardiac life support, and at least one member of the team, whether it's you and definitely your anesthesiologist, have advanced cardiac life support. And that everybody keeps up-to-date training and documentation that they're up to date in their personnel files. That's quite important. And we recommend that periodically when you do your quality control, once or twice a year, you do a practice run where everybody's familiar on their role in case an emergency happens. In addition, if you do any procedure in your office, whether it has anesthesia or not, you should be prepared to handle any major emergency. I can remember early on in my practice, just doing a simple epidural in the office, a patient fainted, and we were lucky we did not have to defibrillate him, but he did need to have some chest compressions applied before he woke up. And it was a blessing that everybody in my office was able to help in and ship out in a brief but rapid response, and the patient did very well. But these things can happen even if you're just doing simple trigger point injections or epidurals, even without sedation. Be prepared for the worst. Have a full advanced cardiac life support card. Have a defibrillator, and have these things checked. We recommend if you have a defibrillator that are weekly or monthly, that it's checked, especially if it's an AED, and that the battery and the company comes once a year to check it. A full ACLS card should be available at all times, stocked with medications, and you should have a monitor available which does EKG readouts, a pulse oximeter, non-invasive blood pressure, and that your cart is equipped to handle emergencies, including nasopharyngeal airways, an ambu bag, nasal oxygen, and that at all times you have a full oxygen tank in the office, and that it is checked by the staff on a daily basis to make sure it's full and that you're always ready for emergencies. Make sure that your cart is stocked with all the appropriate medications. Follow the ACLS protocols. Have the appropriate medications on your card at all times and make sure they're dated correctly. Once again, this year it's been quite difficult to maintain up-to-date medications. In an emergency, don't discard anything on the cart till it's been replaced by your team. And things you might think of containing in there is always have Narcan available in case one of your patients has taken narcotics and not informed you and has a strange response. Also have a reversal agent for benzodiazepines like flumazenil. Always be ready for an emergency intubation and be trained how to do that. And we recommend that you have a non-depolarizing or depolarizing neuromuscular agent in the office at all times. And in the event that you do anesthesia in your office, make sure your anesthesiologist does an in-service once a year on reactions to anesthetics, which include malignant hypothermia. Sorry, I'd like to just remind everybody here that we spend a lot of time learning how to do procedures. And the quality of our work is very often reflected in the way we do procedures and the knowledge that we gain. But day to day in our office, doing mostly procedures we do many, many times, the quality of our life and the ease and the ability to sleep at night are based on how well we organize our team, develop policies and procedures to safely clean the room, to monitor the patients, and to work together as a team to handle emergencies and to handle the day-to-day issues, especially documenting the care we give so that it's thorough and that you've documented everything you do and that you take good pre and post-operative care and evaluate the patients and document it, and that you maintain sterility and have records of everything that you do. Because record keeping in the event of a mishap is your best friend. Please feel free to contact me anytime by my email if you have any questions or want any information. And if you have any questions, please feel free to ask them now, or if you're shy, please feel free to write me an email. Once again, my email is hsfinkelstein@gmail.com. And for all interventionalists out there, I cannot say enough about being a member of the World Institute of Pain and getting the fellowship training. That and adherence to good product safety policy and procedures in your office will save you a lot of headaches in the future, make your career a lot more rewarding. Thank you very much for listening.
Thank you, sir. Thank you for your nice and excellent presentation, because every intervention we should take care separately and organize every steps, both officially as well as steps of in our OT, and always prepared ourselves. I think it is very excellent presentation and learning a lot from you. Thank you, sir. Now our next topics is femoroplasty, and I would like to request Dr.
Sound loud, sound please loud.
Okay, thank you, sir.
Can you hear me?
Yeah, yes.
Okay, okay. Thank you, sir. So I request to Dr. Angel M. Juarez Limas. He is from the Mexico and staff in the pain clinic department of National Institute of Cancer, Mexico, and he is the founding member of the Alive Pain Clinic and the founding member of the Mexican Society of Ultrasound in the Pain Management. And I request to Dr. Lamy sir for share your screen and start your presentation. Good morning, sir. Can you hear me?
Hi, good morning. Yes, good morning. Can you hear me too?
Yes, sir. Yes, sir. I can hear you.
Okay. Thank you very much. I want to thank to the Bangladesh Society of Anesthesiologists and Dr. Kausar Sardar for give me this opportunity to talk about this procedure. This is my hospital, the National Institute of Cancer, is in Mexico City, and we have a lot of patients with cancer of all the country. This is our team. It's a big team. The boss is here, is Professor Dr. Plancarte, who described this technique, and they are our fellows. The bone metastasis develops in up to half of the patients with cancer. Its incidence depends on the primary tumor type. Can you see that myeloma multiple has a lot of osteolytic lesions? So our patients are more frequent with myeloma multiple. In these patients, the most frequent symptom is pain, and the other is loss in mobility. The most affected sites of metastasis are vertebral body, pelvis, and proximal femur lesions. Half of the patients with femur fractures has the fracture in the neck. This is the first report of the team, Dr. Plancarte's teams, talking about femoroplasty as a new option for femur metastasis. These publications is from 2012 year. In this publication say that the main indications are patients with metastatic disease in the head, the neck, and the proximal third of the femur, patients with osteolytic lesions, and patients with a Merz scale of 8 or more points. This is the Merz scales, which takes account the site of the lesions, upper extremity, lower extremity, or peritrochanteric, nature, blastic, mixed, or lytic lesions, and the size of the lesions, 1/3, 2/3, or more than 2/3 of the lesion. And if the patient has pain, mild, moderate, or functional pain. If the patient has 8 or more points, you can consider this procedure. The contraindications are bleeding disorders, infection in the site, cement allergy, fracture, no integrity of bone cortex, and soft tissue involvement. If the patient has already a fracture, you can do this procedure. The technique, you need to begin with antibiotic prophylaxis. We use cephalosporin. You need to put midazolam or fentanyl and sometimes propofol. Only mild sedations and local anesthetic is necessary to do this procedure. You don't need to do general anesthesia. The position is a very important point to do this procedure. You begin putting your patient in lateral decubitus with the affected side up and the hip slightly flexed, and then to take a picture with the C-arm, and once you have the view that you need, you can continue. The C-arm needs to be oriented in a craniocaudal angle to create a tunnel vision. In the photograph of the right of your monitor, you can see the position of the patients. You put something that help you to don't move the patients, and this is the angle that you need to have with your C-arm. Then you need to see two round images that correspond, one to the femoral head and the other to the greater trochanter. Let me show you with this video. You begin with this picture on your C-arm and AP, and then go to lateral view, and you begin to see the two rounds that I said you, one to the trochanter and one to the femoral head, and you need to put two needles, 20 gauge needles, one in this side and one in the other side. And then you return to your picture, and you need to see how your needle of 11 gauge, bone biopsy needle, needs to start down to the greater trochanter and go to the femoral head. The entry site, as I said before, is infiltrated with local anesthetic. We use 1% or 2% lidocaine after you put the sedation, and put two needles, 20 gauge needles, for reference only. This is only for reference, 20 gauge needles, to put one in this side and one in the other side. And then you put your 11 gauge needle between these needles. This is the needle that we used, bone biopsy. And then the needle is advanced slowly, controlling the progress with lateral fluoroscopic views, as you see in this photograph. And we put inside this bone biopsy a needle, a 20 gauge needle, to looking for the advance, then the bone biopsy 11 gauge. So if we don't see that we are inside the bone, we can reconsider to move the other bigger needle. Then where you put your needle in the 1/3 and 2/3 of the femoral head, you need to put a contrast medium, non-ionic, 3 cc's, and then you can identify the vascular drainage of the tumor. If you see that contrast is going to the joint, you need to remove your needle because you can have a complication if you put the PMMA, polymethyl methacrylate, inside the joint. Once the biopsy needle is placed in the distal third of the femoral head, you can put the PMMA. We use syringe of 1 ml, and half of the needle is filling with PMMA. So we put doses. Sorry, I can understand. Microphone. Okay. Thanks. Half of the needle with PMMA, and we put half of the ml. It's important to say that the consistency of the PMMA needs to be in toothpaste, because if you use another consistency, it's very difficult. Its administration must be visualized by lateral and oblique fluoroscopic projections. The biopsy needle can be slowly removed while the cement is applied. You put the PMMA and then can slowly removing the needle and putting the PMMA, as I said, half and 1 ml doses. The amount ranges filling depending on the metastatic bone defect and the femoral head size. The application is stopped when the fluoroscopic image shows filling with the polymethyl methacrylate at the proximal femur and with the raise of the pressure while injected the material, or when the PMMA approaches the site of the insertions of the needle in the cortical bone, in this site. After the procedure, you can request to your patient for a bone densitometry. This is a patient with a bone densitometry after the procedure, and you can see how enhances the parameters in the neck of the patient. The femoroplasty is not recommended for osteoblastic lesions. The injection should be done before the PMMA has induration. You need to monitor your patient with pulse oximeter and be careful for pulmonary embolus. The PMMA leakage is a common complication, so the reposition of the needle with fluoroscopy will be necessary. This is our team, the Mexican Society of Ultrasound. Here we missed Rodrigo Diaz-Tafur from Peru. I want to thank you again for this honor to be here. If you have some questions, you can send me an email and I can send you publications. Thanks. This is all of my lecture. Thank you very much.
Thank you, Engel, for your nice and excellent topics. I think it's a new topics, and that's very nice.
Thank you.
Milton,
Thank
you
you,
should
Doctor.
be a little bit louder.
Okay, thank you, sir. Thank you, sir. So now I request to Dr. Muralidhar Joshi, sir, and his presentation. I want to share his topics, that is regenerative therapy in the management of the pain.
Before that, Muralidhar Joshi is the Indian president of Society of Anesthesia. Just I am seeing here our very energetic lady, our past president of WFSA, Janike Melin Olsen, joined here. Just make a hello to her. Janike Melin Olsen. I'm seeing he is here. She is here. Are you hearing me? Janika Melin Olsen? Okay. She is in join mode. Okay. Carry on, Muralidhar Joshi, please.
Okay, I will
Oh,
introduce
you have
Dr.
to
Muralidhar
introduce, no?
Joshi.
Milton,
No,
you have to
okay,
introduce,
okay,
no?
okay. President, Indian Society of Anesthesiologists and ASOD.
Unmute, please, Milton. Unmute. Unmute yourself. Milton. Milton, unmute, please.
Yes, sir. Now I introduce Dr. Muralidhar Joshi. Sir, he is the president and president of the Indian Society of Anesthesiologists, and he is the ASOD of the Department of the Anesthesia and Pain Medicine and Director, Pain Management Center, Manis Hospital, Hyderabad, India, and he is a member WFSA Pain Relief Committee 2016 from 2020. And he is very famous person to us because we know everyone him. I request to Dr. Joshi sir for start your lecture and share your screen. Sir, good evening, sir.
Good evening. At the outset, right, thank the organizers of the event, first like e-conference on pain medicine as such from the Bangladesh Society of Anesthesiologists. Has strong memories and fond memories from Bangladesh. A lot of friends and well-wishers and all. It's nice and all. But I also know I'm the last speaker of today's session, at least in Asian continent. Probably it's almost it's night at dinner time, or maybe it's all dinner. Some people might have finished or might have left for dinner. But elsewhere, it's good morning. So nice speaking to you. But one thing, probably, I think one thing that has been enchanting for the human beings and all the time is, can we regenerate ourselves? Is the bottom line. For example, it could be you need to keep the pain. People probably who become probably a little bald also would like to have a regeneration of the hair. It starts from there. Like you want to look youthful, you want to look healthy, you want to look young, and you want to look like much more stronger than what you are. And probably if you can regenerate your own life, nothing like it. So sometimes we say it a rejuvenation or sometimes regeneration. But it comes to pain, of course, we have been trying so many things. I think the other speakers in today's session, they did a wonderful job. That was phenomenal, what I would like to say. But regenerative therapy is something like, say, for example, so we have been living in this for so many years and all, of course. It's part of life. Like degeneration is part of life. As you live for longer time, once you cross the 21st year, everything in the body starts degenerating. It might manifest by the you cross the 35, 40 years. You can make out little bit stiffness in your joints or maybe movements and all. But people, we try to do certain things, what's called as a fitness and all those things we keep doing. But somewhere, certain things, it's difficult. Beyond the limit, you find it difficult how best I can go about it. Here, the regeneration is one thing. See, if certain degenerative things, whether it's the spine you talk of, or maybe the joints, if the regeneration can be restored by some regenerative therapies, can I get back my mobility? It could be people at a senior level also, nothing wrong about it. It could be sports injuries also. Like you see these days, and people are playing sports and all, some ligament injury on football ground or cricket ground, and people say he is out of the particular tournament for about 6 weeks. Now, the interest here is in the 6 weeks, what do they do? Do they apply the regeneration therapy? Or if it is they are applying regenerative therapy, is it helpful? Is it useful? Has it worked? So these are dilemmas all of us keep on trying and thinking about it. Worldwide, a lot of studies are being done. Let us see what does the evidence say with respect to this particular therapy. With this small introduction, I would like to move on to the discussion. Thank you, Dr. Kausar, for inviting us, and also we got our own good friend, Dr. So it's nice meeting all of you over here. It's so nice to see all of you together. So fine. So somewhere if you just look at the whole thing, the regenerative medicine is a medical subspecialty that seeks to recruit and enhance the body's own inherent healing armamentarium in the treatment of patient pathology. So basically, we're trying to use the whatever is in your body. Can I use it to improve the healing in your body? But the therapy's intention is to assist in the repair and to potentially replace or restore the damaged tissues through the use of autologous or allogenic biologics. That's most important. Autologous or allogenic biologics. Can we get back the old energy what we had? Maybe can we improve the healing process? This field is rising like a phoenix from the ashes of underperformed conventional therapy. Many things we keep trying and all those things, but something difficult also. And the hopes that high expectation of patients and medical personnel, maybe whether if we can regenerate whatever things which is there, can we move on, get on with life, maybe for some more years or something like that? Can we avoid much more major intervention? That is the way it's being looked upon. But having said that, you need some tools also to to understand that yes, to get the regeneration or whatever, what tools can you use so that I can get back my old energy or my old moments or something like that. Just to pain this thing, what commonly being propagated or being advocated or being used world over, the products can be split into two categories. There could be two categories. Could be one is healing environmental products is one group, and second is cellular products. In the healing the environmental products, we have NSAIDs, which is one more thing being tried out, steroids, synthetic hyaluronic acid, platelet-rich plasma, amniotic fluid, and of course, Barton's jelly liquid suspension. In cellular products group, we have lipoaspirate concentrate, bone marrow aspirate concentrate, umbilical cord blood, and umbilical cord mesenchymal stem cells. There are claims, like you can see, keep studies, seeing studies and all. Some claim that really does wonders and all. At the end of maybe 6 weeks, it's phenomenal, or at the end of maybe 12 weeks, it is great, or maybe at the end of maybe 6 months, it's great. But the question is, let's not forget about that one. It might be good for a study which might end up with 6 weeks or 12 weeks. It could have happened even with the rest also. So there are certain people who say, like, it's just a bias, like 6 weeks, it's nothing more than that. If you take rest and you inject anything, you inject a normal saline also, 6 weeks you take rest, everything improves and all. So a lot of these things are, even FDA also cautions about all this regenerative therapy, these things, like they don't accept everything that that it works, it doesn't work, because that is leading to a lot of abuse across the globe. People keep using it as saying that it rejuvenates and all, but it doesn't happen. Patient feels disheartened, and the clinician also feels like left out. And of course, it involves a lot of the cost also in that one. So let's take a look. What does the evidence say? Do they really work, or we have to look for something? Let's not forget, when we inject cells, especially something like mesenchymal cells also, we should understand this, especially stem cells and other things, they can get multiplied into any kind of like abnormal structures also. So people have encountered even malignancies also, like injected into the disc, and people had, especially initial days of this regenerative therapy, someone developed 3 tumors from the mesenchymal cells, foregut, midgut, hindgut in the disc. So a lot of things we have to understand, but things have moved a lot in the last 10 years. And with a lot of restrictions, FDA allows certain things, but again, each country has its own protocol. What I'm discussing today, some of them are from the guidelines published last year, 2019, from the ASIP the society. If you just look at the lumbar disc injection, based on the available evidence regarding the use of PRP, that's platelet-rich plasma, that includes one high-quality RCT, multiple moderate quality observation studies, a single-arm meta-analysis, and evidence from systematic review. The qualitative evidence has been assessed as level 3 on a scale of 1 to 5. So it's somewhere mid-segment. If the other side it helps you, great, or say you can discard it and work. But of course, this is following a qualitative modified approach to the grading of evidence based on best evidence, because there's only one RCT, and very difficult to do RCTs in pain medicine. I think most of clinicians, they know about it, because the group of patients whom you select for all these things, they have to give consent. You should exhaust all the routine therapies, which are all the current indications of these kind of things as per the evidence. So these things come almost not at the beginning, but almost at the end of the whatever the cycle we have. So with this, we have to understand. Second thing is, how about, if not the PRP, how about injecting the mesenchymal stem cells? Based on the available evidence regarding the use of medicinal signaling, or mesenchymal stem cells with a high quality RCT, multiple moderate quality observed studies, a single arm meta-analysis, and 2 systematic reviews. The quality evidence again has been level 3, that's mid segment. Either they are saying level 1 or level 5. They're not accepting or discussing level 3 midway. Again, I'm telling you all these things you can try out after trying it out. The routine things, what you would have done. We'll come to about that when we conclude with all these things. What are the take-home message? What is summary? What exactly the message from all these guidelines which are coming with respect to the regenerative therapy? See, it's not so easy to conduct regenerative therapy procedures and also because a lot of legal problems could be there and a lot of financial implications out there. We have to be clear about why we are doing and what we are doing and how we are doing. Coming to lumbar epidural injections, based on one high-quality RCT, multiple relevant moderate quality observed studies, and a single arm meta-analysis, the qualitative evidence has been assessed level 4. It's or like scale of 1 to 5, level 4. So it's just understand it's not mid segment, it's in the lower segment. This was using a qualitative modified approach to the grading of evidence based on best evidence analysis. So disc injections with respect to PRP and mesenchymal level 3, but lumbar epidural they're saying level 4. Lumbar facet joint injections again based on one high quality RCT and 2 moderate quality observed studies. The qualitative evidence for facet joint injection with PRP as again level 4. So we are very clear of certain things like when they come to disc with the PRP and mesenchymal they're giving level 3, but with the epidural and facet they're giving level 4. So this we have to have clear. I just picked up certain things because it's only time is for 15 minutes. We can't discuss everything, and it's the end of the day. I don't want to tax people more than what we can discuss. Coming to the sacral leg joint injections for the whatever the variant region things, based on one high quality RCT, one moderate quality observed study, and one low quality case report. Again, the evidence is around level 4. So again, I'm taking disc. They're saying level 3 for PRP and mesenchymal, but epidural injections, facet joint, SL joint, they're giving it as level 4. So we should be cautious about these things. So this is fine about what should I say about the what are the like axillary pain with the degeneration with respect to the small joints or disc and other things. What about the knee joints? The commonest thing, osteoarthritis is quite common in especially in the Asian continent. This was published from in 2020 this year from European Journal of Orthopedic and Surgical Traumatology. This was a systematic review of Medline, Ambas, Scopus, and Google Scholar was performed on the English general literature, all level 1 and 2 studies with a near 6 months follow-up. Again, I repeat, osteoarthritis, it's long-term thing, 6 months follow-up for patients with knee arts from 2010 to 2019 was included. 6 months follow-up is what you can look. So this is where I would like all the probably the delegates and faculty to understand certain results you have to observe and probably you can practice as per your clinical practice model what you do in your own country or your own hospital. The results of this review and meta-analysis suggested that the PRP is superior to hyaluronic acid for symptomatic knee pain at 6 and 12 months. 6 months, 12 months. The autologous platelet-rich condition plasma appears to be clearly superior over hyaluronic acid for pain at both 6 and 12 months. So there were no advantages of PRP over acid for clinical outcomes at both 6 and 12 months. I repeat again, there were no advantages of PRP over hyaluronic acid for clinical outcomes at both 6 and 12 months. So question look at the amount of sterility what you'll have to declare of PRP and also hyaluronic acid. The level of evidence is so basically you can expect relief up to 6 to 12 months. But again, I'm not sure I have to go through all these things about the grading of the knee joint. Was most often they pick up for studies around stage 2 kind of osteoarthritis, which is it's pretty difficult. Stage 2A to 2B kind of thing, but we have to understand what kind of groups they selected. You have to take a look. So level of evidence, they say level 2, systematic viewer analysis. But again, I'm telling I request the delegate faculty to use their judicial clarity and thinking before you embark on certain things, before you offer to the patient. Of course, there are other things also in the body, especially acute muscle injuries. I'm talking sports injuries. You might have probably maybe a tennis elbow or a golfer's elbow, or could be some tendinitis or something. So what they say is PRP does not seem to be superior to usual care. Please again I repeat, acute muscle injuries, PRP does not seem to be superior to usual care. These findings are based on very low quality evidence. Because whatever you have to do, you have to understand, the treatment of tendon ligament injuries, there is little evidence to favor PRP compared to controls. Most of the observed difference was small and even statistically significant are unlikely to be of clinical significance. So that's what you understand. You make the person spend so much on that one, maybe insurance and maybe personal expenditure. But does it really convert into a good clinical outcome for the patient? So moreover, the level of certainty of the evidence was low to very low. Overall, there is currently insufficient evidence to support the use of PAP for treating the injuries. So far, what we have discussed, what we understand is for the disc, PRP, and the missing sense, again, it's debatable about level 3, and definitely for facet joint, SI joint, and epidural, it's level 4, and the knee joint, they say 6 months to 12 months relief, and of course, the acute muscle injury, this evidence is not enough. This was from, again, got published in 2019 from the blood transfusion journal. So to conclude, I would like to say the regenerative therapy should be provided to patients following a diagnostic evidence of a need for biologic therapy. Again, I repeat, please understand, if you establish a need for the biologic therapy, you should exhaust the current conventional proven therapies. We have to discuss with the patients and, of course, telling them his needs and expectations. After proper educating the patient on the use and administration of biologics and in full light of patient medical history, the therapy may be provided independently or in conjunction with other modalities of treatment, including structured exercise program, physical therapy, behavior therapy. So don't think that by just injecting the biologics you can get away. No, it's not. It has to structure along with exercise program, physical therapy, behavioral therapy, along with that appropriate conventional medical therapy as necessary. Appropriate precautions should be taken into consideration and followed prior to performing the biologic therapy. So basically, there is still a word of caution with respect to select the proper patient these things, and patient should know it may help or it may not help, and we are still in the probably the learning phase. It will take some time for us to really to say that this really works and we can offer it as a first-line therapy. So it takes some time for, I think. With this, my thoughts, what I understood about regenerative therapy, I'm sharing with you. Thank you so much, and thank you one and all. Thanks a lot.
Thank you, sir, for your nice and excellent presentation, because regenerative therapy, PRP, and stem cell therapy is very much
Milton, loud again.
very much UG opportunity is our daily to daily practice. Now, we are very much enlightened by your excellent presentation by the all faculties from the different side of the world. And now I request to our respected chairs, Dr. Respected chairs, Dr. Rijigo Diaz, for your valuable comments regarding these sessions. Sir, can
Hello,
you?
yes. Can you hear me?
Yes, sir.
Okay, perfect. I'd like to thank again Dr. Kausar Sardar and the Bangladesh Society of Anesthesiologists. I enjoyed very much the presentations, and I just like to finish with a few things regarding each of them. Dr. Shiv Pratap Singh Rana from Ultrasound Guided Interventions. It was amazing to see how ultrasound guided procedures have gained so much space in pain. Nevertheless, it's always a concern, the anatomic variations in this patients, right? So I pretty much like to see more publications regarding this type of interventions, and it's an amazing job what you're doing. Dr. Amitabh Gulati with the advances in legal publication. I think in cancer pain related or cancer related pain, this is a gold standard for a lot of patients, and pretty much nothing has changed majorly since the 2013 publication from the which were published in Pain Practice. Being of course, morphine the gold standard for our treatments. To Dr. Benson again, and for Dr. Fickleston as well, and all the presenters, it was an honor to be here. I most of them I have them here in one of my books. They're all very well known around the world, and regarding safety and interventional pain procedures, of course, this is a major thing we've been struggling with different medications that published to have a lot of problems, especially steroids or particulated steroids. And I just like to say one thing regarding safety, and is don't forget about X-ray safety, because we're always concerned about other things, but we're always exposed to radiation as well as our patients. To Dr. Harvey Filgis, it was an excellent presentation. I think, at least here in my country, we struggle a lot with how important it is to have proper and adjust settings for our type of work. It is very important to document everything, as he said, and especially take into concern to have a good setting and certified establishments if you are capable of having that. In my case, we have the Joint Commission in our hospital, and they come every 5 years to see if things are working properly. To Dr. Juarez, he wrote me a text a few seconds ago. He's a good friend of mine, and he excused because he had to leave. But he mentioned to tell all of the audience that he had in the past he's had two questions always. And what is the main contraindication for this femoroplasty? And it is fracture. And the other question that comes a lot for this is how much milliliters can you put in the femoral head? And he stated that it varies a lot. It's between 4 and 9 milliliters for males and 2.5 to 7 in females. Nevertheless, in cadaveric studies, they've shown to put up to 40 milliliters. Regarding the regenerative therapies, I must say I don't know much about them. I've been reading a lot. I'm still to check results within patients I receive. I've done Prolo. I do hyaluronic acid. I've not started to do PRP or stem cells. And what I do think is that we should start doing more guidelines and start working in the same path, because there's a lot of different kinds of injections we're able to put, and there's a lot of people doing different things. Again, thank you very much for this opportunity. I'm very happy to collaborate with the Bangladesh Society of Anesthesiologists, and thank you very much, Dr. Kausar Sardar. We both think it's very important to be certified in this, and especially having the FIP and SIPS certifications. Thank you again.
Thank you, Dr. Rodrigo, for your nice and excellent talk. I think everyone enjoyed these sessions from the different area, from home and abroad. And it is very excellent e-conference in COVID situation. Now I request to our another chairperson, Professor AKM Shamsul Alam sir, for your valuable comment. And I request to sir for conclude these sessions. Sir, can you hear me?
Yeah, I am hearing you. Am I audible, Milton?
Yes, sir. Yes, sir. Excellent.
Okay. Thank you, Milton. Yes, sir. Actually, this was an excellent session. There were 6 speakers from different parts of the world, 3 from USA, 2 from India, and 1 from Mexico. And we all learned a lot from these sessions, and all the speakers were excellent in their presentation. And we, especially the young physicians who are interested to do their career in pain medicine, have learned a lot. And from myself, I want to thank the organizing committee of BSA, who has arranged such an excellent e-conference in this COVID period and giving me the opportunity to chair such an excellent session. Thank you. That's all from me. Thank you, everybody.
Thank you, sir, for your valuable opinion. This is the last but not least. I actually we all young pain physician or who are working in pain in Bangladesh, our mentor, our iconic pain specialist, and one and only FIPP pain specialist in Bangladesh, who is Professor Kausar Sardar Sir, General Secretary, Bangladesh Society of Anesthesia. I request to Sir for say something and conclude our second day. Sir.
Thank you. Thank you very much, Milton, for nice conduction. I must mention our deep sense of appreciation, gratitude, and honor to all speakers. We are very grateful to all of you for sparing your time from your very busy schedule. Bangladesh Society of Anesthesiologists is grateful to all of you. We are delighted for your gracious presence here. It is very true. Within 15 or 20 minutes is very tiny time to talk on the topic on which you have talked. But what I feel, it was adequately concise, clear, and very sharp. And again, most importantly, very timely landed, every speaker. All participants have heard enough from you. What you have shared, it was amazing and unforgettable. And finally, my apology to all of you for 1.5 hours downing the session happened mostly for the early part of the session. Thanks again to make extended time for us. I don't want to miss the chance to ask one question to Professor Honorio Benjon, sir. Are you here?
I'm here.
Okay, nice. As it is very related to your presentation, it is on current issue actually regarding post-COVID patients, those who have raised D-dimer level, and it continue long time after RT-PCR negative event. And even patients are physically very fit, D-dimer is still a little bit higher. What is the cutoff value of D-dimer level for post-COVID physically fit patient to perform safely epidural or transforaminal injection or even simple spinal anesthesia? Though the evidence may be almost nil as the disease is very new, just give your opinion from your background knowledge. Please, sir. Cutoff value of D-dimer level for post-COVID patient.
What's your question again, specifically?
Specific is the what is the cutoff value for the D-dimer level for the post-COVID patient, those who are going for the any interventions or go for regional anesthesia, D-dimer level?
Are you talking about the D-dimer level?
Yeah, safe D-dimer level.
There's not a lot of studies that look into the safe levels of D-dimer. The problem with the anticoagulation guidelines is there has been no studies, prospective studies, observational studies, randomized controlled studies, very few in regional and almost none in pain medicine. So we base our recommendations on the half-life of the anticoagulant drug. With regards to the specific blood coagulation test, then we recommend that it has to normalize or be within normal levels, whatever the level is in your hospital, before you can do neuraxial injection, spinal epidural. Now, for regional nerve block, there's a little bit more leeway, especially in the superficial injections versus the deep plexus injections. Those that are deep, those that you cannot put pressure on, celiac plexus block and the whole thing. So I think I can answer your question on 2 points. The D-dimer level or any coagulation study has to be normal before spinal epidural, because the consequences are so much greater. For regional anesthesia, I think that you can kind of fudge a little bit and accept a slightly prolonged clotting study, slightly abnormal D-dimer level, as long as it's a superficial injection and you can put pressure on it. We are doing a retrospective study on several hundred patients that we did here at Northwestern in patients who are on anticoagulants and slightly abnormal clotting test. And we did not see any problem, but these are the femoral nerve blocks, sciatic nerve blocks. So for neuraxial spinal epidural, the clotting test, D-dimer, whatever test should be normal. For regional anesthesia, the deep and plexus blocks, visceral, celiac plexus, superficial, superior hypogastric plexus is normal. But for the superficial nerve blocks, I think you can do them in patients with slightly abnormal clotting tests. I hope I answer your question.
Okay, thank you very much. We are saying here, again, we are going to our WFSA past president, Dr. Janica Malin Olsen. I'm seeing here, he's here. Are you hearing us, madam? You are joined state.
Janica is there.
Okay. I think she's apart from the computer thing. Okay, thanks a lot, all moderators, for nice moderation in all sessions of today. Almost all moderators of today are young pain stars in Bangladesh, and they have been awarded with Young Pain Physicians Award yesterday, and they're doing very good job. And again, thanks a lot all speakers of today for sharing your knowledge and experience. Thanks a lot all chair of the session. Thanks a lot all attendee, participants, and those who are watching on live TV telecast and Facebook online. Thanks a lot Novista Pharmaceuticals for technical support, RAS TV for live telecast, the whole conference, and obviously Squire and Opson in Pharmaceuticals for platinum sponsorship of this first international conference on PAIN 2020. See you again, all of you, tomorrow at 2 p.m. Bangladesh time with same link. Have a good night for east part of the world and have a good day for the west part of the world. Now I'm handovering the mic to my president of Bangladesh Society of Anesthesiologists, Professor Debobroto Boni. Yes, please, sir. Conclude the session.
Thank you, Kausar. I am very BSA, especially I am also an BSA, are very grateful to all the faculties of the today's. There is a 6 mega session, and I think this is the largest Zoom meeting, more than 7 hours, and it is, and I can thanks to our all participants who can join with us, and thanks all of the faculties, and also welcome tomorrow. We requested all of the young physician and others join timely and enjoy this mega scientific program. And this is thanks to the all, and good night, good evening, and good morning to all. Thank you.
Thank you.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.